Dr. Sanjay Gupte sir and the whole team of Dr. Gupte Hospital, Dr. Divakar sir who has come all the way from Bangalore today early morning. So welcome sir, welcome to IMA Pune. This is a great day because maybe many of you, at least 90% of the audience over here have been the students of Dr. Mrudula Phadke madam. And we all are so eager to listen to her. And thank you very much, Dr. Gupte sir, for arranging this oration by Dr. Mrudula Phadke madam. She was HOD when I was in BJ Medical, as well as she was Dean of BJ Medical College. So we all have Dr. Sanjay Patil is here, Dr. Bondwe sir is here, all BJites here, Mantri sir, everyone is raising hands that we all are her students. So it's a great day today. Today is 1st October, sir, and this is a special day for us as well because today the new team, Dr. Raju Varyani's presidency, we completed 6 months. So these last 6 months have been very active and very fruitful for IMA Pune. We have been doing a lot of academic activities. There are physical activities. All of these are witnessing that. At least twice a month, we are having physical CMEs. We are having webinars. And these CMEs are of different topics. There was cardiology, there was general surgery, coloproctology, oncology. Today it is genetics. So I feel that our team is very fortunate to get associated with other teams who come out with such different topics. And so all the members get benefited. So I'm very, very grateful that today's topic is on genetics. This is something new to learn. So I'm sure everyone is going to enjoy it. IMA Pune also organizes a lot of social activities. And if you all know, we have a great project going on as Aao Gaon Chale. And just yesterday, we had a great presentation to the national team. And I'm very happy that Dr. Gupte sir is going to get associated with that project as well. He has been associated with us even for the sports activities. Recently, in the month of May 26, 27, 28, we had cricket tournaments. And he was the first one to come forward and to sponsor that event. And it was a great success. So thank you very much for all your associations with IMA Pune. We are really, really grateful to you. Let's have something. Let's just go through a few slides about IMA Pune, what activities we are doing. It doesn't run. So as you all know, booking or registration for CME is not physical, it is online. It's very easy. You have to register yourself online and fill the Google form. No need of asking us whether we are registered. Once you fill the Google form and it gets submitted, you are registered. So it's very easy. This is one important scheme. It is IMA Maharashtra state scheme, social security, but the office is in IMA Pune premises and our team from IMA Pune runs this scheme, and I request everyone to become the members of this. I take this opportunity to welcome Dr. Asmita Gupte madam. Welcome madam. Let's all stand. Yes. Good morning, madam. Without taking much time, I just run through the slides. So last month we had this CME on coloproctology. Then on 15th August, we had this special Vyakhyan on Bharatiya Swatantrechi 75 Varsha by Avinash Halbe sir. Then there was CME on neurocritical care on 27th of August. well attended, well appreciated. There was a CME on oncology on 27th August, again a research-based CME. There was a special talk on the occasion of Organ Donation Month on 27th August by Dr. Kapil Zirpe on myths and facts about organ donation. As I mentioned earlier, we have adopted a village called Kadve near Velle, and we go every month, either 2 times or even at least once to Kadve for health checkup camp. So on 20th August, we had a cancer screening camp over there, and we donated some plastic head covers to these villagers. On 3rd of September, this was a program by IMA Pune Art Circle, where I'm the secretary. We had Ek Sham Shamji Ke Naam, where our own member, Dr. Sham Damle sir, presented beautiful Hindi Marathi songs based on nature's beauty. So it was an audio-visual program. Then we had a fantastic state-level conference, Hospicon 2023. In a pre-conference workshop, it was meant for nursing staff and admin staff, and we gave some live demonstration to them, including the fire safety and the CPR training. So they were the faculty for the pre-conference workshop. You can see Dr. Sarada sir, Navarange sir, Sanjay Patil sir, myself. Then we had Hospicon 2023 on 10th of September, which was inaugurated. The exhibition was by Dr. Ravindra Kute, who is the IMA state president. We had the Hospicon souvenir released on that day. And if you all have received IMA Plus physical copy, it is the Hospicon souvenir where you will find all important articles related to hospital management. So they were all the faculty. Now I'm coming to the upcoming IMA CMEs. Of course, this is today's. Then on 15th October, we are having CME on cardiology and diabetology. There will be IMA Maharashtra state elections on 15th of October, and I request all of you must come over here physically to give your votes. This is from 8 a.m. to 5 p.m. Along with that, we have organized CME. So IMA does all the programs, but there is always academics attached to it. And then on 22nd of October, which I am telling you all the while, we have the Marathi Sahitya Sammelan. This is Rajyastariya Doctoranचं Marathi Sahitya Sammelan. So I request all of you to get registered for that. On this occasion, even on 21st, that is a day prior, we are trying to keep one beautiful program. So I'll be in touch with you and communicate with you about the details of Shabda Sharada 2023 Sahitya Sammelan and the pre-Sahitya Sammelan program. On 3rd of December, our annual conference, pre-conference workshop will be there of Multicon. And 9th and 10th of December, we are having IMA Pune's annual conference, Multicon. These are some awards that we received. Recently, IMA Pune received the Membership Drive Award from IMA Maharashtra State. And congratulations to our team of Dr. Virendra Ostwal and Dr. Sumit Shah, who did a lot of work to increase the membership. This is our IMA Plus. As every time I request everyone, this IMA Plus is our own magazine. Please do write for it. Please do send your articles, your poetry, your experiences with patients, and we are there to publish it in IMA Plus. New membership, it is very easy to join. Single membership is 18,526 and couple 27,790. I request everyone to join. So thank you very much, and may I now request our President, Dr. Raju Varyani, sir, to come and give his opening address. Thank you.
Thank you, Dr. Gitanjali Madam. A very good morning to all of you and welcome for this very important CME, which is like a future CME. Welcome. Now, monsoon has arrived. We are facing many diseases, vector-borne diseases. Whenever we advise the tests for dengue, like NS1 antigen is advised, IgG, IgM. And if that NS1 antigen is positive, please don't label that patient as dengue positive. NS1 antigen is not dengue positive. On many death certificates also, when the patient is NS1 antigen positive, it is written as dengue. NS1 is not dengue positive, it is dengue-like disease. Only if ELISA test is positive, you can label that person as dengue positive. If ELISA dengue is positive, then only it is dengue positive. Because unnecessarily there is load on civic bodies. If we label that patient as dengue positive, NS1 positive is only dengue-like disease, not dengue. On 15th October, we have IMA Maharashtra state elections. So all the IMA eligible members of IMA Pune are requested to do come and give your valuable vote for this important elections, which is for the post of president-elect of IMA Maharashtra state 2023-24. Do come on that voting day with your identity cards. As far as today's CME is concerned, genetics in clinical practice by Dr. Gupte Hospital. Along with this, we have a very important oration, Dr. Asmita Gupte, IMA Pune, Dr. Asmita Gupte Oration. For this, we have Professor Dr. Mrudula Phadke, Madam, who will be delivering the oration on genetics today and tomorrow. So we all are students, most of them are students of Madam. So Madam is known to all. So we will have excellent oration by Madam in the afternoon time. So also we are thankful to Dr. Gupte sir and Dr. Asmita Gupte Foundation and Greenarray Labs. So this research work is going on by Dr. Gupte sir since long, and genetics is the future of medicine. Which whether morning exercise is useful to you or evening exercise is useful to you will be determined by your genes. Genes will play a very important role in diagnosis and management of diseases. Genes are very important in oncology management. So the future of medical practice is genes. So this is very important topic for the future. Thank you very much.
I take this opportunity to welcome Dr. Mrudula Phadke, Madam. She has joined online. So may I request our President, Dr. Raju Varyani, sir, to welcome her with a floral bouquet.
Welcome, Madam. Welcome, Madam. Welcome.
Dr. Phadke, Madam. She's muted, yeah. Dr. Phadke, Madam, a very good morning from IMA Pune. I'm speaking from IMA Pune. Can you start your video, Madam? Everybody is eager to see you. It's okay. If Madam comes, then we'll again welcome her. Yeah. Okay. Thank you, sir. So without taking much time, we are going to start the session now. And to chair the... You want to say?
Today, Dr. Diwakar has joined us. He is in the auditorium. He is former Karnataka Medical Council President and presently is Vice President of Karnataka Hospital Association. Welcome, sir. Yes.
So we'll start the first session now. To chair the first session, may I request Dr. Meenakshi Deshpande and Dr. Vaishali Kode Naik to come onto the dais, please. Dr. Meenakshi Deshpande is the immediate past president of IMA Pune. Both of them are gynecologists, and Dr. Naik Madam is HOD at MIMER. So over to you. I've kept the programming details and the CVs.
Good morning to all of you on a rainy Sunday. So I'm very glad to see such a big audience today on a Sunday morning. And this all credits goes to Dr. Gupte sir and Asmita Gupte madam, who are there in the audience and who has taken a lead to formulate this oration every year for IMA Pune since last year. And a huge applause for them for giving this oration to IMA Pune. Thank you, sir, for such a great event which will be conducted every year on some important topic, a focused conference, one-day conference with an CME and an oration. So now we go forward. We have our first speaker, Dr. Ananda Babrekar. He will be speaking on chromosomes and their clinical application. Cytogenetics. So I'll be introducing you. Dr. Ananda Babrekar is a PhD in zoology, awarded SPPU Pune. He's worked as a project assistant, junior research fellow on a research project by KVIC and ISRO UOP. He's won the VC Shah Best Poster Presentation Award at the 17th All India Cell Biology Conference and the International Symposium Pune for the poster presentation. He's selected for the mini school and workshop of multiple time scales in the dynamics of the nervous system at ICTP, Italy 2008. So we welcome you, sir, for a great talk and a good lecture topic which you have been allotted to you.
Yeah, thank you. Good morning, all. To start with that, cytogenetics and fish in clinical practice. So, what is cytogenetics? As everybody is little bit aware about the cytogenetics, that is nothing but the study of inheritance in relation to structure and function of chromosomes. Now, the question comes in mind: chromosomes. What are chromosomes? Chromosomes are nothing like they are thread-like structures made up of protein of a single molecule of DNA that serve to carry genomic information from cell to cell. So now we need to jump to the cell. Now everybody is aware about the cell, that is a basic structure of our body, and cell follows a particular cell cycle that having various phases, that is G1 phase as well as synthesis phase and G2 phase, and the mitosis is important phase, that is a cell division, which is cytogenetics has to look for this particular, or they are eager to wait this phase of cell cycle, and that is why we need to identify, or we need to arrange the cells in a metaphase so that we can see the chromosomes under the bright field microscope. And that is, these chromosomes are bundles of tightly coiled DNA located within the nucleus. Then these chromosomes are harvested in metaphase stage, and the banding is done, that is trypsin GIMSA banding is done, G-banded, and that observed under the microscope. Now coming part to the chromosomes, as human there are 46 chromosomes are present, 23 chromosomes which are contributed by the parents from father as well as from the mother, and these chromosomes basically, if you describe the structure of a chromosome can be having following parts like centromere, telomeres, short arm which is a P arm, long arm is a Q arm, and specific bands are present. Now depending upon the presence of a centromere, the chromosomes are described. Some of the chromosomes are metacentric chromosomes, some of the chromosomes are submetacentric chromosome, and some of the chromosomes are acrocentric chromosomes. Now chromosome pairs from 1 to 22 are known as the autosomes, or they called as the autosomes. However, X and Y are called as the sex chromosomes. Now in cytogenetics we need to have samples which required basically two categories. One category is that which sample is already having the spontaneously dividing cells like leukemic blood, bone marrow aspirates, and solid tumors, because they are already tuned to develop fast. So that is why you need not require stimulation. But there are some non-spontaneously dividing cells are there which are present in our peripheral blood, as well as amniotic fluid sample cells, chorionic villus sampling, as well as cells obtained from POC, that is products of conceptions, where we need to stimulate by adding the PHA, and that gives the undergo cell division. Because cytogenetics, or the whenever you need to harvest chromosomes, we need to identify the cell dividing cells, or we need to catch the, if we want to catch the bus, then we need to catch the metaphase, and that has to be observed in the dividing cells itself. harvesting chromosome is important step in the cytogenetics. Then culturing, for that basically there are two types of cultures we can have. One is the suspension cultures, where we can add peripheral blood in the media, bone marrow aspirates and that can be grown in the routine incubator. However, there are some suspension cultures which are present that grown in the CO2 incubator, like amniotic fluid cells or CVS cells. Now this one picture of metaphase where chromosomes can be observed under the bright field microscope. Now how we can identify those chromosomes can be identified. Basically, abnormality can be identified or bifurcated or divided, either structurally abnormality or you can have a numerical abnormality. So you can have the red arrow which shows the chromosome 21 is appeared thrice. However, a pair of chromosomes is present in a normal human being, so that there could be a numerical abnormality. Now there are, while reporting these cytogenetics or karyotyping studies, there are some guidelines which are given by the International Society for Chromosomal Nomenclature, that is ISCN guidelines, and that is why we have to identify, we have to count the 20 metaphase, and that has to be done by the two analysts, and that to by blindfolded, so that whether they can corroborate or they can identify, they can match their results, whether the person 1 or analyst 1 is identified an abnormality, either an analyst 2nd has also found some that particular abnormality. So every clone can be found to be as represented as a karyotype. Now numerical abnormalities as Down syndrome, that is a trisomy of 21, chromosome number 21 appeared. 3 chromosomes you can see there. Turner syndrome, that is 45X or XO conditions, and Klinefelter syndrome, that is XXY condition. Now there can be some of, as I told you earlier, there can be some structural rearrangements, that is translocation. For example, Philadelphia, that is translocation between chromosome number 9 to 22, generally seen in the hematological disorders. Robertsonian translocations, that is basically occurred in the acrocentric chromosome number 13 and 21, and there could be some deletions, duplications, as well as the inversions in the structure of chromosomes. Now, while reporting, ISCN says that criteria, it has set some criteria for reporting abnormalities. More than 2 metaphases are showing structural abnormality, and more than 3 cells showing the numerical abnormalities. So that can be reported as the abnormal. So this is a particular typical form of a type of a report, where you can see the earlier metaphase which I showed you, that showed 3 chromosomes of 21. So there could be a frank Down syndrome that all 20 metaphases showed, or all the cells are showing chromosome number 21 appeared in a 3 number. So similarly, there could be a mosaicism can be observed. So here you can see the report says that it is a mosaic Down syndrome. Some 10 metaphases had showed chromosome 21 appeared to be triply in 3 number, as well as some 10 metaphases showed a normal appearance. So it can be the mosaicism can be observed in case of these constitutional abnormalities. As this is a typical karyotype, where you can see the chromosome number in the last row, that 21 chromosome you can read with red arrow, that is shown that chromosome 21, this is a typical Down syndrome karyotype. Now this cytogenetics, as is basically very labor intensive, then it very tedious, because you have to look under the microscope, you have to count the metaphases, you have to count the number of chromosomes, whether the chromosomes are there, you have to identify where all the bands are this present or not. So that is why it becomes very time consuming, and there is no automation in as regards with this karyotyping, and so there is no interference of AI nowadays, and that is why it takes longer turnaround time for the reports, generally for 12 to 15 days, or amniotic fluid takes, because growing the cell is not within our hand. We have to provide nutritious material to the cells to grow them in an incubator. Some of the cells may grow fast, some of the cells will take some more time. You can say that those cells are sluggish, so that they will take some more time to grow. So depending upon the growth, we need to identify, we need to harvest the chromosomes. Now this is a gold standard, or this is the routine cytogenetics part. Now there is a molecular cytogenetics, that is FISH, that is fluorescence in situ hybridization. Now this is very specific targeted part or targeted technique where we need to know about particular site or loci which is present, or we identify or we question. There has to be some query with along with the symptoms, so that what we need to look for that. So that is why FISH technique is very useful. Why it is very useful? Because it is very user friendly. And one important part of the FISH technique is that you don't require the viable cells to run this FISH test. As well as this is very rapid results. Within 2 days, 2 and 3 days, you can identify, you can immediately get the results. And another part is that formalin fixed tissues also can be used or for these FISH studies, because it's very specific. DNA probes are available in the market, approved probes that specific binds to the specific loci, and that will, but we need to know which loci we are interested to look for that. So unless and until we do have a hint of a particular, it will be it won't be possible. Now the probes which are available, postnatal probes are also available, prenatal probes are also available. In prenatal, we have a combo, particularly that trisomy 20, 21, 13, 18, as well as for to identify the sex chrome aneuploidies, as well as these constitutional abnormalities, that is microdeletion syndromes, as well as the Down syndromes. And for cancer acquired abnormalities, that is hematological malignancies, solid tumors, where we can use the, for example, the probe for BCR-ABL, that is translocation between chromosome number 9 and 22, the 922 translocation. So which are the diagnostic applications or prognostic application of cytogenetics? That can be into the hematology as well as in oncology. Then pediatric people can also go for that. Obviously the obstetric branch also will utilize this particular test, as well as the prenatal diagnosis, which is very, very important. So these are the scenarios where we can prescribe particular cytogenetic tests depending upon the morphology, depending upon the clinical features and suspected underlying genetic causes, and which test can be performed. For example, if a pediatrician has found that gross dysmorphism, then the chromosomal structure or chromosomal abnormalities may be there, either numerical or structural. So karyotyping cytogenetic test can be advised in that, and for that we need a peripheral blood in the heparin vacutainer. Dysmorphic features, if for example there is a developmental delay or obesity, obese baby, for example Prader-Willi syndrome, microdeletion syndrome, such Angelman George, where we can use the specific FISH probes to identify these microdeletions. Even in the same fashion or similarly, if there is an ambiguous genitalia to identify a sex of a baby, then we can run the FISH test, that is SRY FISH, so that immediately we can identify the sex of a baby. Because sometimes gynecologist as well as the pediatrician comes in the, oh, there is an ambiguous genitalia, how to identify, so this can be prescribed. Similarly, the primary amenorrhea is a major challenging part nowadays, so that in case of primary amenorrhea we can also go for the karyotyping test. Now in last scenario where we can go for the karyotyping test on the amniotic fluid, that is prenatal diagnosis, or on CVS samples. If a pregnant woman shows double marker, triple marker positive, then NIPS nowadays is advised, and even NIPS is showing the high risk result, then we can go for this chromosomal abnormality, chromosomal studies, karyotyping or FISH on amniotic fluid sample as well as the CVS sample. In case of advanced maternal age, that also we can have this particular test, which is defined above 35 years old lady. So in nutshell, essentially these tests are very extremely informative tests which helps in the diagnosis. It has some particular independent parameter for a prognosis and helping clinicians for the better patient management. So at Greenarray, we do this particular test, that is cytogenetics as well as subtelomeric FISH test, and to identify this ambiguous genitalia, primary amenorrhea, cytogenetics and FISH SRY gene test. And at the end, I would like to, when the farmer is becomes happy when he can have a yield of crop in a good quantity, a cytogeneticist can smile on his face. You can see the smile on his face when he can harvest, he or she can harvest good chromosomes from the blood. That is important. And with this, I would like to thank IMA House, IMA team, as well as the Gupte Hospital team, Dr. Sanjay Gupte sir, Asmita madam, and our Greenarray CEO Nitin Gupte sir, our director sir, Dr. Sarjan Saha, and entire team of our Greenarray for giving an opportunity. Thank you very much.
Thank you so much. Excellent overview of the chromosomal clinical applications. And being a fetal medicine person, I can very well relate to it. And it is really very important clinically, prenatally, as well as when there are ambiguous genitalia. And it's an emergency for obstetricians that what exactly we have to counsel the patient's relatives that what baby is born.
Baby is born, because they have an anxiety to know whether baby
that
boy
is the first thing they want to know that what exactly
I can understand,
it's a male or female. And that time it really comes handy, and the situation become tricky, and you help us in such situations. Thank you so much for a very lucid presentation.
Thank you.
We take questions.
Is biochemical trace or some kind of microscope?
Microscope is required because we need to get a blood in a heparin container. We have to grow them in a cell culture media in an incubator, because we have to keep an eye on the dividing cells. Unless and until there is a division of cells, we won't be able to harvest those cells, because we have to catch the chromosomes in the metaphase. If you go for the cell division, it has particular phases: prophase, metaphase, anaphase, and telophase, and cytokinesis. Then chromosomes are arranged, and that can be observed under bright field microscope in the metaphase stage. For that, we need to add colchicine, that which arrange the metaphases, and that can be harvested. No. Our bright field normal, where we have to look through our eyes, basically. Cost of is this test because it's laborious, so it starts from 4K to 7K, around that kind of thing. Fish is quite expensive because these probes are very expensive, because we have to go for the approved probes, so that is why. Depend upon the syndrome.
I think that is exactly why Dr. Gupte sir and myself thought about this, and we started an oration, because such topics need to be discussed amongst all medical professionals, because we can have pregnant patients in our relatives, in our friends, and all of us need to know that this genetic testing is utmost possible from 8 weeks of pregnancy onwards, and we need to test nearly each and every pregnant female for such tests, so that we have lesser number of abnormal children coming out. So thank you so much.
Thank you, Dr. Babrekar. Please come over here. May I request our President, Dr. Raju Varyani sir, and Dr. Sanjay Gupte sir to join for felicitation of Dr. Babrekar. I request the chairpersons to join for this.
Thank you.
As we have all gathered here for a very futuristic CME, and we really congratulate IMA and Gupte sir for this initiative. But at the same time, this CME is going to take us to a very basic things also, like how genetic and even our nutrition, our day-to-day diet is related. And our next speaker is going to talk about it. She's going to tell us how to get the maximum benefit of our diet and exercise, which is guided by the genes, and for which we invite Mrs. Saili Dindorkar to give us a talk on this. She has over 17 years of experience as a health professional practicing clinical nutrition and promoting importance of nutrition. She has experience on basically she gives consultation on lifestyle disorders, specialized consultation for cancer patients, diabetic, special care patients, for weight gain, weight loss, pre and postnatal, even PCOD patient, which will be very handy for all obstetricians. She does nutritional counseling and consultation, as well as she's interested in various clinical research and trials. And she's been conducting lectures on best practices in nutrition and dietetics. The dais is yours.
Thank you so much for this introduction. Good morning, everyone. And we'll be starting, and I'll be talking about nutrigenomics and Greenarray. Thank you so much for inviting me here as a speaker. Yeah, so what is gene? So gene is a segment of DNA, and it helps us to give the instruction. It helps to give the instruction to our body, to our hormones, and it is basically a coding which will help to pass on the information. Here, then SNP, single nucleotide polymorphism, or it is called as SNPs in genetic language. You call it as SNPs as well. So what this SNP has, there is a helix kind of structure in your gene, and it has thymine, cytosine, guanine, and adenine, these 4 protein strains, so nucleotides in that. And when it comes to SNP, a single letter change can change your DNA complete, building block of your DNA. So I'll be talking more with the examples which will help you to understand that how this DNA structure changes and how it directly affects your health. So what is nutrigenomics? Nutrigenomics is the interaction between your genes and your food, your nutrition, and how it reacts when specific amount of food is consumed in specific particular time, when, what, and how. These all answers you get from nutrigenomics. And there are many different kind of studies involved in genetical factor. Your environmental factor also involved in this nutrigenomics. So I have an example. Do you all know this? Can you see all this? Coke, right? This is 0-calorie Coke. So, do you all know phenylalanine, right? It's a protein. So excess of phenylalanine, what happens when it is there in your body? It is toxic to your brain, and ultimately we get a condition like PKU. And when this kind of thing is consumed for larger amount of time, and it is just not this Coke, the fast food, 0 calories, sugar-free products, when you see in the market, or frozen food, when you see in the market, that time you are ultimately consuming something which is going to change the DNA of one's, DNA of the individual. So it is affecting that deep to you. And ultimately, since 1960, the studies are going on, which are showing that infants are having conditions like PKU when they are born. Got it? So phenylalanine, there is an enzyme which is blocked, which helps in converting it into the utilized protein. Okay, the way we said that diet, nutrient, and different kind of metabolism, so carbohydrate metabolism, fat metabolism, protein metabolism, your gene expression, cellular functions, these all are giving signal to your gene. So ultimately nutrient and your gene is interacting. Again, one of the example about ApoE APOE2, APOE3, APOE4 gene. So we all know omega-3 fatty acid helps us to reduce the triglyceride level and LDL levels. So the consumption or the prescription of cod liver oil, fish oil, omega-3 fatty acid, different are Indian products like Zavas, flaxseeds, which are being given or prescribed by us and even doctors to many of the patients. But when it comes to APOE4 gene, which is the rarest gene, and when somebody is having APOE4 genes, you will see the drastic change in that patient's triglyceride levels. So it drops drastically, comparatively APOE2 and 3 gene. And one of the best example is about folate. September month was celebrated as a Poshan Maha. So for IDA, your iron deficiency anemia. And folate is one of the important nutrient for DNA production. And deficiency of it can give put the person to the higher risk of various disease conditions like even cancer. Folate plays an important role in DNA synthesis and even for reproduction and even for the fetal growth. So when MTFR gene is there, which helps to convert the enzyme, when there is a deficiency of MTFR gene, the genotype A, B, C, you will see the result. Genotype A person is having the normal level of enzyme where iron is being converted, hemoglobin levels are normal, whereas B has the lower one and C has the lowest enzyme level. And here we'll see more patients of iron deficiency anemia, and they are suffering from chronic disorders like cancer patients. Okay, as we mentioned, the protein nucleotide in DNA strands, SNPs. So when lactose intolerance is the condition where milk and milk product, they are not tolerated by the patient, by an individual. So when you have CC protein nucleotide in your gene, here the patient will show the symptoms of lactose intolerance. They won't be able to digest and tolerate the milk protein, and there is an absence of enzyme which helps in enzyme lactase, which is not converting that into the sugar. So lactose, CT and TT genes, those who are having CT and TT genes, they can tolerate milk very well, milk and milk products. Okay. Obesity, so according to the statistics, currently India has 135 millions of obese people, and the prevalence of CVD is around 54.5 million people. Type 2 diabetes. So when we say nutrigenomics and disease conditions, and when we talk about obesity, obesity is lifestyle disorder. But then it has been guided with the help of certain genes where fat metabolism takes a major role. It plays a major role in guiding and your fat deposition and utilization of your fat. Okay, so when it comes to diabetes, similarly, you have when you have a lifestyle disorder, you will see the inflammation, you will see the metabolic stress, you will see the oxidative stress, and ultimately, many genes are responsible for insulin resistance as well as glucose intolerance and metabolic syndrome, and ultimately result into type 2 diabetes. Now, what and how nutrigenomics is going to help us to understand the disease condition, to understand and prescribe the particular diet, and understand the lifestyle of the person and what all changes are required to do. So personalized nutrition, where you will get you will see the report further. We have some reports we have given in the slides that you will understand what kind of genotype this person is having. You will understand that how that particular genes is impacting that person's lifestyle, and ultimately it is going to give you that particular lifestyle disorders. It could be a diabetes, it could be PCOS, it could be obesity, and so the report will help us to guide and give us the recommendation of proper lifestyle, proper diet. And next is about disease prevention. Yes, it is. Nutrigenomics gives us a preventive measure as well as curative measures. So for particular disease conditions, we have panels which helps us to understand the disease condition and what all nutrients can helpful to guide us for this kind of condition. As I gave you the example of ApoE 234 gene. Then athlete performance. Here, I have one more example to give you about one of the players. What's his name is Habana. Okay, Brian Habana. He's a rugby player, and he was a rugby player. He still plays, and they won the World Cup in 2019. Okay, so before his World Cup, he underwent with all genetical test. So here nutrigenomics was also one of the panel. He took all the panels of nutrigenomics, and before the game, he understood that what kind of gene he has, which is going to help him to give the good endurance, which is going to help him to pre and post exercise meals. There are pre and post exercise meals which are consumed, which helps us to pump the energy, and post performance meals as well. So accordingly, after knowing his reports, he went for the training. He decided his placing in the game, because rugby is a very high power game, and he decided his placing. He changed the placing, and similarly done with many players in his team, and finally they won the World Cup. So it helped him pre-training, post-training, and post-performance as well. So there were less injuries, and he was able to perform at his best. So this is about sports. We have many medical conditions as well. Okay, so Greenarray Nutrigenomics has comprehensive panel of diet panel, PCOS panel, weight management, fit genomics panel, and cardiac health panel. Now, what all things you get in diet panel? So what could be the potential to the best type of diet for you? Do you have gene that makes you more likely to have snacks in between? Do you have any vitamin deficiency? Is there any reason which can resist the eating of certain foods? Nausea, vomiting, all these things are also being covered. Uncovered the interaction between your cholesterol and diet. So cholesterol on diet, here we also get the guidance which oil, what oil, and when to eat. So there are multiple amount of oils available in the market, including cold press oil, different kind of cold press oils. So all these things, the recommendation and impact, which helps us to guide properly to our patients to make them understand how your diet and lifestyle should be. Okay, here we are going to talk a little bit about the fat metabolism. You all know that vitamin D is it is fat soluble vitamin, and fat metabolism. When it comes to fat metabolism, fat has there is a gene which helps to control your fat, and this fat and yeah, one sec. Yeah. So when it comes to that particular gene, and when that gene is absent, or there is some issue with that particular genes, the fat metabolism is hampered at that moment. And when this fat metabolism is hampered, what is the result? There is sleep apnea. You will see the patient is having inflammation, because that particular gene is going to make you understand your energy metabolism, your fat metabolism, and when to use what kind of nutrient. So which cycle is to be used. So proteins, energy, or fat, which you need to use for energy purpose. And when it is altered, you will see your metabolic cycles are being disturbed. So there are many traits in this panel, but I'm just talking about the fat metabolism because there are particular genes which affects the fat metabolism. These kind of sample reports you see. Can I enlarge this? Sorry. Okay, here you will understand the metabolic cycles and your genotype, what kind of impact it has on your body, and even it gives the proper recommendations which helps us to understand that what kind of lifestyle you should be having. All the reports are having good recommendations which helps us to understand what lifestyles you should be having, what kind of diet you should be having, when to exercise, and what all you need to exercise. PCOS, so this panel identifies the key genes that have an influence over your appetite, your fat storage, your fat metabolism, insulin resistance, oxidative stress, and snacking habits. Yes, it is seen in PCOS patients that they have different snacking habits, and there is no sensitivity for particular nutrient or hunger hormone as well. Okay, so how this hyperinsulinemia and different kind of lifestyle disorders again are going to affect your PCOS and how you get into the condition of PCOS. There is a particular gene here, IGFBP, which is also helps in metabolizing your fat cells, as I was mentioning about vitamin D and vitamin D and impaired glucose intolerance and fat metabolism. Here what happens when you see an obese person, he has a good amount of fat, adipose tissues. Fat is, vitamin D is soluble in fat, but then you still see the vitamin D deficiency in particular patient. Here with those particular genes, you are not able to utilize that fat for energy purpose, and then this vitamin D deficiency is seen, and ultimately inflammation, and there is hardly loss of fat seen in many of the patients. I have a patient here with the example I want to tell you. The patient tried many things like reducing the carbohydrate intake, even intermittent fasting, and even ketogenic diet he tried. So when it came to ketogenic diet, he understood that the fat is not being utilized for energy purpose. She was not able, she was bouncing back from particular weight, like she was 125 and she used to come back to 118 and she used to bounce back to 125 again. And here, that time we went through the test and we understood that there is a problem in all the metabolic cycles, and we need to address that first. And the recommendation helped us to treat the patient well. These are the reports. These kind of reports you get. Again, you understand the genotype, you understand the impact, and recommendations are given which helps us to treat the patient well. Weight management panel helps you to uncover the best diet that allows you to achieve your optimal metabolism, to lose weight, improve your overall health, learn about the eating behaviors. Yes, behavioral patterns are seen in different kind of weight management patients. So there are psychological factors are also responsible for this. To identify these kind of genes, you need to understand the weight loss trend, you need to understand the cholesterol levels, and even the benefits of the exercise. Yeah, so these are the traits of the panel what we are covering. This kind of report you get for the weight management patient. Then we have a fitness panel. The fitness panel, which identifies the key gene that has been scientifically shown effect of your body response to typical kind of exercise. Then it even helps us to understand the injury risk of the patient, and aerobic exercise, which exercise will help us, which will help to the particular player or patient or person to further understand the exercise diet pattern for his later life. So actin 3, this genes plays a major role in in their athlete performance. So here people must be knowing Andrew Steele player. So Andrew Steele, he's an Olympic athlete, and Greg Rutherford. So both of them, they are Olympic athletes. Both of them underwent with the genetical testing. So Andrew Steele underwent genetical testing after losing 4 times in Olympics. And when he understood that he is not able to make out, or he is not able to give optimum to his training, because he tried all kind of practices, the way the all other athletes are doing, all kind of trainings he underwent, still he was not able to go to the 40-45 second was his target. He was not able to achieve that target. And when he underwent with this test, he got the result that the actin 3 is not, the particular gene is not there in his body. That strain was missing, and that is why he was not able to perform at his best. Similarly, you must have heard about the circadian rhythm. So what is circadian rhythm? So circadian rhythm is basically you get the response of circadian rhythm with your physical, mental and psychological state of mind of 24 hours. Okay, so how it works and what all things are responsible. So genotype is one thing which is responsible for your circadian rhythm. Jet lag is one of the responsible factor, and then other is your mobile device light, which is responsible for circadian factor, and it changes your cycle. So ultimately, when it comes to, we can change the circadian rhythm with the help of lifestyle change for that person. So here you understand when is the best time to exercise, what is the best time to exercise after assessing the person, because assessment is very important in this circadian rhythm patients. So we will get the good results, and then we will understand that how this patient can get a good results after exercising at particular time, and what exercise that person should be doing, like aerobic exercise, yoga, what kind of training is required for that patient. Again, this is the this is the sample report we have. I wanted to circulate the sample reports. If we can get, we will circulate it in audience so that you will understand and you will be able to read the report, and you can see it in your hand that what all things you get in this report.
Last 1 minute, please.
Okay, so yes, I'll go a little fast. So ultimately, modifiable and non-modifiable factors for CVD. So here, non-modifiable factors we cannot change, but modifiable factors are all related to your lifestyle, and you need to make changes in these factors which will help us to reduce the risk of CVD. Caffeine, again, much discussed. Here, coffee is the main product, and these kind of products which has caffeine. So coffee has many other chemicals, like manganese is there, polyphenol is there, and caffeine is one of the major factor. So CYP A1, 1F and 1A gene, these are responsible. So when you have CYP A1F genes, that time, even if you are consuming coffee 4 times a day, it is being metabolized very fast, and it is other way around. So people who are having that particular gene, they are more prone to cardiovascular disorders, and in other hand, the other genes is it helps to protect your heart. These are the traits. Okay, this is the case study similar to to what I told you before. And about the trait also, we had VO2 max in fitness panel, I wanted to give an example of VO2 max. VO2 max is something which helps, which is related to your oxygen intake, and this oxygen which ultimately converted into energy in your cells, and this VO2 max is responsible, and it is a benchmark for many of the athletes and to the cardiac patients to understand the your heart capacity and the performance and how you deal with your lifestyle. This is the case study here. The patient, after understanding the profile, after understanding the patient's profile, we were able to treat well, and we were able to change the metabolic cycles, and even we were able to give the good amount of prescribed good exercises to the patient, so to get the patient to optimal weight and to see the change in number of the patient's report. Thank you so much. I was not able to go through it properly, but thank you so much.
Thank you, madam. That was a very exhaustive report on all the how dietetics affect our daily. I think well-being also, not only well-being, it will affect our future health also.
Yes.
So, and that is the most important factor, that today's diet and today's exercises patterns will affect our future life and future health.
Right.
That is the most important message for today. And I think one more message, take-home message, which we should give today, that preconception folic acid and vitamins and dieting is where diet therapies are very important to reduce the abnormalities in the growing fetus.
Yeah.
Because there are many unplanned pregnancies in the present era, and this concept of pre-pregnancy folic acid and vitamin supplementation is not still there amongst all the practitioners. We find it that gynecologists are giving it, but there are many other practitioners who need to know that 3 months of folic acid before conception is a very important aspect for prevention of fetal abnormalities. Thank you so much.
Even one part about the pregnancies, in 9 months we have different kind of diet. Every 3 months, every trimester, diet changes. And nowadays what we have observed, that there are different kind of people, the females ask to eat something fast food. They are more inclined towards fast food, and ultimately, as I shown you this about phenylalanine, so these kind of fast food, ultimately they are changing the DNA structure of that baby, so it affects a lot.
I think that was the main reason why last year, when I was the president of IMA Pune, I requested Gupte sir to start an oration in such a concept that we give some knowledge about how diet, genetics, and even preconception health matters a lot in development of the babies. And I thank Gupte sir and Asmita Gupte madam for listening to my accepting my request. Thank you so much, sir.
Yes, sir. Thank you, sir.
To ask a very practical thing, the PCOS panel, does it combine diet as well as the obesity, or
it combines all obesity factors ultimately, because that is one of the reason of insulin resistance, and so it combines all the traits.
maybe just order PCOS panel?
That's it. That's it. It is combined. It somewhere 10K, I think so. 10K above, right? So she will get back to you about that.
Madam, in sports competition, only few athletes doing genetic testing and their game should be illegal. It should be done for
everyone. Yes, it should be for everyone, because as I mentioned about VO2 max for the aerobic exercise, the people who are performing running kind of athletic activity or swimming, for them knowing VO2 max is very important, and that should be the benchmark. Some of them in India, we haven't, there are some players, they are doing the reports, but yet it is not for everyone. Cricket is most played and loved game in India, but we haven't seen any report of any of the cricketer yet. I've heard about the Kohli, but I don't know. Kohli, ho? They are available, nahi, sir. I would like to know more about it. Yeah, it is confidential. They are not out the way I gave you the example. They are not on screen.
So we are moving more towards individualization about everything, about your health, Like PCOS, we have same treatment for all, but it will change now as per the genes.
Yeah.
For weight management, for obesity, for everywhere, we have to individualize it after this. And thank you for showing us the report, because we were very much interested in knowing what kind of report. Like if you just tell us that the genetics, these genes are present and these are absent, but their implications and the
Yeah.
advice is very important. So thank you so much.
Thank you so much.
made the concept very clear to all the audience.
Thank you.
Thank you.
Thank you.
Thank you, Saili madam. May I request Dr. Raju Varyani sir, President IMA Pune, and Dr. Sanjay Gupte sir to come onto the dais to felicitate madam. I request the chairpersons to join for the felicitation. I also wish to thank the chairpersons, and for their felicitation, I request Varyani sir and Gupte sir to be. Shede Kaka, एक chair please add करा. For the next session, I take this opportunity to invite to chair the session Dr. Diwakar sir, Dr. Avinash Bhundwe sir, who is the past president of IMA Pune as well as IMA Maharashtra State, and also Dr. Arti Nimkar madam to join the dais, please. Dr. Nimkar madam is the past president of IMA Pune, and she is the senior vice president of IMA Maharashtra State and is a gynecologist. I again would like to welcome Dr. Mrudula Phadke madam, who has joined online. Madam is muted, I guess. Yes. Good morning, madam.
Good morning, everybody. On behalf of Bangalore, I thank Sanjay Gupte, Asmita Gupte, and Sajjan Shaw and team of Greenarray Labs for arranging this CME on genetics and clinical practice along with IMA Pune. So it is a good topic because genetics is involved in all the systems of the body, not only in the one part, like it is involved from the head to the toe, like that. It may be the related to the brain, like brain disorders or psychological disorders, or in the eyes. As an ophthalmologist, we come across number of cases of genetic disorders in the eye also. So today, we have with us Dr. Gayatri Raman, who will be telling us about the understanding how genetic screening helps in early cancer detection. So Dr. Gayatri Raman is MD OBGYN, and she's the FPI trained laparoscopist and FOXY certified course advanced in laparoscopy. She's a life member of FOXY training in basic ultrasound, co-author articles in Comprehensive Bulletin on Safe Motherhood and Medical Legal Journal. 91 she has finished MBBS, and 95 she has finished MD OBGYN. So I request Dr. Gayatri Raman to start the topic.
Thank you, dignitaries on the dais. Good morning, everyone. Dignitaries of the dais, colleagues and friends. Thank you, Team IMA, for giving me this opportunity to make a presentation on genetic screening for cancer. At the outset, I would like to make a disclaimer. I'm not a geneticist. I try to be the bridge. I'm a clinician, and I try to be a bridge between the geneticists and my patients. So please pardon me if I seem to demystify, simplify, or at times oversimplify my presentation. So what is the link between cancer and genetics? Cancer is a genetic disease caused by the changes in our genes that control the way cells grow and multiply. So during the course of cell division, if the body substitutes, adds, or subtracts information in the genetic material, variants or mutations results. Mutations in the genes which control the cell division and repair result in cancer. So what are the type of mutations? Largely, they are either germline mutations or somatic mutations. Germline mutations are those which are inherent in the body right from birth. So right from the germ cells. So they are present in all cells of the body. And somatic mutations take place after birth. So only some cells carry these mutations, and especially the ones who are likely to develop cancer. The mosaic mutations are somewhere in between. That is a newer insight, because these mutations occur in utero, but after the initial cell differentiation. So some cells might contain these mutant cells, mutant genes. So depending on the occurrence of mutation, you have a familial inheritance, which is at 10%, and the rest of it is acquired. The acquired is because of environmental factors, aging, and other lifestyle disorders. The journey from mutation to cancer decides what kinds of cancer one develops, whether it is a hereditary cancer because of inherited germline mutations, or is it a sporadic cancer because of somatic mutations. The familial mutation, again, familial cancers are a combination of both, the somatic plus the germline ones. And the cancer genes are largely classified into three groups: the tumor suppressor groups, the oncogenes, and the DNA repair genes. So what is the modus operandi? So the oncogenes are basically genes which control, or rather the proto-oncogenes are the genes which control normal cell differentiation, proliferation. And the tumor suppressant genes control the cell differentiation by apoptosis, or preventing cell proliferation of abnormal cells. And the DNA repair genes, as the name suggests, repair the damaged DNAs. So when there is a mutation in any of these genes, that is, when the proto-oncogenes get mutated or switched on, a mutation results, a malignancy results. A tumor suppressor gene, when it gets switched off, cancer can result. And likewise, DNA repair genes, when they are mutated, will result in a proliferation leading to cancer. So that is the role of proto-oncogenes and the anti-oncogenes, which is present in all cells of our body, in all of us. They are normal genes for normal cell growth and proliferation, but they have the potential to cause cancer if their expression is altered or if they are mutated. Also, there's a lot of overlap between the tumor suppressor genes and the DNA repair genes in tumor causation. So this list of inherited cancers, of which, of course, the breast and the ovarian cancer caused by BRCA gene mutation is possibly the most common and most famous one. Lynch syndrome causing colorectal cancers, the Leigh-Fromani syndrome because of the TP53 gene mutation, familial adenomatous polyposis, Peutz-Jeghers, and retinoblastoma. The main role in cancer causation of inherited cancers is because of oncogene or tumor suppressor gene, that is suppression of the tumor suppressor gene or activation of the oncogene. But it's not just BRCA which causes breast cancer. In fact, just around 10% of the breast cancers are caused by BRCA gene mutation. There's an endless list that we can see which have been also implicated in the causation of breast cancer. The induced cancer or the somatic cancers, the sporadic cancers, are caused by carcinogens, which are physical or chemical mutagens, alcohol, smoke, ultraviolet radiations, advanced age, obesity, and microbes, especially oncoviruses, and medicines like the proton pump inhibitor and some anti-malignant drugs themselves. Now, why does a mutant gene cause cancer in some and doesn't in some others is because of this two-hit theory. Because dominantly inherited predisposition to cancer entails a germline mutation, but it causes tumorigenesis only if there is a second somatic mutation. And likewise, in non-hereditary cancers, that is the sporadic type, the same two types are required, but both hits are somatic, that is acquired or environmental. So the point to note is that even if one has a genetic predilection, environmental factors play the second but decisive hit to cause cancer. So there is where the role of predictive gene testing is for cancer. This helps in estimating our chance of developing cancer in the lifetime, and then also helps in predicting further further cancer development, also the risk of passing it on to the next generation, and provides information to the healthcare provider to plan. So right now, genetic tests are available for some types of cancers like the breast, ovarian, colon, thyroid, prostate, pancreatic, etc. So what are the advantages of carrier screening? It can predict the risk of developing cancer in self. It can help in cautioning the family members, to plan screening accordingly, and can help take preventive steps or mitigating steps. We've all heard about the prophylactic mastectomy, oophorectomy, and then it can undertake lifestyle changes, help in undertaking lifestyle changes. This possibly is the most important because this will help prevent the second hit, which is the decisive hit in causing cancer. So it can help plan regular screening for diagnosis like pap smears, mammography, self-breast examination, etc. These days, pre-implantation diagnosis is also possible to help prevent it to being spread to the next generation. It can help planning resources and, of course, in deciding the treatment modality which is appropriate for the given cancer. The community benefits by adding this to the research registry and the research. There are disadvantages too. So most of it, I think most important is the psychological one of being diagnosed of having a mutant gene, which may not lead to a cancer, but that burden is psychological nevertheless, which can lead to unindicated medical interventions and therefore financial issues also. And of course, the insurance guys are always there to hype up the premium if they know that one is carrying a mutant gene. Angelina Jolie has made it world famous by going ahead with a prophylactic mastectomy because of the BRCA gene mutation. The results of these genetic carrier screening tests could be positive, negative, or variant of unknown significance. So that is where there is a role of genetic counseling in this genetic test. So these counseling covers many aspects of the testing processes, including the hereditary risk assessment, the appropriateness of the genetic testing and the potential harms, the medical implications of it all, the possibility that the test might not be informative, the psychological risks and benefits, and the risk of passing it to the children, the impact of testing for the family, and the best test to perform, and the specific test to perform, including the technicality of it. Now, who should be taking these tests? If the people who have any or all of this or some of these, like people having family members, first degree family members with the same type of cancer, several family members having cancer before the age of 50, 2 or more relatives having cancer, rare cancers like the male breast one, or physical characteristics which are otherwise benign but can lead to malignancy like neurofibromas. And of course, if one is a member of a specific racial or an ethnic community known to have heightened inherited cancer syndromes. This is a brief about the BRCA 1 and 2 as to who should be taking it up. It's almost a repetition of the previous one. A special note on breast cancer in males. It's been seen that 40% of the breast cancers in male may be related to the BRCA gene mutation. And therefore, the NCCN recommends that all men diagnosed with this cancer do get the BRCA 1 and 2 testing done. Important to note it as it is not just for cancer breast, but it's also for pancreatic and prostatic cancer, hence the relevance. So some more statistics regarding BRCA. So as I had mentioned previously, BRCA is responsible, only 10% of breast cancers are caused by BRCA, but those carrying BRCA gene mutation have a very high risk, like 50% plus, 50 to 70% plus of developing CA breast, and around 30 to 40% of ovarian cancer. And likewise, the risk of breast cancer in males is 10% more than those not carrying the mutation. And therefore, and also the increased risk of pancreatic and prostate cancer. And it would is a numbing thought to know that the incidence of BRCA gene mutation in the general population is 1 in 400. So you can extrapolate the numbers. And then there are, of course, some more tests, the oncoproteins and the oncoviruses, which can help in the screening process. BONC, or the oncoviruses like HPV, Epstein-Barr's, hepatitis, HTLV, HHV, etc., have also been implicated in different malignancies. Viral genome quantification by the RT-PCR is one of the standard methods of diagnosing viral oncogenes, and hence its role in genetic screening. The cervical cancer success story is a story which everybody knows and should be told and retold for generations to come. So it has provided an excellent example of the power of early detection and therefore subsequent treatment. The pap smear started the whole process. Now, because of pap smear, all of us also have got to know that HPV is the main virus causing cervical cancer. And not only that, HPV also is responsible for anorectal, oral, penile cancers, respiratory papillomas, papillomatosis, and warts. So we at Greenarray have developed an HPV detection kit, which diagnoses all high-risk HPV types. And of that, one of is also is a self-sampling kit, which the women can do at the comfort of their own home. This is a rather busy slide, but in summary, this basically shows the current cancer screening processes using the various methodologies and what it can benefit. I mean, who can benefit from it? In the sense, unknown primaries or people who are apparently healthy find out from this testing that, yes, they do harbor a malignancy. So what are the recent advancements? Liquid biopsy. Now, liquid biopsy has the potential to become an instrumental non-invasive screening tool for solid tumors as against the presently used standard biopsy, which is invasive, can cause seeding, painful, and can be impractical. At some points, it cannot be reached also. So types of liquid biopsies are based on circulating tumor cells, circulating tumor nucleic acids and exosomes, and body fluids like blood, serum, plasma, urine, CSF, saliva are used as samples. So to that extent, it is non-invasive. And it's been called the holy grail of cancer research. So the goal is to develop a blood test, such as this one, that can accurately identify cancers in their early stages. Multi-cancer early detection tests also combine the molecular analysis of tumor-generated markers along with AI to simultaneously detect a variety of cancers. They are promising tests, but are to be used with caution at the moment. No screening is without a debate. So should it be a universal screening or a targeted screening? Right now, one would advise a targeted screening as the approach. To quote a number, the estimated number of incident cases of cancer in India for the year 2022 was found to be 14,61,427. Having said that, these numbers of these are the cancer cases diagnosed in India in 2022, of which around 10% are hereditary, and human tumor viruses account for 12 to 20% of these cancers worldwide, which means that at least 1.5 lakh cancers can be potentially predicted or prevented every year using genetic screening alone and in India. So, as I said, you can extrapolate the numbers. So that, and the rest can very definitely benefit from the lifestyle changes. So before signing off, I would like to make a case report. This is Mrs. TT who approached our hospital, age 37, with a family history of 2 paternal aunts positive for cancer breast, 1 for cancer ovary, and a sister with diagnosed cancer breast. So she opted to test herself for the BRCA mutation and tested positive for it. So she went ahead with a prophylactic bilateral mastectomy. And lo behold, on HPE, one of the breasts showed infiltrating duct carcinoma and the other benign proliferative parenchyma. So she came to our hospital, approached Sir Dr. Gupte to consider hysterectomy with bilateral salpingo-oophorectomy. So that's the power of screening. Thank you.
Thank you for the presentation on understanding how genetic screening helps in the early detection of cancer, and with that we can make out and take all the precautions to prevent the further increase of cancers. And to change the genes, there is no genetic therapy has to come in the future years, I think, then can alter the genes also. Thank you.
If there is no history of the cancer in the family and one person finds the cancer positive, how we can correlate with the any mutation in the genes? Or
yes, there are tests which can test for mutations, and then depending on the mutation found, we can decide whether this was a hereditary mutation or a somatic mutation which has been got subsequently, a sporadic mutation, and then subsequently the guidance can be for the family members as to whether they need to go in for the testing or not
in the next generation.
That's right.
So it is
not just next generation, the same generation relatives also. Yes.
So with this genetic study, it is very much easy to prevent, diagnose and treat the cancer nowadays.
Yes, at least it has given us an opportunity to do that. Yes.
Yes, madam.
Pardon me?
Breast cancer. If mother has breast cancer at age of 70, daughter is advised BRCA1 or BRCA2, like, or not?
Basically, again, it will depend whether the mother is positive or not. If she has got breast cancer because of any other gene, BRCA testing will not be helpful. So the index case needs to be tested first, and then depending on the gene that she is carrying or the mutation that she is carrying, we would advise accordingly for her family. Oh, they are genetic tests, so they are 100% accurate. But that's what I said. Carrying the mutation doesn't mean that you're going to get the disease. Mutation can be diagnosed. Yeah.
Thank you, ma'am. Please come over here. May I request President Dr. Raju Varyani sir and Dr. Gupte sir to come on to the dais to felicitate ma'am. And I request all the chairpersons to join for the felicitation. Excellent talk, ma'am. Excellent. Let's go to the next topic.
Yeah. Before beginning of the next lecture, on behalf of this jam-packed audience in this IMA auditorium, I thank IMA Pune branch and especially Dr. Sanjay Gupte and his Gupte Hospital team for organizing such a very, very important CME on very, very important and lesser known thing in medical fraternity. The next lecture is on a very important topic. It is on newborn genetic screening. As you all know, traditionally in India, whenever a child is born, his parents and all grandparents, they run for the horoscopic thing. They go for arranging a horoscope. Recently, I came to know that this horoscope is rather organized after 2 days. But the modern genetics and of course the study of genetics has given us opportunity. If you do it in first 48 hours, you get more details about the child's future, especially his health. In the first 48 hours, if you go for this genetic screening. There are so many conditions which rather may occur in his future life. Very important. There are around 50 conditions which can be sorted out in this screening. Out of that, phenylketonuria, congenital G6PD deficiency, cystic fibrosis, then sickle cell anemia, then congenital adrenal hyperplasia, and congenital hypothyroidism, and so many things can be diagnosed beforehand. And to enlighten us on this topic, may I invite Dr. Sarjan Shah to give this lecture. Dr. Sarjan Shah is MBBS and MD from Bharati Vidyapit Medical College in 2008. He is Director of Greenarray Genomics and Research Solutions. He is Director of Green Cross Pathology Laboratory. He has attended molecular diagnostic courses at SGPGL Lucknow and TMC Calcutta. Kolkata, received training cytogenetics and counseling from Dr. Hema Purandare in Mumbai. Completed his training as NABL auditor in 2009 under Virupaksha, the pioneer of NABL in India. And again, when NABL was upgraded in 2017, he did his rather training at Zydus Hospital. Right now, he is serving as consultant pathologist and NABL auditor, deputy quality manager since 2008, and now the deputy technical manager as well. He is associated with Help Voluntary Blood Bank as a quality manager and technical manager under NABH since 2009, and which has become the first private blood bank in Gujarat to receive NABH accreditation. He has presented more than 100 speeches in CMEs and research papers in academia journal. May I request Dr. Sarjan Shah to start his presentation. Thank you.
Thank you, sir. Good morning, ladies and gentlemen. I am Dr. Sarjan Shah. I am the director at Greenarray Genomics in Pune. And topic we are discussing today is newborn genetic screening. So what every couple and family wants after their baby gets delivered at Gupte Hospital, that the baby should be healthy and hearty and they should have a great life. So when I was making this presentation, India's population was 1220 million, and thanks to hospitals like Gupte Hospital, it is approaching 1500 million. And the birth rate is around 20.6. So every day 30,000 newborn babies are born. Incidence of neonatal disorder is 1 in 1,000. Thus, every day 30 newborns in India are having some or the other kind of disorder. Individually, these disorders are very rare, but when they are clubbed together, the incidence is 1 in 1,000. Still, in India, we don't have a good NBS newborn disorder prevention program in India. So what is newborn screening? Newborn screening is the process of testing newborn babies for treatable genetic, endocrinological, metabolic, and hematological disorders. The goal is to identify the newborn at risk for treatable disorders, traditionally focused on disorders with effective early treatment. Now, how did it all start? Well, as you can see, this gentleman called Robert Guthrie, he is also known as the father of newborn screening. Now, he had an intellectually disabled child, and his physician friend asked him that he's suspecting phenylketonuria, as madam discussed in the earlier presentation. And at that time in US, in 1964 this was. So in US also there was only one lab in California, and they had to send the sample all the way there. So he asked him if he can develop some kind of test, and he actually did develop a test called bacteria inhibition test. And fortunately or unfortunately, his son was negative, but his niece became positive. So then he made it his mission that I have to put newborn screening panel into practice. And he also devised a filter paper system for collection and transportation of this small blood sample. And that is also known as Guthrie's card. So aptly, he is the father of newborn screening. This was back in 1964. Now, as we can see the milestones in newborn screening, as sir said, the first screening panel was started in 1984 with 6 disorders in their mind, which were congenital hypothyroidism, galactosemia, PKU, then G6PD deficiency, and maple syrup urine disease. Then eventually in 2001, congenital adrenal hyperplasia was added. In 2002, mass spectrometry came into picture, which is sort of a technology which divides proteins into a single panel and identifies the test. So it became a second-tier confirmatory system in 2002. And as in how the diseases were discovered, there were high incidence of newborn disorders, the panel became bigger and bigger. And as sir said, it became about 50 disorders in mass spectrometry. So till 2018, this mass spectrometry was used as a confirmatory panel. But due to lots of false positives and false negatives, genetic testing was started. And in 2023, all the developed countries like USA, Australia, Europe, they're all using genetic testing for newborn disorder detection. In 1968, Wilson devised a criteria that what diseases should be there in this panel. And I feel they are still relevant. The first was condition should be an important health problem. The test should be acceptable to the population. Disease does not manifest at birth or routine examination. Treatment will prevent mortality and morbidity. Delay in diagnosis will cause irreversible damage, and screening should be cost effective. Indian Pediatric Association also came into picture, and they published there, according to them, what should be the 3 categories for newborn screening panel testing. So category A, they said that screening should be done for congenital hypothyroidism and hearing, and it should be a must in Indian scenario. Then screening for congenital adrenal hyperplasia and G6PD deficiency should be added in a phased manner. And as we all know that G6PD is seen more in northern states, so that is mandatory there. And screening of sickle cell anemias and hemoglobinopathies should be there in pockets of high incidence. Category B was for high risk screening. Screening for the disorder should be conducted in high risk population like consanguineous marriage, previous child with unexplained intellectual disability, seizure disorders, previous unexplained sibling deaths, critically ill neonates, and newborn children with symptoms, signs, or investigation suggestive of inborn error of metabolism. And category C screening was for in-source rich settings where laboratory is available, transportation is easily possible, and there it should be done for 30 to 40 metabolic disorders. Now, why screening is important? This again is a very busy slide, but we have mentioned here all the different disorders, and if it is not screened, the baby will be there will be a developmental delay, intellectual disability will be seen, there can be neurological damages, seizures can occur. As we are aware, hemoglobinopathies will require multiple blood transfusions, and even death can occur. And when all the babies are screened for neonatal disorders and neonatal disorders are identified, then most will stay alive, most will have a good life, there will be less chances of mental retardation, intellectual disabilities. They can have a normal life with fewer metabolic crises as compared to an undiagnosed patient. Who should avail this test? Ideally, every newborn should undergo this test so that many congenital disorders can be diagnosed early, and the incidence will again become shorter if all are screened for that. This will help in early treatment measures and prevent some important disorders of which severely affects baby's health and progress. Now, what are the types of newborn screening? The blood spot screening, which is done in a laboratory, a hearing screening, which determines if a newborn is deaf or hard of hearing, pulse oximetry to rule out heart conditions. CNS ultrasound is usually done for newborn babies who are preterm. Now, what are the types of laboratory newborn screening? One is a conventional type, which include immunoassays, ELISA methods, mass spectrometry, and HPLC. And there are genetic screening, which is by Sanger sequencing, which is the gold standard, and next generation sequencing, which will have panels for neonatal screening. Now, what is the kind of sample we'll be able to use? So it will be a dry blood spot, as you can see from the image. A heel prick or an earlobe prick sample can be taken, and those sample will be put on 5 or 3 round circles which are present on dry blood spot or a Guthrie's card, as I mentioned earlier. A cord blood can also be taken. With the help of Gupte Hospital, we have actually identified how to take the sample. We train the doctors how to take the sample, so we get baby sample properly, and we have validated this system. So in a way, for a baby, it becomes a non-invasive technique. And of course, first void urine sample will also have a lot of DNA, so that also can be taken. Now, what is conventional NBS? Conventional NBS primarily detects levels of amino acids, acyl carnitine, and biochemical markers that detect congenital disorders. Samples are run in batches and results can be achieved in a week. Any positive needs to be reconfirmed again with a second sample and eventually with a genetic test by next generation sequencing or Sanger sequencing. And it should be done between 48 to 72 hours. It is a very time dependent test because all the reference ranges for that are time dependent. The CLSI guidelines suggest that NBS, conventional NBS should be done at birth at 48 to 72 hours. Also 28 days after birth or discharge from hospital, whichever is earlier in case of preterm baby, and do not opt for NBS if blood transfusion is given, because there will be mixing of blood of the donor as well. What are the types of conventional panel? So basically they are divided into two. One is a basic panel and another is an expanded panel. So basic panel will have 6 disorders, which usually in the world are congenital hypothyroidism, congenital adrenal hyperplasia, G6PD, galactosemia, biotinidase deficiency, and PKU. And expanded screening will have around 50 disorders, which include the metabolic disorders, endocrinal disorders, hemoglobinopathies. Now, what are the demerits of conventional NBS? Firstly, as I said, it is time dependent. It has to be done between 48 to 72 hours. Why it is to be done between 48 to 72 hours? Because after breastfeed, the baby's metabolic system awakens and there is a huge progress of those amino acids in the blood. So just after breastfeed, if you take it, lot of amino acids will, even if they are deficient, there will be a jump in their level. And of course, the stress of birth process will also add to it. It is important to adhere to the recommended time frame for obtaining newborn screening tests because the cutoff values for screening analytes are set to reflect values expected at this age range. Now, there are chances of a lot of false positives. If a baby is given total parental nutrition, preterm babies, low birth weight babies, artifacts like if there are blood clots present, then it can interfere with the results. Even some antibiotic also interferes with the protein. False negatives can occur because of weather conditions. So this was very interesting that if the blood is getting transported from the hospital to the lab and it's an extremely heat condition in a summer, it temporarily deactivates the galactose enzyme. And so when the blood sample reaches the lab and we test it, it will show a deficiency, but it is actually not a true deficiency. And these cutoff values are not demography based. So we are using the same values, USA is using the same values, Australia is using the same values, even Africa is using the same values. So if early collection is done, then false positive can be seen in hypothyroidism cases and CAH cases. False negatives can occur in amino acidopathies and organic acid disorders. So many potentially treatable conditions cannot be detected in infants using current newborn screening conventional methods like cystic fibrosis, sickle cell disease, and severe combined immunodeficiency. You have to go for genetic testing in these cases. And sickle cell, SCID, we know that incidence is increasing day by day. Most of these disorders result from genetic mutation and could in principle be diagnosed shortly after birth only with genetic screening. So coming to next generation sequencing in NBS, NGS embraces the same concept as NBS to be predictable, preventive, and personalized. As I mentioned, here we are detecting the genes and not the metabolites. Even asymptomatic babies at birth can also be diagnosed. Many more genetic conditions can be diagnosed with this, and it is time independent. It can be done in newborns, it can be done in children, it can be done at adolescents also. So Greenarray Lab has developed a cost-effective newborn genetic screening panel of 47 genes using next-generation sequencing to screen this as per Indian scenario. So we need to look into what is common in India. There is no point in discovering a test which is very common in USA and not in India. That is just wastage of resources. So all the conditions of metabolic disorders, hemoglobin disorders, congenital hearing loss, and endocrine disorders are covered in this short panel. So these are the 34 disorders which we cover. It covers the complete gene of the panel. So not even a single mutation is missed. Even a novel mutation can be identified in this case. And management and treatment strategies are available for this. We also have a larger panel of more than 350 genes covering more than 400 disorders. So as I mentioned in short panel, all other disorders covered are renal disorders, congenital heart disorders, pediatric cancer disorders. There are disorders for vision loss, hemoglobin disorders, epilepsy disorders, neuromuscular disorders, immunodeficiency disorders are also covered. And management strategies are available for most of the cases. So when we compare NGS and conventional NBS will give you at that moment what the child is suffering from. It is like a blood test, that what is happening in the blood at that time, what are the metabolites which are rising at that time. And genetic screening will give you the idea about what the baby is suffering today, tomorrow, or day after. So an example of this is a very long chain acyl-CoA dehydrogenase deficiency, which can either present in infancy with a severe cardiomyopathy, multi-organ failure leading to death, or in an individual who starts exercising and presents in adolescence with rhabdomyolysis. So there are two different presentations according to the mutations involved, the gene rearrangement in that particular baby, which can only be detected by genetic screening. Coming to the comparative analysis between both, the methodology are different. The disorder, there are larger number of disorders which are covered with genetic screening. The detection is at gene level, so confirmation is not required. The test interpretation gives you an idea of predisposition also. All of us are aware about beta thal trait and beta thalassemia major. So we can identify the traits also. So by that we can identify that what will the baby suffer in future, how you can plan your pregnancies in next pregnancies. You can go back and test the parents also. You can go back and test, as Gayatri ma'am suggested, the family also. Those disorders can be identified in the family as well. Now the most burning question India will ask is, kitne mein padega? So the potential benefits of early diagnosis, timely treatment, and finding out the whole family tree tendencies will outweigh right now the cost, a little higher cost of genetic screening. But as we all are aware that when COVID started, it used to cost, the single test used to cost us 5,000. Right now it is less than 500. So as more people will come into this, the costing will go down. Now, as I discussed, NGS can be used as an adjunct or as a first line test. As an adjunct, it will clarify the borderline biochemical screening results. It will improve the prognostic utility of those conventional NBS results. It will pinpoint those screen positive patients where clinical intervention is needed, and it will prevent the unnecessary medicalization. And when it is used as a first line treatment, timely rare disease diagnosis which will prevent the cost and distress to the family, and an extensive diagnostic ODC can be prevented. It also gives you a reproductive decision idea that what you need to plan for future pregnancies, and of course the timely treatment. Coming to few cases we have seen at Greenarray, a healthy baby was born to a normal non-consanguineous couple, and couple opted for a genetic screening. We found a GJB2 gene mutation, which is for deafness. And usually we see that all the babies who are deaf, they cannot hear any sound, so they cannot speak also at the same time. But now science has come to this, that language therapy, speech therapy, if you identify the mutation in a deaf child and you give this treatment, they do develop speech. It's not that a deaf child will always be deaf and dumb. It is not like that now. There are therapies available which can be started. So only a genetic screening will help in early detection and management of congenital disorders like this. Case 2, this was a consanguineous couple and they opted naturally for newborn screening, and we found out a BTD gene mutation in this case. Now BTD gene is for biotinidase. Biotin is an enzyme which has to convert into a free form by an enzyme called biotinidase. So if it is not available, biotin is no use. And biotin is most essential for fat, protein and carbohydrate metabolism. It's a small vitamin, but it is very essential for all the metabolites. And we find out that in 2 months time, the baby's biotinidase levels in a laboratory showed less value. And immediately the baby was started on biotin supplement. So he will have a normal life now, other than identifying later that should have started biotin, and because of that there are malnutrition and neurological damages. So newborn genetic screening helps in on-time medical intervention for the baby and also help the couple to get themselves screened before planning for next pregnancy. Now this was a very interesting case. A healthy baby was born to a normal non-consanguineous couple with an elder sibling with 2 episodes of seizures after 1 year and mild developmental delay. So the couple opted for newborn screening. Newborn screening revealed a ACADM gene mutation. This condition can have a disease onset within 1 to 3 years of age and shows varying penetrance. So it will not show at birth, but it will come up later in life. Therefore, the condition might get missed by a conventional NBS window frame of 48 to 72 hours. If not detected on time, this can lead to developmental issues and failure to thrive. After finding, the 3-year-old sibling of this baby was also tested by Sanger. So after doing the panel, we can identify the mutation. That single mutation can be done on Sanger sequencing. So as we knew the previous baby was positive for this particular mutation, we immediately checked for the baby who was 3-year-old and found the similar homozygous mutation. So, and after we found out this, it showed an elevated level of an octanoyl carnitine acid. So that was the defect in the baby. But since the same mutation was there in both, we could identify this mutation, and then the family was also tested for this. Newborn genetic screening helps in early detection in the newborn and identifying the similar genetic conditions in siblings which could have outgrown as the child matures. Now these were the cases. Now what Government of India has been doing for this. So there were 3 programs were started in 2007, 2008 and 2012 with different disorders in mind by the government, but due to political reasons, none were continued. Abhi Modi hai to mumkin hai. So Government of India started something called Rashtriya Bal Suraksha Karyakram with 4 Ds in mind. That was early detection, disease identification, deficiencies, developmental delays and disabilities. So they trained the ASHA workers, because you have to go to each villages and find out these disorders. So ASHA workers were trained how to identify these disorders at birth and also to do the follow-up of this child till adolescence. So idea was to identify the rare diseases. National Health Policy also mentioned the same in 2017, and now a new draft which is added for National Policy for Rare Diseases in 2021 will be added into the National Health Policy, which has following things in it: to review the national policy for treatment of rare disorders, to define rare diseases in India, to draft national policy for rare diseases, to suggest vision and strategy in country's context. And the very important point in this is compensation of up to 20 lakh for any newborn disorder diagnosed baby. So in summary, NVS is not simply a test for diagnosing a disorder, but a coordinated, comprehensive system that is consisting of other aspects also, like education of the society, follow-up of abnormal results and confirmation, diagnosis, treatment, management, periodic outcome evaluation, quality assurance, and evaluation of the whole program for a good newborn health. So let them plan these things, like waking up at 3 a.m. for no reason and just crying, rather than worrying about that health. Thank you.
Thank you very much, Dr. Sarjan Shah, for completing a lecture in given time, accurately, even a few seconds before. Yeah, I would like to ask one very simple and a very important question, that what is the accuracy in this diagnosis, percentage of accuracy in this?
Sir, that is why the NGS panel is almost 99.99%, because it will only the pre-analytical errors can give a rise to any issues. Otherwise, it is absolutely, bang on, because here we are looking for genes and not metabolites. Like actually, when we look back, the conventional newborn screening is hardly 50 to 70% effective, and you have to keep retesting the samples to confirm it and again go back to genes. But once genes have been identified, there are no chances of it being negative.
You have worked in NABL, you must be aware of it.
Yes, yes.
Thank you very much. But how do you differentiate the false positive and false negative test in all this?
You have to do the genetic screening. In newborn genetic screening, there are no chances of false positives and negatives, but the conventional biochemical ones, which shows you a lot of false positives for the what I all mentioned, the timing and everything is very important. That is why all the developed countries have shifted to it, because there the costing is not that bigger issue and they are covered. So that is why they have gone to genetic testing.
If we can take one or two questions, which are very important.
You mentioned about the effect of feeding the
Yes. Correct.
In that case, is cord blood the best sample for
Yes, because we are identifying fetal cells and identifying the genetic test out of it.
That
So
is
there,
the simplest actually.
yes, absolutely. That is why we have validated it at the hospital, and now we are asking others also to join, because parents don't want their newborn baby to be pricked on heel and earlobe, and everybody will have a resistance to it. So that is why we are looking for a as far as non-invasive process to do the test.
For the NBS, you said that the 48 to 72
hours, yes.
And in cord blood, there is a stress of the liver.
Right.
So sampling is correct that time?
Ma'am, for genetic testing, it is correct at birth, but not for the conventional NVS, which is used right now. For that, it shouldn't be done at birth.
So we have to train who is collecting the blood.
Absolutely.
Not after the breastfeeding, not after even crying of the baby.
Absolutely.
Yeah.
So we have prepared a pre-analytical guideline for newborn screening. So whosoever is collecting it, we actually go there, our scientists go there and explain the criteria, how to take it, when to take it, things like that.
Like NBS, is there any genetic sampling timing is?
Not really. We can take it anytime. That is why genetic screening starts with that umbilical cord, then you can take it anytime.
Yes. And like we are diagnosing the abnormal genes and conditions, but nowadays we are seeing that the milestones of the baby are very fast.
Yes.
Is there any reasoning for that?
For fast milestones, we have to check. For delayed, we have a panel, but for fast, we'll have to check. Nobody has complained so far, so but it is difficult. I have 2 daughters, so I know what you are saying. So absolutely.
Yeah, we are seeing that baby are growing very fast. They are turning on the abdomen.
Influence.
Yeah.
It's the competitive environment, probably. I don't know. Yes.
As the antibiotics and other medicines, if rather other things are given, the blood should not be collected after that. Is there any effect of the vaccines which are given at birth? Like
I'm not aware of, sir. As far as the
it is not mentioned,
Yes, vaccines I'm not aware, but antibiotics, yes, there are publications on that.
Previously, we used to give oral polio.
Okay.
And even the BCG is given. So, is there any effect? It is not.
We'll find out. We'll find out.
Thank you.
Yes.
Thank you, Dr. Surgeon. Please come over here. May I request? Yes.
Excellent presentation. So actually, I wanted to ask that in case of childhood leukemias and all that, this thing so is there any way to detect it?
Yes, of course, we have a hereditary cancer panel, so that also can be done at
so when
birth.
there is no family history or anything,
Still we can do it. There are a lot many tests
so
available.
the advanced screening of this, that panel we present, maybe if some parents
Yes,
come
in
and-
that 400 disorders we have included pediatric cancers also. So most of the common pediatric cancers are included in the bigger panel, not in the smaller panel, because the incidence is that way.
You can send it right at the newborn.
Absolutely, anytime. Yes.
May I request Dr. Varyani sir, Dr. Gupte sir, Dr. Sanjay Patil sir and Dr. Navarange sir also to join for the felicitation, and all chairpersons to join, please.
Hello. Dr. Gupte sir doesn't need any introduction, but it is my privilege to introduce him.
So we'll skip that because so that we won't keep Madam waiting. Otherwise, we'll be delaying the oration. No, it's okay. I'm here around, no problem. So, yeah, introductions are not important.
It is his greatness.
See, already I have on the first slide, so don't worry. Thank you so much. Great to.
ओळखून आहेत असं म्हणायचं का?
Exactly. काय हरकत नाही. Okay. Thank you so much for being here in such a large numbers, and that shows the interest of everybody in this, new science that's coming in. And I think in years to come, and I'm glad a lot of youngsters are also here, that we are all going to talk only about genomics and nutrigenomics, pharmacogenomics, and most important, that later that you have one very important topic, and that's by Dr. K.H. Phadke, and that is the microbiome. So these are the things that we are going to have in future discussing, in detail, and I'm sure you will take it up, you will take interest. There are so many good books now available, even colloquial in literature also. One book that I may suggest to you read is called as Hacking Darwin. That's a wonderful book that gives us idea about what's going to happen in this field in next year. The whole scenario is going to change completely, and everywhere you go, right from as you will see, all babies will be having their genetic testing, so you will have your genome on your pen drive all along, and every single thing that you do, even if you go for aptitude for your scholastic aptitude, the children will go for this athletic aptitude, whether to go for marathon or go for sprinting and all this. And this is all going to depend, even when somebody goes for a job, people are going to see the job and see whether what kind of risk-taking things are there. Insurance policies will depend on that. Your driving license also may depend on that. And that's not something I'm imagining and telling you. This is the British government's, official expert panel report, and it's available on, web everywhere. And this is what they predict. is going to happen. So genetics is a total revolution. Just like, atom came and the bytes, came and, atom at the atom bomb and this thing, then the bytes came and we had the, computer revolution. This is the next revolution happening in front of us. And that's why every one of us, and as clinicians, as, doctors and people in this field, we are the ones who need to lead this revolution. And that's why everyone has to take interest in this particular field. And I welcome Dr. Pingle has come all the way from Mumbai. As you know, he's a very, very important person in IMA. He's the former state president and my MMC colleague. So, Dr. Pingle, wonderful to have you. Now we have obviously less time for this talk, and so I'm going to go a little faster in this. So, as I said, we don't want Madam Phadke waiting. So, these are the reasons why we need to do the testing in reproductive medicine, causes of infertility, genetic diseases transmissible to offspring, optimization of assisted reproductive technology, the ART technology, and of course, investigations in case of repeated pregnancy loss. 65% of the time we are able to diagnose why the cause of infertility, but that means in 35% we just label it as unexplained infertility, and that's why we need this genetic testing to come in. So this is a summary slide, but let's go directly to the male infertility. You take it pre-testicular, testicular or post-testicular, in any situation, the genetic testing becomes important. The genes play a role, and more than 200 genetic disorders have been decided or are seen in OMIM. OMIM is an atlas where you see all these genetic disorders displayed and details of that. And again, these are free softwares or free databases available on website for all of us. So everything is now available out there for us to study. Is the matter that whether we have the inclination to do so. So genes can interfere in male infertility, again in gonadal development, gonadotropin action, gametogenesis, organ malformation, and sexual behavior. There are chromosomal aberrations, there are partial chromosomal aberrations, and monogenetic diseases. In whole chromosomal aberrations, there are almost 1 to 2%. And as Madam was just saying, the things are changing, and we see that male infertility is increasing tremendously. And I think we have to look at it very carefully, because you see now oligospermia and azoospermia patients coming up very, very frequently and I think that's a lot of lifestyle issues are involved in that, and that's something we need to look at also. So commonly done, I'm not going to go into the details of the test because you already heard that in some of the first lectures, and you'll be again hearing in the next lectures. But when you have a patient of azoospermia or severe oligospermia or actinozoospermia, these are the tests that we have to carry out. The partial chromosomal aberration for AZF. AZF means azoospermia factor, which is on Y chromosome, and again this can be seen in detail, and we can find out the cause of why the patient is having that oligospermia or azoospermia and so on. So these are again the test polymerase test, chain reactions, multiplex PCR, and so on, which are utilized for these particular testing. Single mutations are also there, and single mutations are again important because CFTR gene is famous, though it's not so common in India, but we have other common genes, AR gene mutation, and we'll discuss some cases regarding this and how that affects in treatment modalities also. So let's start with a case first. The 32-year-old male patient diagnosed with severe oligospermia. The patient's physical examination, all profile was normal. In fact, karyotype and Y chromosome microdeletion test was also normal, had no particular history of infection, congenital anomalies, or iatrogenic injuries. So was referred to for gene mutation test. And when we did the gene mutation test, we found out that there was a mutation, homozygous truncating variant mutations in exon 6, a particular, I won't go into the details of name, but that regulates the spermatogenesis. So at least in these kind of patients, we are able to pinpoint what the cause is and what we can expect. Otherwise these patients, as we all know, keep on growing from pillar to post and taking all kinds of treatments and hoping that they will get some benefit out of that, waste a lot of time in that, and then finally end up in going for various ART techniques at very late at infertility level. So it's diagnosing accurately and properly does make a difference. This is another case. This patient had obstructive azoospermia and absence of vas deferens. And we know when absence of vas deferens is there, generally the CFTR gene is mutated. This gene has also to do with cystic fibrosis, and as expected in this particular patient, we found that CFTR gene mutation was there. Now, why this is important? Then what will happen? What treatment do we go for in this patient? Whether, can we connect, do something to sort of replace the VAS, or directly do nowadays techniques like TESA are available, and we can collect the sperms from the testes directly and do IVF. So all these possibilities are there if we diagnose accurately and properly. A lot of time is saved, a lot of money is saved for the patients, and the treatment becomes quite timely. So this is again an important case. Now this is something we always feel in genetics, or we have diagnosed the mutation. So what do we do with that? Usually there is no cause. So this is one test now which is done fairly when you have all the hormone levels normal, but still there is severe oligospermia, or sometimes even azoospermia, and you do this FSHR mutation testing. If it is comes positive, then it's possible to use. I'm not saying in 100% cases, but if you know Dr. Rupin Shah, who is a famous andrologist from Mumbai, he has done a lot of studies on that. And when you use this HMG injections in these patients, there are advantages, and you find that the patient gets better results. So it's not that always these are untreatable diagnoses. No, sometimes they are very much treatable diagnoses also. So this is what was done in this patient, and we found that actually the sperm count improved in this particular patient. Now, most recent, and this is I find very exciting, and as I said, we'll be talking about microbiome in the afternoon. We saw many patients who are having absolutely so-called normal semen. All usual parameters are done under microscope and everything. Even the sperm culture or semen culture is done in routine manner and found to be absolutely normal. But some patients can have pregnancies and the others don't. And why this happens? So we went into the detail of the analysis and found there is now something called as microbiome, and there is something called as semen microbiome. That means there are thousands of good and bad bacteria in the semen itself. And if we are able to diagnose and find out what these bacteria are, whether they're good or bad bacteria, whether there is now, again, I'm sure Dr. Dake Phadke will tell you about what is dysbiosis, disturbed balance of these bacteria. And if we can find that out, then there is a possibility that we can correct it, and in that so-called unexplained infertility, we can treat and achieve pregnancy. So these are the kind of reports that we generate. Thousands of bacteria are identified. There are some good strains, there are some bad strains. For example, Prevotella is known to be a bad strain, but now these are not just single bacteria to be identified. There are various strains, and that's why we have to go and actually diagnose them by next generation sequencing. This is something not you can do by culture and all, but if you do this and you find that various different type of bacteria are there, then the challenge becomes, how do we change this? And that's a bigger challenge. There's no final answer to it, but we have seen in many patients the proper lifestyle changes. And that's why, what happens in infertility patients, many times only the female is blamed. She doesn't conceive. I'm sure you heard of the families, even second marriages, third marriages by the husband, but the husband is obese, he's drinking, he's having a terrible, lifestyle, and still the wife, because his semen report is so-called normal. And that's why the wife is always blamed. So now we have to actually act on this and make sure that the males also take onus of this, improve their lifestyle, diet, and then we can achieve results in many such patients. So now we go on to the female infertility. Again, has been discussed, there is a huge role in premature ovarian failure, PCOS. PCOS cases we know that are increasing to the extent now they're almost 18 to 20% in practice, again because of lifestyle issues and the junk diet that starts right from the childhood. So various chromosomal abnormalities in females can be found. Again, I will not go into the detail for the shortage of time. Then genetic testing in female infertility is done by karyotype, fragile X DNA testing, next generation sequencing, and single cell testing. And we find these single gene mutations also in these cases. This will be, they will guide us towards what is the exact diagnosis in that particular patient and whether it's treatable or whether we do need to do or take some other measures for that. So again, as I said, let's not go into the technical details of this, because as I see, there are not only gynecologists, many other branch people are there. But so if we can go directly to the cases, and I think that makes it a little more interesting. So a 27-year-old female with no family history of any genetic disease was diagnosed with primary amenorrhea, expressed concern about her inability to conceive. Then physical examination was normal, slightly elevated, or rather elevated FSH levels 40 was the per ml. Diagnosed with primary amenorrhea since 23 years of age. Karyotype analysis for both the partners was normal. They were referred for chromosomal microarray analysis to see whether a chromosomal abnormality was the cause of the infertility. It was found that she had definitely change or these the various mutations or changes that are called as deletions and additions or gains, and that was found. And so crucial etiology for premature ovarian failure was seen in this patient. Now this is where again the role of genetic counselor comes in, or a clinician comes in, to decide now how to go about it. She is only 27 years old patient so far. So what do we do with her? But we are not going to get her eggs if she's already having premature ovarian failure. So whether to go for donor eggs in her case, which is possible and feasible, or if we get this idea much before, maybe if she would have been tested much before for this genetic testing, maybe whenever the eggs were at that time available, if at all, then could have been frozen and kept and so on. So this is something that we'll have to think for the future, that whether we start actually testing the patients earlier in this situation. So again, a second case, 35-year-old female presented with primary infertility. The genetic test of patient revealed autosomal dominant heterozygous missense variant. So again, genetic testing can identify the cause of disease, and we can decide our further management accordingly. Fortunately, since now all these ART techniques are available, and donor eggs and all are possible, or even surrogacies are possible, so all these issues can be tackled in a different manner. So genetic diseases are also transmissible to the offspring, and we've been talking about NGS and the hereditary cancers and so on and so forth. There are so many others. Almost 2,000 genetic disorders now have been identified, and that's why it's important now. And the time will come, I'm pretty sure pretty soon, that the young couples will undergo preconception carrier screening, if not before marriage carrier screening, which happens in Israel because they have a lot of Tay-Sachs disease also. So there are diagnostic options in this PGT and PND, that is invasive prenatal diagnosis. We know we do by CVS or Korean villus sampling, or we also do by can do by amniocentesis. But now non-invasive tests are available. And as of course all the gynecologists and obstetricians do know, but for other branches, after 10 weeks, anytime we can draw mother's blood, and there is cell-free DNA available of the baby in the mother, and we can test that DNA and then rule out many of the conditions, especially trisomy 13, 18, 21, and any sex chromosome anomalies also can be looked at. So one of the case studies, non-sanguineous couple in their 30s, this is one of the recent cases that we encountered. The first child had delayed milestones, convulsions, moderate MR, and low glucosamidinase A and a total hexosaminidase level. Child passed away at the age of 2 years. Was diagnosed as lysosomal enzyme disease, and to be specific, it was diagnosed as Sandoff disease. And now this couple, she is a relative of a doctor, came recently for now what further, what are they going to do further? And this is where again the testing helps. So in this baby, fortunately, they found out that there is a variation in HEXB gene. And that's why the couple underwent, carrier screening. And it was found that husband and wife were both carriers for same variant of XHB gene, but this gene is a autosomal recessive gene. That's why they were not suffering any obviously symptoms, but that means there was a possibility of 25% of having Sandoff disease in their further child. And that's why again here we either can allow them to have next pregnancy and test this during a prenatal period at 3rd month itself to find out whether that gene is present, or by amniocentesis and around 15-16 weeks, or we can tell them to go for PGTA, and that is testing, creating the many embryos as we do for IVF, and testing the embryos for this particular gene, and then deciding this thing. So rather than it's PGTM rather than PGTA. So what are these differences? We'll discuss in short. So this is a various indications where we undergo advise these testings. Again, I think theoretical testing will not do, but PGTA, the embryos now can be tested for aneuploidies, for monogenic diseases that we just discussed, and structural rearrangement also. And now even non-invasive PGTA is available. That means the embryo which is grown in culture fluid, that fluid can be tested to see whether that embryo can be, so actually embryo biopsy is not required in such situations. Now the final part in last 5 minutes, because as I said, we are not going to delay the oration. So there are now many cases. For various reasons, we get so many of the repeated miscarriage patients and BOH patients nowadays. And let's not go into the details. Most of the times, we are not able to pinpoint the cause. Why? Because in 50% of the time, the cause is genetic, and we need genetic studies in these cases. So these tests will help us in identifying genetic causes, tailoring the treatment to the patient's situation, reducing emotional stress, because once she comes to know at least that the baby was genetically abnormal and that's why miscarriage occurred, at least, they're it's a closure situation that, they don't blame themselves for doing something wrong or eating something wrong, or the mother-in-law doesn't blame the daughter-in-law for doing something wrong and all that. So in RPL also there is a huge role. The POC is important. That is, nowadays it's advised that for every single miscarriage, this product of conception should be done. It used to be difficult before, because in missed abortions where the baby is already not viable, it couldn't be done because cytogenetics or cell culture couldn't be done and karyotyping could not be done. But with now microarray testing, even in missed abortions, it's possible to find out the cause why this particular miscarriage occur and what we can do about it later on. So genetic testing can be used as diagnostic tool also in RPL, and later on, as we'll see, it can be used as a therapeutic tool also. So POC, as I said, should be done. Then parental genetic testing. If you just do the testing of that particular child or conceptance, that's not enough, because you have to find out where that problem came from, and that's why the parents also have to be tested in these repeated, and many times you find the cause and accordingly you can decide how to go about treating them. So there are single gene defects which can be identified in these patients. There can be immunological defects. Then what usually are there are two simple causes of repeated pregnancy loss or miscarriages. One type of cause is basically a genetic cause where there is something genetically wrong with the embryo. The second cause, of course, is immunogenic cause, mainly because from mother's side that embryo is not accepted, and then you can go in the subgroups and find out why this is so, and diagnose and decide. So there are thromboembolic gene defects. In India, in our patients, somehow we have found the embolic test or thrombophilia testing, when it is done, we have found that this plasminogen activator inhibitor is comparatively quite common in our situations compared to any Western literature that we come across. For example, in Western literature, factor V Leiden will be common, but we find this plasminogen activator, and then there are treatments for this and can be taken care of. And that's why we should be doing all these tests. I think I'll go directly to the case study. A non-consanguineous couple presented with a history of RPL with unknown cause. Genetic analysis of product of conception was not done in their case. A couple was advised to go for karyotyping. The male partner had revealed that balanced chromosomal translocation was there. Now this balanced chromosomal translocation is tricky because you can diagnose it only by karyotyping and not by even other advanced tests. But once you have that diagnosis, you can decide what should be done, whether they should take a chance and you go for PG, T8 karyotyping of the embryo later on, or advise donor sperms and donor semen use in the next pregnancy. So these kind of cases, again, the next case, a couple with normal karyotype at 3 miscarriages during 10 to 14 weeks of pregnancy, product of conception, karyotyping analysis for last miscarriage was normal. Again, microarray testing was done and problem was seen, and microarray test helped in identifying the cause of miscarriages, and then it can guide us for the further treatment in that particular patient also. So the panel that we have now, RPL has lots of genes, and I don't want you to go through that slides at all, but see how many genes are responsible for repeated pregnancy loss. This is just one, this is second, this is third. So all these genes are responsible at various situations in this problem. So to sum up, genetic testing itself is not a therapy for recurrent pregnancy loss, but it can inform and guide therapy options for individuals experiencing RPL. Genetic testing can identify chromosomal abnormalities, inherited genetic mutations, and other genetic factors that may be contributing to RPL, which can then inform treatment options and planning of the family. So if a specific genetic disorder is identified, genetic counseling can be provided to the parents, and in some cases, pre-implantation genetic testing also can be advised. So thank you very much. We are quite eager to listen to Madam Phadke. I can see so many of our patients here, and that's why I definitely would like to cut it short. Thank you so much.
Thank you, sir. With this lecture, we will find the solution from the infertility and repeated abortions. So thank you.
Thank you, sir. Thank you, sir. May I request Dr. Varyani, sir, Dr. Navarange sir to come on to the dais, Dr. Sanjay Patil to join on the dais to felicitate Dr. Gupte sir. All the chairpersons, please join for the felicitation. All the chairpersons. Just give us 5 minutes to make the arrangements and we'll immediately start. Video. वर करा.
आणि आपण केलं ते
थोडं तिकडे समय. राहू द्या. नाही समय आणला लगेच करायचं. म्हणजे आधी व्हिडिओ लावा. आपण साऊंड नाही आला तर काय करू? साऊंड चालू आहे. साऊंड चालू आहे. चालू करा. A very good afternoon, Dr. Phadke Madam. We welcome you from IMA Pune. And may I request our President, Dr. Varyani sir and Dr. Sanjay Gupte sir to welcome you.
Good afternoon, Dr. Phadke Madam. Good afternoon, Dr. Phadke Madam.
Madam, please unmute yourself.
She is unable to unmute herself, I think.
Good afternoon, madam.
Good afternoon. Can you hear me? I'll rejoin.
Yes, madam, we can hear you. Can you hear us?
Are you getting an echo? Then I'll rejoin.
No, it's okay, madam.
Okay.
We wish to welcome you. So I'm requesting our President, Dr. Varyani sir and Dr. Sanjay Gupte to welcome you.
Welcome, Dr. Madam. Dr. Phadke Madam, welcome.
Namaskar.
I am overwhelmed.
Thank you, madam, for joining. The hall is full packed with all your students and they are waiting to hear you. I request our president to give you a welcome address.
Good afternoon, madam.
Namaskar.
We all are missing you here.
So am I.
So today we have Dr. Gupte, CME. In this we have oration, IMA Pune, Dr. Asmita Gupte Oration. We welcome you all. We welcome Dr. Sanjay Gupte, Dr. and immediate past president, IMA Maharashtra, Dr. Suhas Pingle sir. Are you able to listen, madam?
No. Okay, welcome, madam. This is Dr. Gitanjali Sharma, Honorary Secretary, IMA Pune. So we start the program with the auspicious lamplighting, and I request all the dignitaries on the dais, Dr. Sanjay Patil, Executive Trustee, to join on the dais for the lamplighting, please. Asmita, madam. Okay. Now request Dr. Navarange sir to speak a few words about Dr. Gupte Oration.
Madam, good noon, madam.
Good afternoon.
Good afternoon. How are you, madam?
Good afternoon, Dr. Naurange.
Very
Good
nice
afternoon.
to see you here.
Namaskar.
Namaste. Madam. I will give a very, very brief introduction of this oration. And this oration was started last year in September 2022. And unfortunately, I was not physically present here, but mentally, and I was, of course, observing on Zoom from USA. So I missed the first program, but that was a very great, successful program. And the great person, Dr. Mashelkar, was had obliged us to be present over in the same auditorium. And this particular oration was started at the request of Dr. Meenakshi, and I was a little instrumental, Dr. Sanjay being my close friend, and he rightly named it as Dr. Asmita Gupte Oration Award to honor his wife. And this particular oration, we have kept it this way, but it will be always an academic, intensely academic program, and giving us some new vision as what they are instrumental in giving birth to the humanity. Similarly, they would give us the insights of some new topic. And similarly, we have today amongst us, and the right choice about the topics of genetics is Dr. Mrudula Phadke. I remember you, madam, when you came and joined first time in Pune, I had just completed my 5 months of housemanship, first house post in pediatric. And that was the thing which I remember in ward number 31, 32, that you used to take rounds, and initially you were not teaching us, but just listening to what the students are saying. And then you take a total hold of the situation and become a great teacher for all of us. And you are the most beloved teacher. And you are the right person, I said, because she was instrumental in bringing the topic of genetics in the medical college. I think it was first amongst Maharashtra, if I don't go wrong. And it was initially under the Department of Medicine, under Dr. Mutalik. And you took it forward and made a sapling grow into a big tree. And today's topic is very apt as this genetics today and tomorrow. I would go back a little. Genetics yesterday, today, and tomorrow. And what we heard in the first 5 talks, is that genetics has not only embraced us from the diagnostic point of view, coming to the pinpoint, what could be the reason for a particular thing, but it is going to affect our plates and our daily activities also, as what would be nutrigenomics, genetics, and also the exercises is related to various gene mutations. So I think it's going to go a very long way, both diagnostic, primary prevention, secondary prevention, and even the management aspect of it. Madam, with respect and love to you, so many, I think the hall is having the capacity of 196 and we are here at least 210. So this is the love and appreciation towards you and the insights you have imparted untiringly for so many years. We would have appreciated you being over here, but I think you have just come from UK and maybe because of Ganesh festival and you wanted to avoid the traffic and jams and so much of crowd, you have preferred to deliver the talk from Zoom platform. Thank you. Welcome once again.
Thank you.
Thank you, sir. मॅडम मी डॉक्टर गीतांजली अश्विनी आणि अविनाशची मैत्रीण आहे.
अरे वा, I am so pleased to hear your voice.
Yes, thank you, madam. आणि if you would have come over here, you would have seen the full auditorium exactly the way MG auditorium used to be packed for your lectures. I mean, there are lecture halls in BJ, pathology lecture hall, pharmac lecture hall, but madam's lecture used to be in empty auditorium. It used to be so overpacked, overfull. तर अशा त्या लेक्चरच्या आठवणी आज परत जागृत होत आहे. डॉक्टर संजय गुप्ते सर तुमचं इंट्रोडक्शन देणारच आहे, पण मी एक छोटीशी कविता मॅडमसाठी सादर करते. नावात मृदुलता, नावात मृदुलता, कामात अचूकता, मनात ममता सदा वसे, बाल्य चिकित्सा ध्यास जीवनी, ज्ञानदान हा वसा असे. व्यक्तिमत्व हे मोहक सुंदर, व्यक्तिमत्व हे मोहक सुंदर, हास्य निखळ गालात वसे. गुरु आमुचीही माताच सकला. सत्य pediatric ward साठी मॅडम वॉज लाईक अ मदर. माताच सकला, प्रेम स्निग्धता हृदयात वसे. शक्ती बुद्धी व्यक्तित्व कणखर. मॅडम वॉज नॉट जस्ट HOD आणि नारटाई शी वॉज डीन ऑफ बीजे. त्यामुळे त्यांच्या कणखर व्यक्तिमत्वाचा आम्ही सगळ्यांनी खूप छान अनुभव घेतला आणि इट वॉज व्हेरी व्हेरी एंटरप्राइझिंग. शक्ती बुद्धीचं व्यक्तित्व कणखर, संशोधनाचा स्रोत असे. ना पैशाचा ना नावाचा, लोभ मोह तो कधी नसे. जीवन सफल सुबक साजिरे, जीवन सफल सुबक साजिरे, निर्मोही सेवेत असे. उदंड आयु तुम्हाला लाभू दे, आज तिनी प्रार्थना असे. आज तिनी प्रार्थना.
Thank you so much.
Thank you very much for being over here. And now I request Dr. Sanjay Gupte sir for formal introduction of Dr. Mrudula Phadke.
Namaste and good afternoon, madam.
Good afternoon to you.
It's great to have you here with all of us. Though you are on Zoom, it's like you are in the middle of us, definitely. Friends, last year we are very fortunate that we had none other than Dr. Mashelkar himself as the first orator of Asmita Gupte Oration. And everybody had really liked the talk and it had gone even viral and everything. So this time it was a real challenge to find somebody who is, equally eminent, equally scholar, equally, really academic, and so with after a lot of thinking, we could find nobody else than Dr. Mrudula Phadke. And as we know, she is the pioneer in genetics. And first I'll go through the formal introduction of Madam. For people, I'm sure 90% of us know all about her, but still, Dr. Phadke has been the first woman Vice Chancellor of the Maharashtra University of Health Sciences, Nasik. She has been a consultant to UNICEF and recipient of President of India Medal. Dr. Phadke has intense involvement in patient care, student teaching and research, and while working as professor of pediatrics, as all of our eminent students here can vouch. Her previous and a lot of things that she has done. She has been a member of Global Advisory Committee on Vaccine Safety, WHO Geneva, Senior Advisor, National Rural Health Mission, Ministry of Health, Government of India, Independent Director, Serum Institute of India, visiting scientist at Hopkins Institute, a former Director of Medical Education and Research, and so, she has been consultant to Melinda Gates Foundation. So, a lot of accolades to her credit. But what is important is she was the pioneer of genetics, and that's why most apt person to be here. We all heard when we were resident in Visa Medical College, the G of genetics was really taught to us by Phadke Madam. And personally, Madam, you would not remember, but the kind of a spark you had generated in me. I spoke on a talk. I gave a talk on genetics in POGS conference long back in, I think it was in 2001 or something. And Madam was at that time Dean of the Visa Medical College, and she was invited there as a chief guest. And when I spoke a little bit that time about cytogenetics and all, and in her presidential address, she had appreciated that, specifically saying that I really appreciate a gynecologist being aware of something about genetics. Yes. And that sort of lit a spark and got me interested in this field, and that's where we have come now. So, Madam, you really are the reason and cause leader for all this, the progress that we could make. Thank you so much, ma'am. Thank you.
Namaskar.
Madam, just before we start, somebody very close to you is there, and
yes.
I don't think it's a surprise to you, but Dr. Gambhir is here, and he would definitely like to speak a couple of words before we start your oration. Thank you, sir.
He has only made all my slides.
नाही, हे थोडंसं खोटं आहे. बरं, मी मराठीत बोलणार आहे, कारण मॅडम माझ्या अकॅडमिक मदर आहेत, आणि आईबद्दल बोलताना मराठीतच बोलणं, मातृभाषेत बोलणं हे नक्कीच मला जास्त सोपं जाईल. ऑब्व्हियसली म्हणजे इंग्लिश शब्द, हे थोडे इंग्लिश शब्द माझ्या भाषेमध्ये असतीलच. तर मॅडम, माझं नाव गंभीर आहे, पण थोडंसं विनोद पण मी करू शकतो, जरा दाखवून येतो लोकांना. मॅडम बद्दल काही जर का सांगायचं झालं मला, तर ते एखादं ओरेशनच असेल, तरी पण मी ते थोड्याशा वाक्यामध्ये, थोड्या शब्दांमध्ये मी सांगायचा प्रयत्न करणार आहे. मी माझं जन्मजन्मांतरीचं भाग्य समजतो की मॅडम मला माझ्या आयुष्यात आल्या, आणि मला त्यांचा सहवास, मार्गदर्शन, प्रेम आणि विद्यादान हे मागची जवळजवळ 45 वर्ष मिळाली. आणि अजून सुद्धा आम्हाला जर का दिवसातनं एकदा फोन नाही झाला तर आठवड्यातनं एकदा फोन नक्की होतो. आणि जशी आई मागे लागते अभ्यासाला, तशी मॅडम मला अजून माझ्या मागे लागतात की हे वाचलंस का, ते वाचलंस का, याच्याबद्दल तुला काय वाटतं, माझं मत विचारतात. आणि मॅडमचा मोठेपण आहे की त्या सगळ्या स्टुडंट्सना त्यांचं काय मत आहे केसेसबद्दल असं विचारतात. ते कशासाठी विचारतात मला माहिती आहे, की त्याला विद्यार्थ्यांना उद्युक्त करतात की त्यांनी स्वतः विचार करावा, काहीतरी शिकावं, काहीतरी स्वतः त्याच्यातनं त्यांना पुढे पेशंटला ट्रीटमेंट द्यायला त्यांना मदत होईल म्हणून. मॅडमच्या काही क्वालिटीज सांगताना एक महत्त्वाची क्वालिटी म्हणजे त्यांचं फॉरवर्ड लुकिंग विचार हे नेहमी असायचे. याची जर मी 2-3 उदाहरणं देतो, की मी जेव्हा रेसिडेन्सीला आलो तेव्हा आमच्या डिपार्टमेंटला ब्लड गॅस अॅनालायझर होतं. त्याच्यानंतर सोनोग्राफिक मशीन जे होतं ते बीजे मेडिकलमध्ये हे पहिल्यांदा पेडियाट्रिक्स डिपार्टमेंटला होतं. नंतर एक 4-5 वर्षानंतर ते रेडिओलॉजी डिपार्टमेंटला आलं. इथं कोणतं सोनोलॉजिस्ट मला माहीत नाही, पण सुरुवातीचे आणि बरेच सोनोलॉजिस्ट हे आमच्याकडे शिकलेले आहेत आमच्या डिपार्टमेंटला. HPLC मशीन हे कॉलेजमध्ये फक्त आमच्या डिपार्टमेंटला होतं, आणि मॅडमनी सगळी ही डिपार्टमेंटची हे जी यंत्र सामग्री होती ही वापरली, आणि ती जी वापरली ती त्यांनी रिसर्च ग्रँट्समधून मिळवली होती. हे त्यांचं विशेष आहे, कारण त्याचं फॉरवर्ड लुकिंग ॲटिट्यूड. आणि याच्यामधनं आम्ही शिकलो सर, जसं म्हणाल जेनेटिक्स आणि इथं एस्टॅब्लिश केलं. ते जेनेटिक्स नुसतं एस्टॅब्लिश नाही केलं तर ते फोफावलं, त्यांनी आम्हाला त्याच्यामध्ये रिसर्च करायला लावलं. आणि हे सगळं करताना मॅडमना एक त्यांचं अजून सांगायचं एक विशेष म्हणजे की मॅडमना त्यांनी त्यांच्या ऑफिसचं दार कधी बंद नाही ठेवलं. तर मॅडम मला सांगितलं, मला आठवतंय की मॅडम ज्या वेळेला प्रोफेसर झाले, हेड ऑफ द डिपार्टमेंट झाला, त्यावेळेला त्यांच्या वडिलांनी सांगितलं त्यांना की तू ऑफिसचं दार कधी बंद करू नको म्हणून. आणि नुसतं ऑफिसचं दार आम्हाला सगळ्यांना डॉक्टर्सना तिथं अप्रोच नसायचं, नर्सेसना अप्रोच नसायचं, विद्यार्थ्यांना अप्रोच नसायचं. तर मॅडमचं ऑफिस तुम्ही सासूमध्ये कधी आलं असेल तर बघितलं असेल की त्याच्या मागे पेडियाट्रिक्सची ओपीडी होती आणि पेडियाट्रिक्सच्या ओपीडीमध्ये सगळे गरीब असे निरक्षर लोक किंवा ज्यांना कमी हे माहिती असले लोक हे तिथं औषधं घ्यायचे आणि त्यांना फक्त एक अशी बाई दिसायची खिडकीमधनं, जी बसली खुर्चीवरती, त्यांची पाठ दिसायची. त्यांना तर माहीत नसायचं मॅडम हेड ऑफ द डिपार्टमेंट आहेत म्हणून. आणि त्या मॅडमनं विचारलं यायचं ते औषधं घेऊन, मॅडम ही औषधं कशी घ्यायची सांगा आम्हाला म्हणून. आणि मॅडम हेड ऑफ द डिपार्टमेंट असताना त्यांनी कधी कोणाला त्याचं, मी नाही सांगणार तुम्हाला असं कधी म्हटलं, मला तर माहित नाही म्हणजे. तर त्याच्यामुळे ह्या मॅडमच्या 2 क्वालिटीज आहेत की ज्याच्याबद्दल त्यांचा ह्युमन टच एवढा आहे की अजून सुद्धा जर का तुम्ही त्यांना एकदा भेटला असाल, तुम्ही त्यांच्या याच्या संपर्कामध्ये असाल, तर त्यांना तुमच्या मुलांची नावं त्यांना माहिती असतं. तर विचारत ही काय का सध्या करते, तो सध्या काय करतो, हे त्यांचं म्हणजे त्यांच्याकडे एन्सायक्लोपीडिया. मी ते ट्राय करायचा प्रयत्न केला पण मला काही ते जमलं नाही. तर त्यांची मेमरी जी एन्सायक्लोपीडिक आहे आणि ती सतत ती ऍक्टिव्ह असते. आणि अगदी आता थोडक्या शब्दामध्ये सांगतो की मी आता मणिपालला काल होतो आणि मणिपालला आमच्या लॅबचा बायोकेमिस्ट चेन्नईमधून आला होता, तो मराठी आहे, अनुप निळदारू म्हणून. तो काही दिवस बीजे मेडिकलला शिकायला होता अंडर ग्रॅज्युएट करिअरमध्ये. त्यांनी जी आठवण सांगितली ती सगळ्यांना आपल्याला एकदम अशी काहीतरी सांगून जाईल की मॅडम ना, तो मला म्हणाला की मॅडम डीन असताना सुद्धा आमचे लेक्चर घ्यायला यायचे. आपण बघतो की डीन किंवा असं कोणी मोठे मोठे पदावरती जातात त्यावेळेला ते लोकांना कधी अप्रोचेबल नसतं. आणि दुसरी गोष्ट त्यांची अकॅडमिक ऍक्टिव्हिटी ते सोडतात. मॅडम VC असताना त्यांना गोवारीकर म्हणाले, त्यांनी त्यांची सगळी टीचिंग डिपार्टमेंट युनिव्हर्सिटीमध्ये पहिल्यांदा चालू केली. त्याचप्रमाणे मॅडम पेशंट्स बघायला यायच्या, ओपीडीमध्ये यायच्या आणि विद्यार्थ्यांचं लेक्चर डीन असताना सुद्धा त्यांनी कधी नाकारलं नाही. ते त्यांनी चालू ठेवलं आणि ते सगळी त्यांना स्टिम्युलेटिंग लेक्चर्स असायचे. पुलं म्हणाले की या जगामध्ये पाय धरायला फार कमी व्यक्ती आता उरलेले आहेत. आपल्या सगळ्यांना पाय धरायला जी व्यक्तिमत्ता आपल्याकडे आहे त्यांना उदंड आयुष्य लाभो. त्यांनी असंच मला रोज फोन करावेत आणि मला जरा चिमटे काढावेत, म्हणजे मी पण जरा वाचत जाईल. एवढं बोलून म्हणजे मी मॅडमना विनंती करतो.
Thank you, sir.
Madam, we are eager to listen to you.
Yeah, thank you. You're Gitanjali?
Yes.
Yes. Honorable President of the IMA, present President, past President, and all the presidents of IMA, Dr. Asmita Gupte and Dr. Sanjay Gupte of the Gupte Memorial Oration, and all the very distinguished luminaries, chairpersons for today's function, Dr. Prakash Gambhir, Dr. Navarange, and all my very, very dear students. At the very outset, I am profusely thankful, in fact, overwhelmed by my introduction. I think nobody has ever told me that I have such qualities. I don't think you have described me. I am a simple person, like much worse than what all of you are today, and much worse than what you all have achieved. So having said this, I will start my little oration, not to match to anyone's oration, because Dr. Navarange already said, Madam, speak on genetics of the past. So I am really going to speak on genetics of the past. Can I have the first slide, please? I'm not seeing the slides. I'm not able to see my slides. I was able to see it some time back. Can somebody project the slides for me? Or can I have this? Slides कोणीतरी project करू शकेल? Dr. Asmita Gupte and Dr. Sanjay Gupte, Dr. Navarange, Dr. Gambhir, Dr. Meenakshi Deshpande, Dr. Pingle, Dr. Mangesh Pate, all of them have been one of the best students of the BJ Medical College, and now the doyens in their respective fields. They have taught generations of students, and there is so much to learn from them. I am indeed very thankful to Dr. Asmita Gupte. I remember her as Kishori Junnarkar and Dr. Sanjay Gupte. Thank you very much for giving me this opportunity. Can I have the next slide, please? Now, genetics. Everyone knows the science of heredity now has assumed so much and such a great importance. To an old timer like me, geneticist, what did I do? I thought genetics is like a loaded gun, that you have so many genetic diseases, you have so much of predisposition to many diseases, and the commonest diseases being the heart disease and the coronary artery disease and the type 2 diabetes. But I thought that this loaded gun of genetics needs one trigger, and that is the trigger of lifestyle. So if you want that the trigger is not pulled, then change your lifestyle today. But what does genetics mean to a common man? Dr. Gupte said it so beautifully in his lecture on infertility. But I thought that to a common man, genetics means only one thing: disputed paternity. The next two slides, please, in a row. Disputed paternity, you don't need a DNA test to find out that this probably is the father. And I think both of them holding the mobiles. So that's just to tell you that genetics for a common man is just disputed paternity. And sure, indeed enough, no DNA test needed if father and child are so similar to each other, as this funny slide is showing. The next slide, please. Before I begin, I express my sincere thanks to Dr. Kate, Dr. Prakash Gambir, Dr. Bankar, Dr. Khedkar, Dr. Mokashi, Dr. Bhate, Dr. Bulak, and all of you, all the patients and students of the BJ Medical College, the Genetic Department, Sassoon General Hospital. I learned only because of the mistakes that I made on the patients, and they pardoned me for it. Thank you so much. Next slide, please. To a common person and to geneticists, to a physician, to a pediatrician, and to all of us, the commonest genetic disorder that we see often is Down syndrome, with an incidence of 1 in 600 births. Pediatricians still see Down syndrome once a month, one case, and you don't need rocket science to diagnose a child of Down syndrome. Trisomy 21, 47 chromosomes. This little lovely little child with all the features of Down syndrome, the face is staggeringly similar for all children of Down syndrome. But the next slide, please. But I learned to diagnose Down syndrome when Dr. Shirole, late Dr. Shirole and late Dr. Ajay Joshi, a child was brought, a neonate was brought to the pediatric department, and the neonate was all bundled up. Only his hand was coming out, and the hand was hanging, and little toe and the feet and little part of the toes was coming out. And Dr. Shirole said, what is wrong with this child? We were all stumped. And he said, don't you think, looking at the hand of the child, he said, don't you think this child has Down syndrome? We were surprised. What did the child have? A single palmar crease, what we call as a simian crease running across the palm, and increased distance between the first and the second toe. Added to that, compounded to that, was the hand of the child which was dangling out. That means the hand was very hypotonic. These three features made him make a diagnosis, and we were all stumped. That was the clinical diagnosis of Down syndrome. And I feel that still our new generation should think that they will be able to diagnose children who are brought in blanketed and totally curled up. Can I have the next slide? So you can see the face of the child, and you have the classical features as you saw just now. The epicanthic folds, the downturned eyes that we call as mongoloid slant, no more called as mongoloid. So downturned eyes, nystagmus, brush field spots, cataract, soft, very soft ear cartilages, hypotonia, simian crease, and the little finger, which is totally inturned, what we call as clinodactyly, and single crease even on the little finger. These children have brachycephalic small heads, and they obviously may have congenital heart disease, GI abnormalities, and they have developmental delay. Now we no more can call it as mental subnormality. We have to call these children as Divyang children. So these are the clinical features which I think were there yesterday, they'll be there today, and they will be there tomorrow. But we have to have the eye of Sherlock Holmes to diagnose them. So to the younger audience, please remember that diagnosis of Down syndrome, trisomy 21, is today by and large clinical and will remain so. The next slide, please. Tomorrow, what are we going to do? And in some centers, even today, you will see that an older mother, we would say, or at the moment, I should say, every woman who has just conceived should be offered Down syndrome screening. 30, 40 years ago, we used to say that it occurs at 35 years and beyond in the Western world. And in India, we thought that Down syndrome occurs at 28 and 27 years of age to the mother. And obviously, because Indian mothers produce children at a much younger age, we still don't know, but it's a fact that Down syndrome does occur at younger age group in India. And therefore, needless to say that with high-fi genetic tests, it's important that we try to diagnose Down syndrome right in the antenatal period. And what can we do for it? In all the centers in Pune probably, and some centers all over Maharashtra and few centers in India, second trimester Down syndrome screening is possible. And that is done by maternal blood. You do the beta HCG, you do unconjugated estriol, you do alpha protein and inhibin studies. These are done regularly in many centers in Pune. And with 80% accuracy, you can kind of think whether the child is going to be Down syndrome. But what does this 80% accuracy do? You do the mother's test, you do the screening, and you increase the anxiety of the mother because 20% chance that the baby may not be Down syndrome. So we went further ahead, and now even first trimester Down syndrome screening is done. And most important is the ultrasound machine. So you will try and see nuchal translucency. And if the nuchal translucency is there and nuchal fold is thicker than normal, obviously due to the hypotonia, the child's neck is a little extended. And then you do blood test, that is the PAP-ACE test. So if first trimester screening is done, number one, by nuchal translucency on ultrasound, beta HCG, and PAP-ACE screening, you will be able to diagnose Down syndrome 95% of the times. But then we have to go further ahead, even that 5% should stop. And therefore, detection of fetal DNA in the maternal blood, which all the previous speakers so beautifully said, non-invasive screening test, and it gives you 98% accuracy. The next slide, please. This is the, no, there are two more slides in between. Yes. So then what you can do is using a next generation sequencer machine, you're going to do all the tests and non-invasive tests on the blood can be done. The next slide, please. This is the next generation DNA sequencing, 98% accuracy for detection of all chromosomal disorders. Can we go to the next slide, please? Which are the other chromosomal disorders that need a mention? Downs is one we have said, but one must also be able to diagnose trisomy 13, and trisomy 8. Point to tell here that deep palmar crease in a mentally retarded child, besides Downs, you are going to think that the child could have trisomy 18, and that's going to make the diagnosis different but easier for you. Turner syndrome, earlier speakers spoke so much about you. Amenorrhea and all we can detect easily by doing chromosomal studies, one of the common syndromes. I would like to mention on Fragile X, particularly common in males, and they have large testes, large ears, and mental subnormality. And ironically enough, they are a little subfertile. And therefore, a clinical diagnosis of Fragile X syndrome should be made first and followed by genetic diagnosis, but particularly cytogenetic diagnosis. Any patient with odd faces, we called in those days FLKs, funny looking child. Now child is not called like that because it is body shaming. And therefore, let us all use the word, not even developmental delay, but we should say that this is a Divyang child, and forget about his odd faces. You look at them, but do not mention them. And of course, children with many cardiovascular, gastrointestinal abnormalities, hair, lip, cleft palate, as seen in trisomy 13. And a good high index of suspicion goes a long way. So diagnosis by clinical means is important. The next slide, please. Single gene disorders, after chromosomal disorders, we know it too well. a child with a thalassemic face, malar prominence, low nasal bridge, little icteric tinge, teeth which are protruding out, and obviously with hepatosplenomegaly, you don't have to think, but it is nothing but thalassemia major. The next slide, please. And in our genetic clinic, we had a number of children who came for thalassemia major, to the extent that one child, in those days, bone marrow transplant was not available. Now it is available, and that's the genetics of tomorrow. One can not only do a bone marrow transplant, but even gene therapy is possible for many genetic disorders. But in those days, we did not have the facility. Only bone marrow was available in some countries abroad. And therefore, we were resorting to counseling, and we were trying to tell the recurrence risk to the parents. And the father of this thalassemic child actually stumped us totally. We told him recurrence risk 25%, you and your wife are carriers. And as Dr. Gupte rightly said in his talk, the father married another person who was not a carrier and produced a child who was a normal child. And the normal child then gave bone marrow grafting to the baby who was a thalassemia patient. So I would insist here that whenever you are doing counseling, I spoke the truth 40 years ago, telling that you are a carrier. Not that I don't speak the truth now, but that time I was frank enough telling him that both of you are carriers. And so this is what is going to be the recurrence risk. Please remember, counseling has to be non-directional, and it is the parent's choice that is supreme. The next slide, please. So this is what genetics is going to remain today and tomorrow. Pedigree analysis, most of us forget all the time. So before doing a counseling, before doing a diagnosis, one must do a pedigree analysis, draw a beautiful pedigree, thereby showing the proband who is a sufferer and all the people who are carriers with the dots. And this is especially important for inborn errors of metabolism that you learned this morning, wherein we know that majority of them are transmitted as recessive traits. The next slide, please. So what do we see? What is the future of single gene disorders for us? Prevention of single gene disorders by avoiding consanguineous marriages, something very simple to practice, but very, very difficult. Thalassemia has been eradicated in Cyprus, but we are unable to do thalassemia screening, and particularly carrier screening for young girls or young boys is still not possible. And there is a social element in it. Girls who face difficulty in getting married even today and who are given so much of substandard treatment, if you do carrier screening and detect a girl as thalassemia, that girl as thalassemia carrier, that girl may not be able to get married. So if at all carrier screening is to be done, my advice to this August gathering is, please do carrier screening, but do them on the boys first. And then boys who are carriers may not marry a carrier girl at the time of her marriage. I will tell you a lovely story of sickle cell anemia and carrier state. In tribals where we used to work along with Dr. Kate, he devised a simple method, what he called as tattooing method, because tribals tattoo on their hand devs, what are called as gods. They have 5 gods. And Dr. Kate would tattoo a sickle cell, tattooing of a sickle cell on the patient who was found to be sickle cell trait and who came sometimes with thrombotic or other kinds of crisis. And these children were screened. So Dr. Kate did a lot of community screening. He still does it at his age of 85. And he puts all tribals into tattooed tribals or non-tattooed tribals, thereby meaning an easy way of detecting a carrier in tribals. Let us at least do some carrier screening in our population. And then, of course, prenatal diagnosis, which is getting advanced as the days go by. And then enzyme replacement therapy, especially for inborn errors of metabolism. Can I have the next slide, please? And what do we see in this next slide? We talk on not only single gene disorders, but we talk on genetics of common diseases, polygenic multifactorial diseases. Most of us know coronary artery disease, type 2 diabetes, hair, lip, cleft palate, congenital hip dysplasia for the orthopedicians in this gathering. And we know that their inheritance is very, very complex. And so we need to know about the role of environment. It's not only the genes that are important, but it is your environment. And environment has many, many factors. And one of the factors there, besides your environment, like the air that you are breathing, is nutrition. And rightly so, you had a lecture on nutrition. The next slide, please. And what do we see on nutrition? All of us know that as diabetics and as coronary artery disease, it is the nutrition that's important. But what is it in the nutrition? The nutrigenomics. Effect of nutrition on genes and effect of genes on nutrition. Most important is the gene for lactose intolerance. Most of us who have lactose intolerance have acquired lactose intolerance. We get it as we grow by in age. Our enzyme, lactase enzyme, becomes lesser and lesser, but that is acquired lactose intolerance. There is an entity called as congenital lactose intolerance, where from birth the child is sensitive to lactose. Treatment is very simple. You have to give lactose-free diet, milk-free diet, and substitute enzymes wherever possible. The same thing is for a rare disorder like phenylketonuria, again an inborn error of metabolism, genetically transmitted. Parents carrier, and phenylalanine accumulates in the blood only because the enzyme phenylalanine hydroxylase is deficient. And because phenylalanine accumulates in the blood, the patient gets mental retardation, may get convulsions, may get seborrheitis. We detected one case of phenylketonuria only by seeing severe seborrheic skin that the child had, little fairish complexion, and the child was mentally subnormal. We got his phenylalanine done in those days from the National Chemical Laboratory, and the child was put on a special diet. So if that is possible in those days, why not we do all the therapies and all that is available for us? So phenylketonuria is another disorder governed totally by genes, and a simple dietary treatment of low phenylalanine diet, not absent phenylalanine diet, low phenylalanine restricted diet may be good for patients who have inborn error of metabolism, phenylketonuria. The same is true for galactosemia. Can I have the next slide, please? And then we move on from there to diseases wherein good amount of food is going to help to the patient. So genes that are responsible for altering your nutrition, and now the nutrition, which is going to see what is happening. The classical polygenic multifactorial disease, type 2 diabetes. Genes make variable contribution. Obesity is a major risk factor in type 2 diabetes. And how to detect it? By quantitative trait locus analysis. You can also do single nucleotide polymorphism, and you can detect and find out how much is the insulin resistance. And when you do SNPs or SNPs, the single nucleotide polymorphism is a good genetic marker. It is a good linkage analysis to tell you whether you inherit the genes for getting type 2 diabetes. And needless to say that there are 600 gene markers obesity governs. So if you are obese, well, you already have 600 genetic markers. And therefore, I think it is extremely difficult to find out. And the linkage analysis only is going to tell. The future of genetics lies here. When you are born, if you know that you have 98% predisposition to type 2 diabetes, well, the matter could be a bit simple. Can I have the next slide, please? And the same thing holds true for coronary artery disease, is the genes and the environment. So obesity, well, we are going to control, we know it too well, but how are we going to manage the HDL, LDL, and the VLDL? HDL, the protective high density lipoprotein, and LDL and the VLDL are the bad low density lipoproteins. Well, everybody who's a little obese has a genetic predisposition. You just prescribe. There are lots of physicians here. So with the highest regards, statins are prescribed. And statins, what do? They inhibit hepatic 3-hydroxy-3-methyl glutaric coenzyme reductase. And therefore, they decrease the circulating cholesterol. Simple methodology: take statins and then eat what you want. It's not so simple as that, because we know that there are several candidate genes which are known, which predispose us to cardiovascular diseases. The cholesterol ester transfer protein, the lipoprotein lipase, the hepatic triglyceride lipase, the apolipoproteins, and the lecithin cholesterol transferase. All these can be identified today and will be identified in every sense of the word tomorrow. And if you do SNPs, you'll be able to identify, and you do your gene sequencing, you know that if you have deficiency or absence of any of these enzymes, then what do we have? Then the treatment probably is simpler. The next slide, please. How treatment is simple? Well, there is a gene diet interaction, which we know. and coronary artery disease, malignancy as well. And when you are born with such genes which are predisposing you to coronary artery disease, well, this beautiful pre-lunch slide of 50 samosas, you're going to say no, no, no to these samosas. If you have all the genes to produce inheritance of coronary artery disease. So it's true for malignancy. You all learnt about the BRCA gene 10 minutes ago. Well, take vitamins, take antioxidants, and maybe control your obesity, hormonal regulation, and you may conquer not only diabetes, not only coronary artery disease, but malignancy. I'm still using the word may because I don't know what is stored for us tomorrow. The next slide, please. What is stored for us tomorrow? It is only epigenetics and diet. Epi is above. So we are talking on genetics, but I want to tell you something on epigenetics. Epi is above, and it is temporarily activating or repressing our gene expression. Means your genes are there, but whether they get switched on or they get switched off depends on your epigenetics. And therefore, it's the change in the gene expression without actual change in your DNA sequence. So your DNA sequence the same, born with the same gene, but it is in your hands to alter your epigenetics, and you can change your gene expression. And how do you change that? This gene expression can be changed by 3 or 4 factors, which we are going to tell you. But it's rather dismaying, and I do not know why it occurs. But once an epigenetic change occurs, then it gets passed from generation to generation. So epigenetic change that occurs often gets transmitted intergenerationally. So see how beautiful is epigenetics, that the genetic change occurs. Your DNA remains the same, but the expression of the gene is altered, and then it gets transferred. In 1940s, there was severe hunger in Europe. It was called as the Dutch hunger epidemic. And what happened? All the grandmothers of those times could not get enough food. And they produced mothers whose ova were already deprived of nutrition, and they produced children who had mental issues, who were malnourished, and who had so many other problems. The example that I am giving is old-time actress Audrey Hepburn, who was produced like this in Dutch hunger, and it was her grandmother who was responsible for all this. So I might say that if you have any problems, it is very easy. Blame it on your grandmother, and for the males in this audience, mail it straight away on mother-in-law, and the problem is sorted out. So that's epigenetics and diet. We'll go further. Next slide, please. And what does it show to us? A simple slide. You can see the chromosome on the right-hand side. You can see the compact chromatin in the middle. You can see a chromatin that is getting tails. And there are 3 things that happen in epigenetics. The first one is what is called as DNA methylation. The second one is histone acetylation. And the third one is RNA regulation. So these are the simple 3 things that are going to genetically alter our DNA. And can we go to the next slide? And the next slide, the courtesy of this slide, the first slide is on DNA methylation. Simple, add 1 methyl group to the cytosine of the DNA. And this is critical. And what happens when you add this methyl group? How do you add the methyl group? Folic acid is a methyl group donor. So you give folic acid to the patient, either in the form of folate in the diet or folic acid tablet, and all the neural tube defects are prevented. Dr. Meenakshi talked so well on folic acid and preconceptional giving of folic acid, and also that all neural tube defects are prevented. Also preconceptional multiple micronutrient supplementation, not only folic acid, along with it give B12, Dr. Yadnik's hypothesis. How many mothers are getting preconceptional folic acid? Not even 3% of the mothers. And in villages in Maharashtra, one survey found that it was only 0.0003% of the adolescent girls got folic acid in the antenatal period and in the preconceptional period. I think folic acid plays a great role, not only in the neural tube defect prevention, but it plays another important role, and that is on imprinting, which we are going to discuss shortly. So DNA methylation, an important epigenetic mechanism which is going to govern so many things. This DNA methylation is going to improve birth weight of children in our country. 20% of the babies that are born, pediatricians and neonatologists, bread and butter, that they are born low in weight. And if you want to stop this, it is extremely simple to produce a child with good folic acid given to the mother, and the baby is born not only without neural tube defects, but the baby is born good in weight. And having a good weight is going to take the physicians, maybe the physicians will feel that we are controlling hypertension, we are controlling coronary artery disease, because if you're born low in weight and you develop obesity in later life after 20s and 30s, you are more prone to getting high blood pressure, diabetes, coronary artery disease, the classical Barker's hypothesis, and the developmental origin of adult diseases, and that is the Dohad hypothesis and Dr. Yadnik's theory. So I believe that DNA methylation is the crux of the matter and a simple dietary alteration, and we are going to produce good weight babies, and maybe we'll be able to decrease the number of hypertensive and coronary artery disease patients. The next epigenetic modification, the next slide, please. What do we see in the next slide? The next slide, please, is you have histone acetylation. And simple enough, what does this histone acetylation do? Dr. Gambhir described it very beautifully to me. The chromatin and the condensed chromosomal structure, as we see, is like a thick wool. And when you are going to knit it with knitting needles, the needles are going to be your epigenetic modification. And then what the final product through the tail of the wool that you are going to get, a knitted sweater, may it be a sweater or may it be a cardigan, or may it be any other structure that you're knitting like a coat. And so the coat is like your altered epigenetic phenomenon. And this histone acetylation performs the role of your knitting needles, and that is, it loosens the DNA. So you can see in the next slide shows how the DNA has got loosened. And how does it get loosened? Histone acetylation does only two things. The lysine is altered because lysine has an NH2 group, and therefore normally the lysine is positively charged. Our DNA is negatively charged, and therefore the two are tightly bound. And if the two are tightly bound, the gene does not express itself. The DNA does not express itself. But when it gets opened by histone acetylation, the gene expresses. And the next slide, please. And when the gene expresses, the gene gets loosened, as you can see. And this is an important aspect of epigenetic phenomenon, which is the causative factor for all the diseases. So I believe that today epigenetics is the future of genetics. The next slide, please. And what do we have next? When this histone acetylation balance gets disrupted, what do we mean by that? That the spine balance between histone acetylation and histone deacetylation, two enzymes, HAT and HDAC. Deacetylation enzyme is HDAC. And when the balance is disrupted, many diseases occur. One of them is neurodegenerative disease like Alzheimer's. So if you want Alzheimer's to not to occur in you, the next slide, please. What do we do? Anyway, Huntington's chorea, major part of it is dominantly inherited, but some part of it is due to acetylation. Histone acetylation can prevent many things. Histone acetylation can prevent Alzheimer's disease. Histone acetylation can prevent atherosclerosis. And how does it prevent atherosclerosis? So just loosening of your DNA, just loosening of the chromatin work, and all that is going to prevent atherosclerosis, because we know that in atherosclerosis, the low density lipoprotein levels are increased. And we also know that pro-inflammatory cytokines, and there is a vascular endothelial damage. Now, LDL plaques have to go and sit there in the vascular endothelium, and histone acetylation triggers this process. So if there is histone acetylation and you find that there are plaque formations, imagine that the cytokines and the vascular endothelial damage has occurred because your histone acetylation and deacetylation balance is gone. And what does this balance go with? The balance goes if you don't have sulforaphanes in your diet, which are present in broccoli, which are present in cabbage. Most children hate to have cabbage as a vegetable. Imagine that this sulforaphane, which is present in cabbage, is going to prevent atherosclerosis and coronary artery disease in low density in older age group. And the same is true with butyrate, that low density lipoproteins are going to, even if they are there, the damage will not be done if histone acetylation is good. So the long and short of it is, eat lots of broccoli if you can afford it. Otherwise, at least have cabbage and lots of curcumin, for which Dr. Mashalkar had got patent. And for us as clinicians and as physicians to remember, is your balance of HAT and HDAC is important. And tomorrow's genetics lies in this, that you are going to tell your little baby that wait, I'm going to estimate your HAT and HDAC, and then tell you what you're going to suffer later on. The next slide, please. And this tells you the balance between the two. And we know that this occurs due to either gene suppression or gene expression. And the balance between the two, if it is lost, we are going to get the diseases. The next slide, please. And this is, of course, aging and epigenetic process. You know that cancer and folate and the metabolism of regulation is too well known. Can we have the next slide? And in the next 5 minutes, we are going to talk a little bit on personalized medicine. If there is time, please pardon me. You can, organizers can tell me when to stop. We want a little bit on personalized medicine. Individualized or precision medicine is important, and that's going to be the future of genetics of tomorrow. Diagnosis, treatment is decided by the, not only by the epigenetic modification, but by the genetic information of the patient. And you will tailor your medicine, the Ayurveda philosophy of life, that medicine is tailored for individual patient. The same size that fits Kareena Kapoor does not fit Madhuri Dixit. So one size fit all concept is gone, and it is going away. So we can have epigenetic modification and personalized medicine. The next slide, please. And this personalized medicine is that you're going to decide on the genetic profile of the patient, not just the weight, age, and sex of the patient, but you can find out whether the drug is likely to have benefit to the patient or it is going to do harm to the patient. And how can we do that? The next slide, please. Personalized medicine today, I owe all this to Dr. Nilima Kshirsagar. Lot of genetic and pharmacogenomic work is done by them, and it is to detect gene-based variation in drug response. And there are 15 to 30% of all our individuals have a lot of variation, and drug metabolism changes, and particularly the cytochrome 450 enzyme in the liver changes because 57 genes encode for cytochrome 450. So if you have abnormality in any of those, simple enough, you become a poor metabolite of a particular drug, and the patient will have a lot of toxicity because the drug is remaining in the blood. And if you are ultra fast metabolizer, well, the drug is going to get lost from the body, and the patient may not get the desired effect. Classical examples are warfarin, and the other example is phenytoin sodium, the dilantin that we have used. Patients who are fast acetylators, they don't show the effect of the drug, and slow acetylators have more toxicity, and therefore one has to be extremely careful. INH is another one, and slow metabolizers, we have often seen that such patients, the toxicities occur more, particularly in adults. The next slide, please. And now I come to one small thing. Well, we all know drugs and genotyping. We all know that many drugs which are onco or which are cancer drugs, they have been useful in particular ways. And that is one of the drugs used for chronic myeloid leukemia works only when you have the Philadelphia chromosome. And that Philadelphia chromosome, if it is mutated and the kinase enzyme is deficient, then only the drug imatinib acts. So that's about drug metabolism, the pharmacology. We'll not go into the oncology aspect of it. But the next slide, please. I want to mention about one drug. Other important drugs, you know, phenytoin, slow metabolizers, rapid metabolizers, INH. The next slide, please. And then we come to COVID has just gone. And you remember what all drugs we gave in COVID. And I will give you a classical example. One of the examples was every patient, all of us prescribed one AZI and second hydroxychloroquine or chloroquine. Some prescribed even erythrocine. And any patient who came with fever, then a prescription of 9 drugs was given, and 2 of them were chloroquine and azithromycin, thinking that if it is COVID, the patients will improve. And what happened? Well, we don't know whether they improved or not, or whether they improved on their own. But 2 patients, one in Lucknow and one in down south, one of them got severe arrhythmia, and second one, I believe he actually died. I don't have enough actual details of that patient. But what must have happened to them? We are aware of the fact, physicians particularly in this gathering, that there is something called as long QT interval syndrome, wherein the ECG of the patient shows a prolonged QT interval. And this can be achieved by 2 means, or you can get it by 2 means. One of them is a congenital long QT syndrome, congenital long QT interval prolongation syndrome. And the second one is acquired. How do you get acquired? Simple enough. If your potassium level drops, you get acquired QT interval syndrome. But you can also have acquired QT interval syndrome prolongation by 2-3 important drugs. One of them is azithromycin. Second one is hydroxychloroquine. The third one is fluoroquinolones. The fourth one is even ceftriaxone sodium and bedaquiline given now for tuberculosis. All these drugs in some patients, in a few patients, can produce prolongation of the QT interval, which is governed by 3 major and 10 minor genes. And the defect is only in repolarization of the cardiac muscle. And it is this, that sodium and the potassium gating, that has occurred, and the channels have opened, and therefore repolarization does not occur. And long QT interval syndrome is probably one of the greatest things that we are going to think in tomorrow's medicine. And the patient can get Torsades de Pointes syndrome, and patients can drop dead. So our genetics of tomorrow is going to be lots of pharmacogenetics, and we will like to study. Today, I can't tell you how much of the long QT interval is due to drugs and how much of it is congenital. But tomorrow, sure enough, that's going to be known. And that is the genetics of the future, the pharmacogenetics. The next slide, please. Can I have the next slide? And that's your marking of the genome. And that's personalized medicine. The next slide. By single nucleotide polymorphism, many of these can be detected, and SNPs are just small DNA blocks of nucleotides, and they occur in 1% of the population, and they occur between genes. So SNPs themselves don't produce any disease, but their presence can help you as a linkage marker, and we have 600 million SNPs. So the genetics of the future is going to be the biological markers of SNPs. And they will tell you whether you're going to get Alzheimer's, whether you're going to get schizophrenia or coronary artery disease, or for that matter, every possible disease. The next slide, please. Now, in the next 10 minutes, ARMS PCR and all the genetic tests were discussed so nicely. The fluorescent dye detection, the fish technique, all of you saw it, the microarrays and the next generation sequencing. The next slide, please. So all this is going to diagnose patients, but I am going to, in the next 5 minutes before I close, I'm going to give you a new concept, which I think is going to assume lot of importance, and that is genetics of tomorrow, at least, well, for the place where I am working now, and that is in the interiors of Maharashtra, in Nandurbar and Usmanabad, and that is low protein diet given to the mother. The commonest thing, our mothers have a BMI hardly of 17 or 16.5 sometimes. The girl has just got married, goes to her in-laws' place and eats as the last person in the house to eat. One wonders how much of proteins and calories she's going to get. Leave aside the folic acid and the green vegetables. And this low protein diet, it has been shown by enough of evidence now, low protein diet is going to induce low insulin, low branch chain amino acids in the Graafian follicle of the going to be mother, and the blastocyst. The low protein diet is going to affect the blastocyst. It's going to affect the uterine fluid. And what is the result? The result is poor implantation of the zygote. The result is poor placenta formation. The result is poor fetal growth trajectory. And therefore, the baby to be born is going to be low birth weight. And the effect is immensely seen when it occurs in the first trimester. So we all really think every time about the second and the third trimester in the antenatal period. But I believe the crux of the matter lies in the first trimester, and maternal low protein diet is a good evidence that we have. And therefore, it's important to know that give food to the mother and see that the fathers not clear enough, but obese fathers, sperm quality poor, Dr. Gupte has already told, and the DNA integrity is lost along with the integrity of the father if some odd and vices things are done. So I would think, but fathers are not so responsible. It is the diet of the mother which is much more responsible, and we should look after it. The next slide, please. And then what do we have? New concept. Why are we going to focus on the adolescent girls? The UNICEF theory today, Rajalakshmi Nair, is to focus on the adolescent girl, to focus on her ovum formation, and you will see that the fetal growth improves. What do I mean by that? We know that growth of the fetus or growth of the zygote or the embryo that is formed is dependent on one important enzyme, and that is IGF-2, the insulin-like growth factor 2. Insulin-like growth factor 1 is responsible for growth of the human being after birth, but it is the IGF-2 that is responsible. It is the growth factor that works before birth. So the growth of the baby is dependent on IGF-2 and IGF-2R, that is the receptor. So the receptor IGF-2R and IGF-2 govern the growth of the baby in the first 9 intrauterine months. And what is the beauty of this IGF, this growth factor? That the genes for IGF-2, both the genes are imprinted. And what do we mean by imprinted genes? That these imprinted genes are expressed, only one gene is active. So if they are paternally expressed, it is good. But if both genes are active, means both genes are imprinted, or if there is a failure of imprinting, then the mother's gene is also activated and the father's gene is also activated. And then there lies the problem. So gene expression of IGF-2 is dependent on which gene has got activated. And can we go to the next slide? The next slide, please. And there is a wonderful paper, no, not this, previous one, previous slide, please, which has come in Neuroscience News, the Cambridge study by Sandovici, which came in December 2021's journal. And it said that paternal IGF-2 gene is the gene in the fetus, which is responsible for the growth of the placenta and the blood vessels. And if the maternal gene has got activated, that means IGF-2 in the mother has got activated, then the blood vessels in the placenta become smaller, they become thinner. Obviously, the mother has a competition with the baby for survival. And therefore, when the mother's gene is active, the placenta is naturally going to be small. The baby's birth weight is going to be low. And this happens only when there is what we call as failure of imprinting. If imprinting is good, only one gene is active, paternal gene is active, baby's birth weight is excellent. But if there is failure of imprinting, the maternal gene, the mother's gene also in the baby starts active. And this imprinting produces a low birth weight child. What does imprinting depend on? Imprinting depends on one mechanism, and that is methylation. We spoke about epigenetics 15 minutes ago, and imprinting depends on methylation. So if the methylation is good, imprinting is good. But if the methylation is bad, there is imprinting failure. And what does methylation depend upon? It depends only on folic acid, and folic acid. So give folic acid to the adolescent girl, give folic acid right from periconceptional period and from the 5th intrauterine period right later on. Well, you will at least do one good thing, and that is the imprinting of genes, the methylation of genes will be good. And one of the genes is going to be insulin-like growth factor 2. And I believe there lies the future of genetics, at least for me as a pediatrician, and I'm sure to many of the gynecologists. Can I have the next slide, please? And therefore, we conclude that genetics of tomorrow, before I conclude, will I only tell you that future husband, or let me say future partner, saying to his wife or girlfriend, honey, so nice, we got a designer baby, and the bar-coded baby also is born. So today, even bar-coded baby of tomorrow is going to be born with the entire genome located. But the future for India, the next and the last slide, please. Thanking all of you for a very patient listening, I only conclude by saying that there is no substitute for clinical diagnosis in genetics. If you miss a Down syndrome by not looking at the hand and the face of the child, the boat is missed. So there is no substitute for good clinical diagnosis. Many newer investigations are coming. So good laboratories, wishing all the best for all the new laboratories are coming. They are getting better and better. Non-invasive methods are coming through, and therefore the mother's blood can be taken for many diseases, not just 50, but maybe hundreds of genetic diseases. And the accuracy is going to increase and increase and increase. So 100% accuracy in prenatal diagnosis. And we are going to get designer babies. I wonder whether the romance in life will go away, but maybe not. And therefore, for India, what do we have? For our country, still for the next 20 years, we have to look after the adolescent girl and see that her health is good. You're giving her good protein diet, good folic acid. And may I at least pray to this audience that girls in my country, girls in Maharashtra, will be eating along with the male folks in the house and not eat at the last in the families that they are living. Thank you very much. Thank you so much. My personal thanks to all my students. I would like to see each one of them personally and pay my greatest respects for being such good doctors and serving the society. Thank you so much.
Thank you, madam. Mike. Thank you, madam. Thank you. Mike नाही चालत.
Thank you, ma'am, for that wonderful oration. You did absolute justice to the topic and showed us the window, not only from the past instances, but the window to the future, and the message that you gave, that not only the investigations, but the clinical diagnosis is so important, and what we all need to do to improve the situation in our own country. Thank you again. We did miss you here, but you made it up for, with a wonderful oration that you have given. We hope to see you here sometime in Pune and in this all in persons for more and more such teachings from you. Thank you so much, ma'am.
My heartfelt thanks to all of you. Thank you so much.
Thank you, madam. We are now request Asmita madam to come on to the dais. Sanjay Gupte sir, all the felicitation. लाईट बंद लाईट बंद ओके आपल्याला त्यांना दिसतं ते इकडे त्या बाजूने कॅमेरा समोर तुम्ही अनाउन्समेंट करा Madam, Dr. Gupte sir, Dr. Navarange sir, our president, Dr. Raju Varyani sir, Dr. Gambhir sir, they are felicitating you, madam. शाल आहे आपल्याला दिसतेय का?
मला शाल दिसतेय. ससून हॉस्पिटल मधल्या पहिल्या गर्ल चाइल्डला उद्या ती देऊ शकाल का आपण माझ्या वतीने? थँक्यू सो मच. थँक्यू.
जरूर मॅडम. हा, मी अस्मिता गुप्ते मॅडमना विनंती करते. नाही, तिथे आपण कॅमेरा आणू मॅडम. मॅडम कॅमेरा जरा मी हे करणार आहे.
Dr. Asmita Gupte, madam, all the very best for all your great ventures and all the nice things that you are doing. Both Dr. Gupte, Dr. Sanjay Gupte, and Dr. Asmita Gupte, madam. Thank you. And Dr. Gambhir and Dr. Navarange, thanks for bearing with me so patiently.
Madam, this clerk says on behalf of IMA Pune, Gupte Hospital and Greenarray Genomic Research Solutions, it is our great pleasure and privilege to honor you, Professor Dr. Mrudula Phadke, former Vice Chancellor of MUHS, Senior Advisor to Government of Maharashtra and Consultant UNICEF on Child Care, for delivering the second IMA Pune Dr.Asmita Gupte Oration on genetic insights, the theme genetic insights and past, future, present and future of genetics. Thank you so much, madam, for your wonderful excellent work.
खूप आभारी आहे. धन्यवाद. And my greatest blessings to all of you.
Thank you, ma'am.
Thank you, ma'am. Thank you for spending time.
Thank you, madam, for a memorable oration. It will be remembered for a long time to come. Thank you, madam. You have sparked the genetics, genomics ignition. You have sparked this audience. Thank you, madam.
Thank you. Very practical solution to great excellence.
लास्ट वर्ड सांगायला सांगितलं तर त्याची युनिक गोष्ट सांगतो की आपल्याकडे पितृ पंधरवडा चालू आहे आणि व्हॉट इज पितृ पंधरवडा इज सेलिब्रेशन ऑफ जेनेटिक्स सो because these genes have been handed over from going generation, and that is the future of mankind, and above all this is the epigenetics, that is our lifestyle. So we have to be very careful in how we handle the genes that have been handed, which we have inherited, and what we are going to actually we are passed on to the next generation. So we have to handle them very carefully. So that is the message that madam has given us to her talk, and so that is the celebration of genetics. So whatever the inheritance of knowledge that you have given us, madam, will carry to the future. Thank you.
Thank you so much. Thank you so much.
Thank you, madam. You all can sit. May I now request Dr. Kedar Patil, the secretary, for the vote of thanks.
We are indeed privileged today to have a notable dignitary delivering the Gupte Oration today. Thank you, Dr. Mrudula Phadke, madam, for the, it was a recap of our medical knowledge from 12th standard, starting with genetics, coming to applied pediatrics and day-to-day use and future of genetics. Madam has covered it very well. Thank you. We are indeed privileged to have Gupte Hospital and Asmita Gupte Madam Oration. Last year, it was delivered by Dr. Raghunath Mashelkar, who showed some wonderful innovations that are going on in medical field. And we are privileged to continue with this oration, getting great speakers who add value to IMA Pune. Thank you, sir. We are thankful to Gupte Hospital, Greenarray Labs for making this possible. Also, there have been great inputs and efforts by the IMA team comprising of the trustees, office bearers, managing committee, and of course, you people coming in big numbers, the delegates and senior members coming for this program, add value to this program. I thank you all sincerely for making this possible, and also our IMA staff who's been working for this program. With this, I thank you all, respected chairpersons, dignitaries. We break for lunch now. Lunch is being served on the ground floor and at the boardroom for the dignitaries. Thank you all.
I wish to also thank Dr. Diwakar sir, who has come all the way from Bangalore. Thank you, sir, for joining us today, and all the chairpersons who did a wonderful work. Thank you very much. I request all the managing committee members to come on the stage for a quick photo, please. Submit.
Join us at what there is a company.
We will join that for the post-lunch session sharp at 2
Felicitation to Dr. Gambhir.
I request Gupte sir and Dr. Varyani sir and Navarange sir, please be over here. You felicitate Dr. Gambhir.
आपण जी चालू करायची पलीकडचे खाली करायचे पहिले तसं चिकन
पहले ऋतु पर नहीं सुन देगा अतुलला सांगायला पाहिजे कंप्लेंट करू आपण तर अतुलला फक्त सांगून टाकू की प्रूफ जे पाठवलं त्याचं नाही ना ऍक्च्युअल मध्ये नाही डॉक्टर जेवण करतो
शिंदे नंतर प्रिंट यार होणार आणि मग धाकटे फाडतो आणि डॉक्टर केदार दारू बापे नाहीये सो इथे पद्मा अय्यर आणि अल्का हे करतात इथे मॅडम आहे त्याच्यानंतर आता राजू सर हे टीम होते राजू सर हे पण काढू त्यांनी मला सांगितलं त्या मॅडम आल्या असल्या तर सीमा गायकवाड आणि महिला सुरू करा आता माईक लावून A very good afternoon to all of you. सगळ्यांनी पोटभर जेवण केलं असेल असं वाटतंय. तर आता यापुढच्या कार्यक्रमाची सूत्र डॉक्टर केदार पाटील हाताळतील.
Good afternoon all. I welcome you again for the post-lunch session. For this session, I would like to invite the chairpersons, Dr. Alka Silsagar and Dr. Padma Iyer Madam on the stage. We have an interesting topic to discuss by Dr. Suparna Shinde, an eminent cardiologist. It's about preventing, how can we prevent sudden cardiac deaths and know the cardiac risk. Over to the chairpersons.
Friends, it's my honor and pleasure to introduce the Next speaker, Dr. Raju Varyani. I think it doesn't require any introduction. He's a very, very well-known cardiologist. But as a formality, I'll be introducing him. He has done his MD medicine from BT Medical in 2003. He did his GNP cardiology from Ruby Hall Clinic 2008. Fellow Indian Society of Electrocardiology, Fellow American College of Cardiology, Founder Director, Ultra Clinic, Pune, India's first lifestyle reversal gym, former editor, Indian Journal Electrocardiology, keen interest in heart failure, exercise physiology, electrocardiology, pacing, and device therapy. He has many publications in national and international journals, reviewer for various international journals. Over to Dr. Raju Varyani for his very important talk on can we know your cardiac risk. Over to you, sir.
Thank you, Padma Madam. Thank you, IMA Pune, for inviting me. And very much big thank you to Professor Gupte sir. Not many people know that there are two people who saw me on the first day of my life. One of them is Dr. Gupte, who conducted my delivery, and Dr. Navarange, who was my pediatrician. So it gives me great pleasure to be here, especially in this postprandial session when everybody is into a siesta mood and about to go to sleep. So let's see if I am able to keep you awake for next 15 to 20 minutes. I promise you I will not bore you. I'll not get into the details of technicalities of genetics, but we'll see what we are going to take application wise in a genetics and sudden cardiac death. We all know sudden cardiac death is a big problem nowadays. Somebody is dying here, there, some doctor, some runner, some marathoner, they're all dropping dead. And you all know that this is a electrical problem of heart vis-a-vis heart attack, which many people think, lay people, that is somebody dying with sudden death is always having a massive heart attack. So we have to first understand that sudden cardiac death is not heart attack. It is an electrical phenomenon, and heart attack is basically a vascular phenomenon. So heart attack gives you time, sudden cardiac death does not give you time. So only thing which can save you is timely defibrillation and timely CPR, which the rates of which are abysmally low in our country. That's besides the point. It is a topmost killer in Western countries as well as in India. India, the data is almost unavailable, but still whatever is data, sudden cardiac death ranks at the very top of the death causes in India. You have seen all these media coverage of various deaths, but we learn nothing from them. So if you see sudden cardiac death as a cause of natural death, the majority of sudden cardiac deaths happen in people with normal, structurally normal heart and no history and symptoms of cardiac disease. So it comes out of the blue. The word itself has sudden, it comes as a bolt, and the first symptom can be death. And that is why it is imperative for us to know, can we re-stratify and can we get some clues that we can have a sudden cardiac death and act accordingly. And I think genetics is going to play a huge role in doing that. So if you look at the causes of sudden cardiac deaths in young, they're broadly divided into two. One is cardiomyopathy and other is called as channelopathy. Don't go by these big names. Cardiomyopathy is basically a myocardial muscle disease, structural problem with the myocardial muscle, structural oblique functional. And the channelopathies are sometimes channels, ion channels, sodium, potassium, calcium, ryanodine receptor. These are the channels which create instability into the electrical and structural instability into the cardiac muscle, and then they cause arrhythmogenesis. So these are the broadly two things which come to our mind when we talk about sudden cardiac death from electrical causes. So broadly, when we divide them, first reason which comes to our mind is coronary artery disease or ischemic heart disease. Ischemic heart disease, yes, it induces sudden cardiac death, but that is a structurally abnormal heart. The second subset of this is non-ischemic, and in non-ischemic we have cardiomyopathies like secondary cardiomyopathies, wherein it is post-myocarditis, post-valvular, post-alcohol or post-hypertension. So there is some reason to this, these particular cardiomyopathies by which there is a hypertrophy or oblique dilatation of the heart, and it leads to dysfunction of the heart. So these are quite okay. We have seen in COVID lot of problems post-COVID, myocarditis causing LV dysfunction, arrhythmia, sudden cardiac deaths. Been there, done that. But more problematic are the primary cardiomyopathies where you do not have any reason. So these are basically genetically determined. These happen in families, and they are hypertrophic cardiomyopathy where heart is very thick, dilated cardiomyopathy where it is weak and dilated, and there is a third subset called as arrhythmogenic cardiomyopathies, which are actually something similar to dilated, but they have more arrhythmogenicity. So they are very unstable. तड़फड़णार heart है. So they give rise to various impulses and they cause ventricular fibrillations and VTs, and they are very important to know. We can prevent that. So RCM, restrictive cardiomyopathy, and LV non-compaction. Again, these are parts and parcels. Some you can say a cousin, brother, sisters of dilated cardiomyopathy. And the last ones are the channelopathies. The names are big: Brugada syndrome, long QT syndrome, short QT syndrome, idiopathic we have catecholminergic. But these are essentially problems with the iron handling in the heart. And they are all monogenic. Some of them are polygenic, some of them are monogenic. And monogenic means you can actually diagnose them by doing certain gene testings. So whenever we're talking about genetic testing, is it just like a lab, pathology lab, that you take out blood, send it to the lab, get the report and start medicine? No. Genetic testing starts at testing, but ends at various components. Many my prior speakers must have, there are some counseling involved, there is a family counseling involved, there are insurance, there are employment, there are a lot of issues. So it's essentially genetic center is not a lab. It's a multidisciplinary center wherein you have all these people, because the real problem starts after you get the result of a genetic test. की ह्याच्या मुलाला काय सांगायचं, ह्याच्या बायकोला काय सांगायचं, ह्याच्या आईवडिलांना काय सांगायचं, कोण मेला असेल, मामाला काय झालं, मावशीला काय झालं, मग त्या माझ्या लहान मुलाला पुढे जाऊन काय होऊ शकेल का? सो ह्या सगळ्या गोष्टी चालू होतात ज्यावेळेला जेनेटिक टेस्टचा रिपोर्ट येतो. मग दॅट्स वाय यू रिक्वायर अ टीम एफर्ट. अँड फॉर्च्युनेटली वी आर फॉर्च्युनेट टू हॅव that kind of setup today with the Greenarray labs, wherein a person who really is not really related to genetic field has taken an initiative to establish such a center, and I think we all deserve a round of applause for that, Dr. Gupte sir. So when we're talking about genetics, where does the genetics help in sudden cardiac death? First and foremost, before the event, wherein we can we prevent that event, or can we prognosticate that event? Secondly, during the event, can we know that this particular gentleman is going to get a sudden cardiac disease, sudden cardiac death, and we can prevent it? Or during the CPR, can we minimize or maximize the chances of survival? So that is, and third and last, which is usually the case, what happens after the death? Or if he survives by God's grace, somebody has given him a good CPR, somebody was fortunate to have access to an AED, and he survived. What next? Just putting in an ICD is no point. I mean, somebody, ARVC, you put an ICD, he'll get 10 shocks. What about his wife? What about his children? What about his mom, dad? So these things come afterwards. So genetics has a role to play in all these things, pre-event, during event, and post-event. So I'm not going to get into the details of genetics. We'll see 4 representative cases and see how do we apply this genetic testing in the practice. So this is the first case, a 21-year-old female who has been diagnosed with a seizure disorder despite normal neurological evaluations. Now this particular sentence is the most important. Anything which is a resistant seizure in childhood, not responding to multiple anti-epileptics, please rule out a cardiac disease. Always remember, this is a rule of thumb. Any seizure in children can be a hypoxic seizure due to arrhythmia or sudden cardiac arrest. So whenever your heart stops effectively because of ventricular fibrillation or ventricular tachycardia, there is a hypoxia. Hypoxia triggers a seizure. So recurrent seizure, think about arrhythmia, especially when there is no typical seizure and it presents like a Stokes-Adams attack. This patient was noted to have. So what is the next thing? So simple things: ECG, 2D echo, and required Holter. So this patient had an abnormal EKG which was showing prolonged QT interval. Now, whenever I say QT, I remember my residency days, because QT means QTC. And whenever you think about ECG and calculations, you run away from ECG because you don't want to calculate axis, rate, QT, this thing. How many of you have access to a under square root wala calculator? We never had in our college days. But nowadays, with the touch of a palm, you have apps. You just put in the millimeters and you get QTC. You put in the age, you get corrections. Bazettes, Fredricias, all kinds of nonsense formulas are there. So you don't require any kind of a specific calculation. You get the results directly. So whenever you see QT prolongation, correct it for the heart rate and see whether it is more than 480 or whatever the thing is, and then go ahead. Not only you have to see the QT prolongation, but some phenotypes of the ECG, they are also important. I'll come to it later. So this gentleman, this lady had QT prolongation. Then a Holter monitor was attached which revealed polymorphic VTs. Now these polymorphic VTs are very interesting. Monomorphic VTs are relatively stable. Polymorphic VTs are twisting VTs which show different twisting of around the points, TDP. So these particular are very unstable and they can definitely degenerate into a ventricular fibrillation. So it is very important for us to know that. And her family history, again, very important thing. Whenever you analyze a genetics related disease or anything with a sudden cardiac death, always take a detailed family history. So this lady had a maternal aunt and maternal grandmother. So आई म्हणजे तिची मावशी आणि आजी, आईच्याकडची आजी, they have died suddenly at age of 19 and 29. So that gives us a clue regarding the Mendelian inheritance also. So this is very important. Now, obviously, this does not require any rocket science. This was a long QT syndrome, which was running in the family. Now, where does genetics? So I did not require any genetic testing. So where does genetic testing require? LQTS has got 13 different genotypes. LQTS 1, 2, 3, 4, 10. When I was in US in Mayo Clinic, there was a Professor Ackerman, Michael Ackerman, and his only OPD was for LQTS. So this gentleman has described 75% of the LQTS genotype phenotype correlations, whatever is published in the literature. LQTS are very specific. They have various different findings on ECG which are very classical. So this is one condition where you can predict the genotype based on the phenotype on the ECG. Bifid T waves, slow, lazy upstroke of T wave. So these are different. And why do I need to know whether it is LQTS 1, 2 or 3? मेरे को क्या करना है? I just want to impress you. No. The triggers of arrhythmia are different in every LQTS. So LQTS, one LQTS, pregnancy is the trigger. Other LQTS, auditory stimuli are the trigger. Third one, sleep is the trigger. Fourth one, something else is the trigger. And accordingly, the treatment also changes. And that is why if you see the lower part on the right hand side, there are some drugs which help in specific genotype of a LQTS. So like mexiletine is useful in LQTS 3. LQTS 1, you can just pace them. Somebody who's not affording ICD. So ICDs cost like 5 lakhs, 6 lakhs. They are not affording. But the LQTS 1 is there. You can just put in a normal pacemaker, pace them with 80, 90 instead of 72. Their chances of getting VF are reduced. QT is shortened. So these are the way by which you know that by knowing the type of subtype of LQTS, you know how to prognosticate. If you look at this, these are the representative cartoons where exactly we can actually find out etiology and how can you do. So if you know that somebody is harboring a gene of LQTS and is not yet had any kind of cardiac arrest or syncope, but you have to be careful. He may have in future. So you may give some preemptive things. You may give some advice that you don't do heavy exercise, or you want to put in an ICD to someone. ICD is a big thing in India. So you require either a survivor of the cardiac arrest or you what is called as 1.5 prevention. So primary prevention ICDs are not cost effective in India. So if you have a genetic study which says that this has got a SCN5A gene, boss, you can go for ICD because you will never know you will get into a fibrillation. Or there are some subtypes which are amenable for radiofrequency ablations. So genetics plays a big role in guiding us for that. Coming to another case, a 21-year-old female, she was referred to a lipid clinic. Now this is a very common problem. And in October 21, she was invited for a genetic testing because she had abnormally high lipid levels. And I'll tell you, you see here, the cholesterol was 334, LDL was 255, HDL 42, triglycerides were closely normal. So familial hypercholesterolemia is a very common problem because we don't look at आपल्याला वाटतं की हे फक्त कोलेस्ट्रॉल वाढलंय. No, especially if somebody is having a high cholesterol more than 190 200 LDL, please ask them history of coronary artery disease. Now in this gentleman, ask the history, and it is studded with cardiac events. Somebody has had a IMI, somebody has had a bypass, somebody has a sudden death, somebody has had a myocardial infarction. So they were all offered cascade testing. Now cascade testing, somebody must have described you. You have a initial case, and then according to that, you do another testing. So genetic testing was done in this case, and he was found to have ApoB mutation. Now I'll come to that. There are certain 3 to 4 mutations which are very important in familial hypercholesterolemia, and then therapy was started. Why it is important to know familial hypercholesterolemia? It is an imminently treatable condition. It is not like something like a wastebasket diagnosis where you diagnose and then say, yes, I have diagnosed and forget. What can you do? Nothing. But here you can have a treatment. In fact, I remember 15 years ago, Dr. M.S. Hiramat did world's first angioplasty, left main angioplasty in a 10-year-old girl. She was homozygous familial hypercholesterolemia. That time we had tough time getting statins. In fact, Mr. Khanna from MQR provided her free of charge statins. But then you all are aware, high-dose statins have their own problems. But nowadays we have amazing drugs, PCSK9 inhibitors, we have bempedoic acid, we have other medicines which can actually treat this hypercholesterolemia very well. And that is why it is very important. How do we diagnose familial FH, we call? There are some criteria which have family history, personal history, physical signs, like simple sign, looking at their tendons, tendoachilles, and this area, you can see the xanthomas. You can see arcus senalis. Ek sada torch doyat taka arcus senalis. Somebody with age 35 having arcus senalis, go for his blood lipid levels. And last thing, DNA testing. If you see, the criteria says more than 8 or equal to 8 points is familial. So if somebody has a genetic variant, he is directly diagnosed. You don't need to get any other criteria, and that is very important. So these are the 3-4 genes which are very important: LDL receptor, PCSK9, and ApoB. Some are overworking, some are underworking, and they give rise to heavy loads of cholesterol, and definitely incidences of coronary artery disease are very high. And these are very common. In fact, Dr. Sahani from Delhi has got a huge data on heterozygous familial hypercholesterolemia. It is as common as 1 in 10 people. We don't have any big cohorts though, but there is a registry which is going on under the aegis of Lipid Association of India. But very common familial hypercholesterolemia, and make sure that you do not miss these people. Try to screen their siblings and descendants also. And the treatment of cholesterolemia is also very fascinating. There are drugs which are genetically engineered drugs. In fact, there are 2 drugs in the right corner, lometamide and mipomersen. These are drugs which introduce a stop codon. A stop codon is the codon in a DNA formation where the formation of DNA stops. So this stop codon is introduced via these drugs, and cholesterol production is stopped. There is something called as missense RNAs which are introduced. So these are the drugs which are very much fascinating drugs, and the future medicine, in fact, even coronary artery disease might lie, the solution might lie in such kind of drugs. Coming to the third case, 19-year-old female, a soccer player, had an abnormal ECG with TY inversions in V1 to V3 in a routine evaluation. Nowadays, there is a fad of doing marathons and runnings, and you always hear he was running and he just dropped dead. Problem is that nobody does a monitored exercise test in these people. Neither they do not monitor their own intensity. So simple thing like American College of Sports Cardiology has said, simple ECG nikalo. They don't advise echo, but in India, echo is as cheap as doing a test. So you can always do an echo, also you get additional information. So ECG and echo, simple thing, some changes you can go for further evaluation. But do not, especially after 40, if somebody who's sports enthusiast wants to become like Dr. Navarange and run every year, but not everybody is Dr. Navarange. His fitness levels are beyond comparison. You know, he's blessed for that, and he has toiled hard for that. But somebody like me who doesn't exercise that regularly wants to run a 40K. No, you have to undergo a cardiac evaluation. So this lady had a cardiac evaluation done, then Holter monitor was done, which showed frequent PVCs, again very non-specific, but yes, showing. Echo demonstrated a mildly enlarged right ventricle with apical wall motion abnormality. Now, whenever we see apical or any wall motion abnormality, the next knee-jerk reaction is angiokebejo. My boss, my teacher, Dr. Professor Durai Raj used to say, Ritu, you want to become a cardiologist, become a cardiologist. Don't try to become a blind stentologist. So never ever, whenever you see an abnormality in echo, does not equal to sending for angiogram. So this apical hypokinesia is not induced by coronary artery disease. This is induced by fibrosis. And whenever there is a fibrosis in the heart, it's a nidus for arrhythmia formation and ventricular tachycardia and ventricular fibrillation formation. So this is apical wall motion abnormality. RV was little enlarged. So again, going towards dilated cardiomyopathy. So the appropriate investigation next is cardiac MRI. Now this cardiac MRI also requires certain things about cardiac disease. This is a very, very important test. See, your echo tells you about structure. I mean, there are some things in echo like tissue Doppler, speckle imaging, strain. They tell me about muscular level movements of the heart. But cardiac MRI tells me about scars, tells me about fibrosis, tells me about late gadolinium enhancement, tells me that this gentleman is going to get a heart attack, going to get a heart arrest. So this is very important. Cardiac MRI is available in the city of Pune, Mumbai, although there are very few centers which interpret this very well, but then you have to make use of this cardiac MRI, especially patients with syncope, patients with intractable epilepsies, patients with suspected arrhythmias. Always make use of cardiac MRI, and this confirmed areas of fibrosis corresponding to the wall motion abnormality. And again, family history. She reported a paternal cousin who experienced sudden cardiac arrest while running track and has an ICD. So somebody in family has an ICD. Going further, it was revealed to be ARVC. ARVC is arrhythmogenic right ventricular cardiomyopathy. Somebody in your family has it, and he was found to have a gene variant called PKP2. This PKP2, forget about the name. There will be 100 names which will be bombarded today. So there is a gene which codes for arrhythmogenic right ventricular dysplasia, and this lady was also tested for that. And obviously, after a discussion, she was told not to do exercise, no athletic level activities, and was put in an ICD. Additionally, her family members were screened and they were further counseled. Now, again, it is a matter of ethics and morals and legality. Can we just advise an ICD based only on genetically found some variant? The answer, I don't know. It's still in evolution. Maybe some other people in this field can tell me, but yes, if he is affording and if somebody is having and there is some clinical history, definitely they can go for an ICD. So these are cardiomyopathies. As I told you, cardiomyopathies are either thick, that is hypertrophic, dilated, and in dilated cardiomyopathy, it is not lack of blood supply which makes them dilated or weak. It is the molecular level problems with the sarcomere of myocardium, various problems, actin, myosin, intercalated disc, everything is coded by a gene, and they can give rise to a dilated cardiomyopathy. And whenever it becomes unstable, then you get what is called as arrhythmias. And this is the third option, the arrhythmogenic cardiomyopathy, what this lady had. Again, there are 4 or 5 genes which code for this. Some of them have Mendelian inheritance. See, if they follow Mendelian inheritance, it is very easy to diagnose. But there is something called as polygenic inheritance, whereas there are many genes, many environmental factors, they come together. But still, you can prognosticate, you can risk stratify these patients based on gene condition. Last case, a 49-year-old man suffered a sudden cardiac arrest while lifting weight. So cardiac arrest. He's underwent cardiac evaluation, coronary angiogram, echo, MRI, nothing found. His first ECG showed first degree heart block, very non-specific finding. No LQT, nothing. So there is no clear family history of cardiomyopathy, nothing. He was diagnosed as an idiopathic wave. Always remember he had a cardiac arrest and he was put in an ICD. A comprehensive cardiomyopathy arrhythmia genetic testing was ordered and was found to have a defect in a gene called as SCN5A. This is a sodium channel encoding gene, and this is a very important gene. This shows how genetics plays. SCN5A codes for 3 to 4 cardiac conditions, depending on how it is expressed. If it is a lack of function, it becomes Brugada. If it is gain of function, it becomes LQTS. So this is called as allelic polygeneity. So depending on how this plays, you get different diseases and they all end in sudden cardiac death. So Brugada syndrome and all you must have heard many times, but this is one of the basic genes of Brugada syndrome. And just carrying this is like BRCA1 in gynecology. Nowadays there is a fad of do BRCA1 and get your breast removed, thanks to Angelina Jolie. So this is a BRCA1 of sudden cardiac death, SCN5A. So tomorrow people will say do SCN5A and put in an ICD. ICDs have got their own problems, man. I mean, see, so that's why this guy was recommended to have routine cardiac evaluation, avoid sodium channel blocking. Now, very common drugs such as gatifloxacin, terfenadine, cetirizine, they can play havoc with your sodium channels and cause prolongation of QT interval. Add to that, if you have a SCN5A, you are definitely heading for a polymorphic ventricular tachycardia and death. So avoid that. Simple thing like fevers have to be treated in these patients very fast. Yesterday only I got a call from my patient who's been treated with an ICD. He said, "Mala 3 वर्ष shock नाही बसला sir, आता 2 shock बसले." म्हटलं काय झालं तुला ताप आला? हो म्हणे मला व्हायरल चालू आहे 3 दिवसापासून. म्हटलं काही नाही गपचूप बस आणि डोलो 650 3 वेळेला खा दिवसातून. So he's good now. It was an appropriate therapy. We checked it, but fever, simple thing, trigger. So clinical screening of 2 minutes. I'm finishing, madam. So hypertrophic cardiomyopathy, again, there are various genes. There is something called as gene negative HCM, gene positive HCM. Again, hypertrophic cardiomyopathy, it's a abnormally thick muscle. So it is more prone for arrhythmia formation. That much you have to remember. And I'll end my talk with this one slide, molecular autopsy. See, this is the future of sudden cardiac death. When we were in Sassoon, doing a single clinical postmortem was a task because nobody was ready. All the forensic guys were busy in doing medical autopsies, and pathology, nobody was interested in doing it. In fact, I remember me and Sanjay madam, we had a very interesting case. Nobody was ready to do an autopsy. So what about molecular autopsy? Molecular autopsy is you can preserve the tissues of a dead man. Even clotted blood is enough. And you can actually do a genetic study on that and find out how this gentleman has died. He's died suddenly at the age of 23. Why? Because this is important from his family. This is important from his siblings' point of view. And so I think in near future, we will have access to things like molecular autopsy. And what about guidelines? Yes, our cardiology societies all over the world are now recommending the genetics testing for prognostication, for diagnosis. And this is how we have to understand that genetic testing is not just for our own benefit. It carries a prognostic, it carries a diagnostic, and sometimes rarely and in future therapeutic value. And this is very, very important. And with this, I'll stop my lecture. Thank you.
Excellent talk, sir, with practical tips and how to act. And it is because of the electrophysiology and it is not ischemic. Any questions?
This lecture, sir, everyone is awake even after lunch, having because it is to the heart. And so it was a wonderful talk, sir. Thank you.
Thank you. Thank you. Yes, it actually works on the de novo pathway. And it reduces. In fact, it reduces so much that they have only licensed this drug in familial hypercholesterolemia. Yeah, so that acts on the particular enzyme which converts, like HMG-CoA reductase enzyme, you inhibit by statins. It works on that, but at a molecular level. No, but it is very expensive, prohibitively expensive, $25,000 to $30,000 for one dose. But for homozygous hypercholesterolemia, they have to do because otherwise they can't live. But bempedoic acid is a drug which has come very recently along with statins. So statin 80 milligram, 40 milligram you give, he starts getting pains of muscles, aches, sometimes rhabdomyolysis. So what you do is 20 milligrams of rosustatin with ezetimibe, combinations you get plenty, and add bempedoic acid. Bempedoic acid acts on 2 steps above in the de novo pathway of cholesterol formation. So you get amazing results. LDL becomes less than 55. It is comparable to those PCSK9 injections, which are again 20,000 rupees per injection every 2 weeks for whatever you want to take. So nobody takes it. Thank you.
Sir, please wait.
Please wait.
सर थँक्यू फॉर कीपिंग एव्हरीवन अवेक आणि अँजिओप्लास्टीची भीती न घालता तुम्ही सगळ्यांना जेवल्याच्या गिल्ड ट्रिपवर घेऊन गेला नाहीत त्याबद्दल धन्यवाद. I request Varyani sir, Dr. Gupte sir and Dr. Suhas Pingre sir, past president IMA Maharashtra state, to come on the dais to felicitate Dr. Shinde, also the chairpersons to join for the felicitation.
I request Dr. Varyani sir to, sir, Pingre sir, come on. Varyani sir to felicitate.
I request Dr. Vaijayanti Patodhan madam to join the chairperson's desk. I request the chairpersons to introduce Dr. Preeti Arora, who would be speaking on how genetics help in diagnosis and management.
Yes, Dr. Preeti Arora. She's a dedicated chief genomic scientist with a strong background in molecular biology and extensive experience in leading research and development initiatives. She's a gold medalist in microbiology during her postgraduate studies. She has awarded CSIR fellowship for pursuing PhD. She has done a PhD in microbiology from Agarkar Research Institute in Pune 2019, and she's a chief genomic scientist at Greenarray Genomic Research and Solutions. She's a strong background in molecular techniques such as Sanger sequencing, next generation sequencing, and chromosomal microarray analysis to contribute to cutting edge research and diagnosis. I think, shall I continue?
No. It's okay. Thank you very much, ma'am, for
I have provided, she has provided the guidance and mentorship to postgraduate students for their dissertation programs, and she has published over 20 research articles and book chapters in international journals, showcasing a strong commitment to scientific exploration. She has represented Greenarray Genomic Research and Solutions on both national and international platforms, establishing strong partnerships and collaborations within the scientific community. So over to Dr.
Yes. Thank you very much, ma'am, for the introduction. A very good afternoon to everyone. First of all, I just want to say that it's a pleasure that I'm getting today to present some of the interesting clinical cases that we actually have seen at Greenarray. Okay, how much this genetic testing has helped in diagnosis and management. So before actually we move or jump into the clinical cases, I just want to give a brief overview of our company, that is Greenarray Genomic Research and Solution. So starting with the company background, Accurate Diagnostic Private Limited, it's a parent organization of Greenarray Genomic Research and Solution. So it's a research and molecular diagnostic laboratory. It's located in Pune and it was established in the year 2020 by Dr. Sanjay Shah. So as I already said that Greenarray Genomic Research and Solution is not only involved in the diagnostic, along with the diagnostic, we are very much into in the research and academic section also. So just a minute. The laboratory has three major departments. One is cytogenetic department, another is molecular genetics department, and third is the microbiology department. We at Greenarray are doing all type of genetic tests, whether it's a chromosomal test, molecular test, or the gene expression testing. Under chromosomal, we are doing karyotyping, chromosomal microarray analysis. Under molecular test, we are doing QF-PCR. There is a targeted single variant testing. single gene, gene panel, whole exome sequencing, and the whole genome sequencing. The Greenarray laboratory is equipped with state-of-the-art equipment. So we have all the instruments starting from PCR, RT-qPCR, Sanger sequencer, microarray system, and the next generation sequencer. So now coming into the diagnostic services, I'll just briefly go through what are the services we are, what are the tests, genetic tests we are doing. Under preconception, we are doing karyotyping. There is a genetic carrier screening panel, chromosomal microarray, whole exome sequencing. In prenatal, NIPS, FISH, QFPCR. Postnatal, newborn screening, male infertility, Y chromosome microdeletion. There is a single gene test, also some gene panel, and also the semen microbiome testing we are doing for the male infertility. In female infertility, FSHR gene mutation, Fragile X syndrome, PCOS gene panel, and there is a comprehensive panel which is covering more than 50 gene on next generation sequencing platform. For the recurrent pregnancy loss, there are two different panels. One is short gene panel, in which our focus is mainly on the genes which are associated with the thrombosis. And another is an expanded panel in which we are covering more than 50 gene on the next generation sequencing platform. Similarly, we are doing various genetic tests on product of conception sample also. So we are doing like chromosomal microarray analysis, FISH, karyotyping. And in infectious, we are doing respiratory pathogen panel, dengue, chikungunya, HPV, all 14 high risk type, STD, HIV, HBV, HCV, influenza panel, and the TB PCR. Recently, we have validated and introduced our nutrigenomics testing. So in that, we have various comprehensive panel, including the diet panel, weight management panel, fitness panel, cardiac panel, and a PCOS panel. Since I have already explained that we are doing various types of genetic testing under preconception. So in preconception, we are doing karyotyping, chromosomal microarray analysis, that is high resolution 750K. And there is a comprehensive panel that is a genetic carrier screening panel, which is covering 421 gene associated with almost 400 congenital autosomal recessive disorder. So till now, our laboratory has processed more than 1,000 samples for karyotyping and CMA. And similarly, 152 couples are screened for genetic carrier screening. So during this screening procedure, we have come up with some of the interesting case that I'm going to discuss today. So one such case is a case of a non-consanguineous couple with a history of 3 recurrent pregnancy loss, and that too before the 16th week of gestation, was referred to the clinic. So initial investigation like hormonal profile of the couple revealed normal parameter, and the ultrasound scan was also normal. So basically, to understand at the genetic level, they have referred for chromosomal analysis, because in case of recurrent pregnancy loss, the majority of cases are because of balanced translocation. So first genetic analysis was referred for the karyotyping. So the results suggested the male karyotyping came out to be normal. In female karyotype, a unique and a novel balanced reciprocal translocation was detected between the long arm of chromosome 4 and the long arm of chromosome 13. Since this couple with balanced reciprocal translocation have a 50% chance of having recurrent spontaneous abortions and a 20% risk of having child with abnormal genetic makeup. So this case study thus reported a novel balanced translocation that could result in the formation of unbalanced gamete due to meiotic error associated with first trimester recurrent pregnancy losses. Thus, the couple was informed about the risk of birth defects in their offspring due to the karyotype finding. Hence, this test helped this couple to make an informed reproductive decision regarding subsequent pregnancies. Now, another case is related to our genetic carrier screening panel. So there was a non-consanguineous couple who lost one male child at the age of 1 year. Based on the clinical finding, he was suspected to be affected with SMA, but the genetic testing was not done on the affected child. Since the child was no longer available for genetic testing, so the couple was advised to go for genetic carrier screening test. So the preconception genetic carrier screening of couple has revealed that both were carrier for SMN1 exon 7 deletion. So this carrier screening test helped identify the genetic disorder that caused the death of a child. And carrier screening test can help get a final genetic diagnosis even if the affected child is not available for genetic testing. So this final confirmation can help in prenatal diagnosis in the next pregnancy. Such couple can screen future pregnancy for the presence of defective gene in the fetus and make appropriate informed decision. In prenatal, we are extensively doing the non-invasive prenatal screening, or I can say it's a fetal DNA testing in a maternal blood. So looking into this comparison chart, we can see that the fetal DNA testing is highly sensitive. It has a sensitivity of more than 99.99%. And as compared to the first trimester screening, which has a sensitivity of around 60 to 80%. So this all sensitivity, specificity, we all get from the literature and whomsoever have done the testing and the validation point of view. From a lab perspective, I just want to show how much we are confident about the NIPS, what is our observation from a Greenarray lab of point of view. So till now, we have processed more than 2,269 sample for NIPS. So during this screening procedure, we came up with some of the high-risk pregnancy, out of which 6 were trisomy 21 and 3 were detected as a sex chromosomal abnormality. All the 9 sample we have confirmed. This high-risk sample were confirmed either by karyotyping or fish on amniotic fluid, and all 6 came out to be positive for trisomy 21 and all 3 came out to be positive for some of the sex chromosomal abnormality. So from this data, I can confidently say the sensitivity and specificity of NIPS screening is more than 99%. So there is also one thought in everyone's mind that when we send sample for a NIPS testing, there are some sample which went in a no call. But from a literature review of, I think there is a literature of 2018 where they have said that in a NIPS 3 to 5% of sample went into a no call. But at that time, there was no fetal DNA enrichment process was there. Now with the advance in the technology, we can enrich even the fetal DNA from a maternal DNA and we can reduce this no call. And from our observation, I can say that we have processed more than 2,269 samples and only 1 sample went into a no call. So that has reduced a lot also, and the sensitivity and specificity has also increased a lot also. So there was a case, 32-year-old pregnant female. There was no previous history of any abortion and MTP, no family history of any genetic condition. Their prenatal investigation, NT scan normal at the 11th week of gestation, USG normal 13th week of gestation. She was just referred for a NIPS in her 14th week of gestation just to rule out the possibility of chromosomal aneuploidy. So this NIPS result came out to be high risk for trisomy 21. So this high-risk pregnancy was again confirmed with either fish and karyotyping, and they have also came out to be positive for 21. So in this case study, the patient had no prior indication of any chromosomal abnormality. The NT scan and even the USG reports were normal, but the abnormality was picked up at this early stage of pregnancy, helping her to make an informed decision about the pregnancy at the appropriate time frame before getting into advanced gestational age. So this case, I can say it's a very good example of why NIPT should be considered for all pregnant women, irrespective of clinical indications. In prenatal, as Surgeon Sir has give the brief about everything of the newborn genetic screening. So this in a time span of a year, we have screened 790 newborn through this newborn genetic screening panel. And from these statistics, I can say that 5% of sample we observed as came out to be positive through this newborn genetic screening. Some of the variant we detected as a variant of uncertain significance. Some of the newborn are carrier of some of the pathogenic variant. So now if we have a look in the distribution of pathogenic variant in carrier, we can see that there are large number of mutation in our ethnic population are associated with BTD, then G6PD, and then GJB2 gene mutation. So this genetic testing will definitely help in diagnosis and management. Along with that, this data will act further as a database because there is no Indian database available right now. We are right now also relying on other country database to what condition to be screened, which type of mutation are prominent and which are not. So this can also help in developing a new database of our Indian population. So these are some of the distribution of variant that we have observed, that in the pathogenic, there were some SNPs and indels, both are involved. So I can say that this newborn genetic screening panel, it is highly cost effective. It has a great specificity and a fast turnaround time. So there are some newborn cases that we faced while doing this newborn screening. A consanguineous couple conceived normally, opted for newborn screening. There was no family history of any genetic condition. This screening revealed the newborn to have a homozygous variant in hexa gene, known to cause a life-threatening rare condition, that is Tay-Sachs disease, which is commonly characterized by symptoms like loss of muscle coordination and psychiatric symptoms. This is an autosomal recessive condition. The APGR score for the baby was normal, but the baby was still kept under continuous follow-up to check if the baby met all the developmental milestones. So after certain follow-up till 9 months, baby has met all the developmental milestones, later started showing some low weight gain and decreased responsiveness. Therefore, the baby was kept under continuous medical surveillance. Parental testing for this couple for a similar variant showed that both partners were a carrier of this specific variation. So this case is an example of how newborn screening helped the family to know the risk of their newborn, to develop a condition in the future that can be life-threatening, and help the newborn to get on-time surveillance and treatment interventions. Also, this information will be useful to the couple in planning the next pregnancy. Another interesting case that we have observed at Greenarray while doing this newborn genetic screening was a non-consanguineous couple with no family history of any genetic condition. They have just opted as a routine screening as a newborn screening, and they have an elder son who is 6-year-old. The couple opted for a newborn screening genetic panel for the second child. So this screening revealed that the baby is a carrier for the HFE variant. Is just a carrier of a HFE variant, and this HFE gene mutation is basically associated with hereditary hemochromatosis. A mutation in this gene causes increased absorption of iron despite a normal dietary iron intake. So it's an autosomal recessive condition which states that the newborn will remain a carrier, means asymptomatic. While sharing this genetic finding about the newborn and explaining the inheritance and chance of the baby developing the condition, then the couple revealed that the elder son complained of occasional discomfort in the liver area for quite some time. So the general investigation is normal for the elder son. Biochemical investigation was also normal. They were asked to check this variant in the elder son as well. And he was found to be homozygous for this disease after genetic testing. So this child is at risk of developing the disease and its associated symptoms. The elder child was subjected to further testing immediately and received adequate medical care for this issue. So this is an example, I can say, how genetic newborn screening assisted in determining the infant carrier state, which proved to be life-saving for the sibling who had a severe version of the illness. In male infertility, we are doing various testing. One is such a single gene test, that is the FSHR gene mutation test, for which we have processed more than 250 samples of different conditions. Some are for oligoasthenozoospermia, oligoasthenoteratozoospermia, azoospermia, and asthenozoospermia. So we have observed that there is a mutation in FSHR gene which may be associated with male infertility and can be hampering the semen parameter and all. Another test that we are doing in male infertility is a semen microbiome testing, where we have observed there is a drastic difference in the semen microbiome when we compared with a fertile semen with an infertile semen. In recurrent pregnancy loss, we have two different panels. One short gene panel in which we are focusing mostly on the thrombophilia related gene. So here also we have found out that we got a lot many mutation in PI gene and MTHFR gene. There's one case, a 30-year-old female who had experienced 4 recurrent pregnancy loss and 1 IUI failure. There was no known history of any genetic condition in the family. AMH level was around 4.94, and genetic investigation, they went for a small recurrent pregnancy loss panel, that is a thrombophilia panel, in which a homozygous pathogenic mutation was detected in a PI1 gene. So this PI1 is basically involved in normal blood clotting. So this gene mutation caused complete PI1 deficiency, resulting in impaired production of the PI1 protein. Affected female may have excessive bleeding and abnormal bleeding in pregnancy and childbirth. So, and later on, during their follow-up, measurement of PI antigen level and PI activity in the female result suggestive of PI activity lower than 1 unit, and PI antigen was undetectable. After she conceived, for the next time, close monitoring was and treatment was given. So after the treatment basically was given to prevent the intermittent bleeding in the first and the second trimester. The patient was on strict monitoring, as the PI1 gene is also associated with So basically, the treatment was given to prevent the intermittent bleeding in the first and the second trimester, and the patient was also on a strict monitoring, as the PI1 gene is also associated with pregnancy, preeclampsia during pregnancy. At 34 weeks, she developed gestational hypertension, but there was no proteinuria. The blood pressure was also controlled. She delivered a healthy baby at term. About 15 to 60% of women with RPL are found to have one or more mutation predisposing thrombophilia. Genetic factor cannot be modified, but can be managed to a very good extent. Like in this case, diagnosis of a mutation that was leading to thrombophilia was managed through proper medical interventions and care. We are also doing the whole exome sequencing. We have done a lot many sample and we have come up with most of the interesting cases. One such case was a non-consanguineous couple presented for preconception consultation with the concern that their previous child was diagnosed with delayed milestone, no history of any genetic condition in the family. The previous gestational screening, USG 35-week IUGR, LSCS done, baby admitted in NICU for 5 to 6 days. Clinical detail, affected baby, mild dysmorphic features was there, myopia was there. So initial genetic investigation was done basically to rule out the chromosomal related abnormality like the karyotyping and the CMA analysis, and they come out to be normal. So they further went for a whole exome sequencing, and in the whole exome sequencing, a likely pathogenic variant was detected in exon 3, heterozygous in CHAMP1 gene, which is associated with neurodevelopmental disorder with hypotonia, impaired language, and dysmorphic features. So this condition is characterized by impaired intellectual development, speech and language impairment. Parental screening, couple screening, Sanger sequencing was performed for the variation which was detected in the child, and the couple was not detected with this variation. So in this case, whole exome sequencing helped in the accurate identification of the condition in the affected child, as the parents were not detected by the mutation which are present we have validated this HPV self-sampling kit in more than 1,000 sample. So till now, the lab has processed around 2,540 sample for HPV, and that is for the all 14 high risk type, not only for the HPV 16 and 18. So from this data, I can say that not only the HPV 16 and 18, in the recent year, we have found there is a high prevalence of HPV 33 also, that is also a high risk type. And looking into this data, we can say that we are getting more number of positive in the age group of 30 to 40, which needs a high screening at this age group. And not only for the HPV 16 and 18, every woman should be screened for all 14 high risk type. So that was about the diagnostic and the interesting clinical cases that we actually observed at Greenarray Lab. Now, coming into the research and development, as I already told, that laboratory is not only focusing on the diagnostic part, our major focus is also on the research and also the academic section. So our research laboratory is DSR recognized, that is Department of Scientific and Industrial Research. The primary aim of DSR is basically to promote R&D by industry, support a large cross-section of a small and medium industrial unit to develop state-of-the-art globally competitive technology of high commercial potential. So we have our own ethics committee, we have institutional biosafety committee. Now coming into the product that we developed at Greenarray, the first product that we developed was the COVID-19 RT-LAMP based COVID-19 detection kit. So this kit generally doesn't require any hi-fi instrument like a PCR or RT-PCR. We can do the detection simply by a color change. If the sample is positive, it will turn from pink to yellow, and if the sample is negative, it will remain as a pink. So it's just a visual detection of a positive and negative samples. So this kit was the first kit that we developed at Greenarray, and this kit is also optimized against the gold standard RT-PCR based COVID-19 detection kit, and the kit has presented 100% sensitivity and specificity for COVID-19 RNA detection. The second product that we developed at Greenarray was the cost-effective PCR-based HPV all high-risk type detection kit. After that, we realized that some women are not comfortable going to the clinic and giving their samples. So why not to design some self-sampling kit? Then we come up with the HPV self-sampling kit, and this also we have validated in more than 1,000 samples. And the third product that we developed at Greenarray is the cost-effective newborn genetic panel. So it's a 47 gene panel on next generation sequencing platform, basically to screen neonates for conditions which are very much commonly observed in Indian scenario. These are some of our key publications. We are into research. We are publishing all the articles. We have also presented Greenarray in various national and international conferences, various posters, like in the International Conference on Prenatal Diagnosis and Therapy, and also on the BGCI, International Conference on Recent Trend in Bioengineering. In this year, we have presented 2 posters in ISPD, and again on the BGCI, and another in the Molecular Pathology Association of India. So now coming into some of the research projects that are ongoing at Greenarray Lab or in our research division of our lab, first is to study the role of semen microbiota in male infertility, where we are studying how the microbiome is causing male infertility. Another project that we are working is on the characterization of gut microbiome in obese and lean adult by 16S rRNA gene sequencing. Reproductive microbiota and their role in pregnancy outcome, how the vaginal microbiome is contributing to the recurrent pregnancy loss and also the preterm birth. So we are identifying some of the molecular signature that from which we can determine whether that a particular lady is at a risk of preterm birth or a recurrent pregnancy loss. We are also working on preeclampsia. We are locating an identification of some of the genetic biomarkers. So some of the biomarkers we identified through some of the bioinformatic analysis. Now we are testing this biomarker in actual clinical samples. Another project that we are working is exploring new therapeutic targets for diagnosis and treatment of endometriosis using omics approach. Another project is we are looking on the GJB2 gene mutation in Indian population with non-syndromic hearing loss. So these are some of our technical collaboration. We are associated with various colleges, research institute, basically for the research and other academic activities. So with the Symbiosis International University, Intignis Biotech, FC, we provide service to Serum Institute of India, IRSHA, research collaboration with MIT, VIT Vellore, Modern College, and Symbiosis Skills and Professional University. Since I already told, we are very much into academics also. We provide hands-on training workshop in advanced molecular biology technique for all the student and anyone who want to learn this technique. So more than 2,000 students already trained for like starting from DNA extraction to Sanger, and also there is a customized training available if anyone wants to have on next generation sequencing platform and the microarray system also. This genetic course we have recently come up basically for the clinicians. So we are covering, it's an online certificate course where we are covering everything from the basic of genetics, what tests to be recommended, in which condition, where various case scenario, everything we are covering in this genetic course for clinicians. This is our advisory committee. And thank you very much.
Thank you. With all your case discussion, I think all the audience must have known the importance of genetic study in day-to-day practice now, because we need only have to do all these studies whenever there are cases, not like that, but we have we expect only one child. So with that child to be normal, or if there is any problem, and we see that many people they are getting married late. So that also the problem comes in this field. So I think you have elaborated the lecture very well, and I must thank you, and all the Greenarray equipments we have told. So I think you just now Mr. Atul Mahadik has told, so you can visit Greenarray lab. It is at the Happy Colony, Kothur, and you can see the all the equipments. They are really through very well. Thank you.
Yeah, thank you, Dr. Preeti. It was a wonderful presentation, very informative, and we really look forward to the research data, because having Indian data has always been a great toughest challenge. I've been working in medical research for last maybe 15 years, and it's really difficult. So look forward to maybe association from our end also, and
Sure,
otherwise your results will definitely be the game changer in the field of medicine. Thank you so much.
Thank you, ma'am.
Any question from the audience?
I request Dr. Raju Varyani sir to come onto the stage to felicitate speaker, Dr. Preeti Arora, the chairperson, to join for the felicitation. Dr. Sanjay Patil sir, please join. With this, we move on to the next lecture by Dr. Phadke. It's a keynote address about human microbiome, the next frontier of precision medicine. I request the chairpersons to introduce Dr. Phadke.
Good afternoon, everybody. It's my privilege to introduce Dr. Prof.Dr. Phadke. He's a microbiologist by training, and he has obtained PhD in genetics in antibiotic resistance in bacteria. AMR has been one of the most challenging situations globally. He pursued postdoctoral research in molecular and cellular immunology. At present, he is the director of Dr. Agarkar Research Institute, Pune. He has more than 110 papers in international journals to his credit, and has 10 Indian and US patents to his credit. So we are really privileged to have you here. And he'll be talking on human microbiome, the next frontier in precision medicine.
Dr. Sanjay Gupte sir had told that this is the latest one and very exciting branch which is going to change the whole scenario, he said. So all of us are looking forward to listening to you, sir.
Thank you so much, ma'am, for adding additional monovagganic dabav on me because of this last comment. At the outset, I must thank the organizers, especially Dr. Gupte sir, for inviting me. I'm an academician, so I will be talking mostly in terms of the laboratory data that has been generated at various places. Since I'm a microbiologist, my interest has been investigating the microbial diversity associated with extreme pristine and other habitats. And whenever I have been investigating such unique sites where the temperature has been more than 100 degrees Celsius or pressure exceeding 2000 psi, or even the highly alkaline or acidic or highly cold environment, you tend to come across various microorganisms. But having said that, the most unique system where you get to see the extensive diversity is the one which is associated with human. And that is something which has been of our interest, and that is something that we have been investigating. And I would like to throw some light on some of the latest things that have been happening in this particular area. Whenever we talk about human and we talk about our anatomy, physiology that doctors are very good at, we must appreciate the fact that we are not alone. And there are some numbers that I would like to share with you, that in 2008, the entire human genome was sequenced. And after that, more than 20,000 human genomes have been sequenced. And there are several million exons of human genome that have been sequenced. And all of us have come to one conclusion, and that conclusion is there are more than 20,000 genes in a human genome. That means more than 20,000 proteins that are possibly encoded by our genome. When we compare this data just with the microorganisms which are present in our body or on our body, then that number is staggering. If at all we just try to count them in number, quantify them, then we have 10 to 100 trillion microorganisms, and the genes that they encode are more than 3 million. So if we compare with 20,000 genes by human genome and with 3 million or more than that by microorganisms, then we must appreciate the fact that the proteins that are encoded by these bacteria, viruses, fungi, archaea, and several other groups of microorganisms present in our body have to play some important role in our health, in our being well. So what exactly is this microbiome and how exactly they play an important role? So when we talk about microbiome, we don't restrict necessarily to bacteria. We talk about archaea, we talk about fungi, we talk about various viruses which are present. So it's not only these mere organisms, but it is their metabolites, it is their proteins, it is their genes, their structural elements such as protein, peptides, lipids, polysaccharides, as well as various metabolites such as short chain fatty acids, organic acid, and several other, which contribute, which determine the health and metabolism of any human being. Meaning that there is a theater of microbial activity that actually influences our health, our day-to-day well-being. So what exactly does the microbiome have to do with our health? It is something which is very important. If we look at the microbiome, it is intimately linked with the human health, but this has been done through several activities that they carry out. One of the most important activity has been digestion. And why do I say that? Because in our day-to-day routine diet, we have polysaccharides, we have complex carbohydrates, we have proteins, we have lipid, oily, and none of these components are taken up by our intestinal epithelium or gut as it is. So it has to be broken down. Our body definitely produces several enzymes which help in its degradation, but we must appreciate the fact that major degradation or major enabling force behind degrading these complex nutrients into simplified absorbable element is played by microorganisms who produce a series of unique enzymes which will degrade it. Not only that, these organisms, through their metabolic activities and production of metabolites such as short chain fatty acids, they modulate the immune response also. And this is something which is of very interest to us, that the immune response needs to be regulated. It needs to be maintained in a state of homeostasis. And if at all it has to be maintained in a state of homeostasis, that means there has to be a balance between pro and anti-inflammatory responses. And for that, one of the major component that plays a very important role is regulatory T cells or Tregs. And these Tregs are very fluently controlled by the metabolism of the gut microbiome. And that is something which is again very important. Third, and one of the major important properties or important facets of this microorganism is the protection against the infectious diseases. We eat, we drink many times the street food, the contaminated water, and many times nothing happens to us. There is a great story that when Robert Koch put forth his postulates and when he proposed that many of the microorganisms are essentially causing disease, and he talked about malarial parasite, he talks about salmonella, and there was one gentleman, he just picked up his culture and he drank it, and he said, show me whether I get that disease, and he did not get the disease. And simple reason for that is because he had such extensive, he was probably blessed with a very healthy microbial flora which offered protection against them. And this is something which is very important for us to appreciate, that the terrific lining that is there on the gut epithelium, which is contributed by these microorganisms, is what protects us. These microorganisms not only prevent the invasion by the pathogens, but it also sometimes produce antimicrobial agents which will inhibit the growth and activity of these pathogens, and that is something that our body requires. So several activities such as metabolic health, again very important parameter, because these microorganisms through their ability to produce butyric acid can control the sensitivity to insulin and can control the levels of the glucose, and indirectly or directly it is also monitored by the microbial flora, something that we rarely appreciate. And these are various facts and facets of this microbial population that has been associated with the gut epithelium that really has attracted attention in recent years, especially with the advent of some of the interesting techniques which have become available in the various laboratories. It has become very easy for us to identify what type of microorganisms are present in our body and what role they could be playing. Conventionally, whenever we have to map what type of microorganisms are present, usually the techniques that are used routinely, conventionally in pathology labs are microscopic techniques or which are culture dependent techniques. These are the two types of techniques which are followed. If at all there are microorganisms which are very unique in their morphology, such as spirochetes, malarial parasites, or some of the amoeba or such kind of organisms, yes, they can be identified using the microscopic techniques when you are talking about or when we have considering the specific tissue part. But majority of the organisms, when you have thousands of species which are present in our gut, if you want to characterize them, it probably will not be possible for us to use such techniques. Even the conventional cultural techniques, even if you give the stool sample for analysis, normally the test or media that would be used would be specific for Salmonella, Shigella and such organisms, and you would detect the presence or absence of such organism. What about Clostridium difficile? How many of the labs would look for that? And very few. The anaerobic cultivation of the anaerobic, obligate anaerobic cultures is not very easy, not routinely followed. And that is the reason why there has to be an alternate approach wherein we can not only identify what type of organisms are present, but whether they are significant in the given context or not, that needs to be identified. And for that purpose, the DNA based techniques are very important. And just now we have heard from Dr. Preeti Arora that what type of techniques are available in Greenarray laboratory. I must say that with the availability of the next generation sequencing techniques, it's not really very difficult, and not only it's not even very expensive to carry out the sequencing of the entire metagenome. Now, by doing that, whatever different types of organisms are present, we will get the idea about that. But it is not only enough to know what types of organisms are present, whether those genes are expressed or not, which is the second step. And for that purpose, one needs to look for the transcriptome analysis, that whatever genes are there, whether they are getting expressed into RNA or not. Even if the RNA is there, sometimes that's not enough. That RNA, whether it is getting translated into protein or not, so proteome sequencing is the third component. And even if the proteins are there, whether the substrate is available, then only those enzymes will convert that substrate into a product, and whether that product is harmful or not. And for that purpose, the metabolomics needs to be analyzed, meaning that one has to have a combination of genomics, transcriptomics, proteomics, and metabolomics. So for that purpose, one needs to have access to techniques such as next generation sequencer for genomics and transcriptomics, LCMS or GCMS for the identification of what types of proteins are present, and metabolites which are present. Sometimes, if at all you are going to have a targeted approach, then for that purpose you need to have the microarray. These were the techniques maybe 10-15 years back, they were unheard of. Only the few very sophisticated laboratories would have access to these, and these days this is entirely changed, and many laboratories have it, and we are blessed in Pune to have such laboratory where we can have that. How did we get this idea? How do we combine all this information together? It is not a job for one laboratory or one person. It is a very expensive exercise which needs to be carried out, and this exercise was initially initiated after 2008 by a United States government. It was initiated by National Institute of Health, and the special grant worth more than $250 million was given by White House through their specific funds that were available at their disposal. Why am I telling you this? Because this underscores the importance of this particular area, which was recognized by even the US government. And after that, they came up with the project, and this project was known as the Human Microbiome Project. This was initiated after Human Genome Project was completed. And in parallel, there was another project which was Human Intestinal Tract Program, which was run by the European Union. Obviously, the Americans were far ahead, and they did actually sequencing of more than 3,000 reference bacterial genomes from genomes, and then they investigated, they sequenced, they identified what were different communities, what were different metabolites which were produced. And later on, in the first phase, after identifying all this information, in the second phase they targeted three particular conditions. They used the multiomics microbiome analysis, A, with respect to pregnant woman, B, with respect to inflammatory bowel disease, and 3, with respect to type 2 diabetes. So these are the three major diseases where there is a huge body of literature which is available, which has explained the relevance and importance of the microorganisms. So in the phase 1, when the scientist team, they carried out diagnosis, they targeted the intestinal system. That was the most important one, most diverse one. But in addition to that, they also looked for the respiratory tract, they also looked for the vaginal tract, they also looked for the kidneys, and they also looked for the other parts, that is the oral part, where they investigated the microbial population which was there. So when they investigated, they found out specific types of microorganisms which were present. Mainly, in most of the cases, the microbes that influenced the health in particular cases was the one which were different bacteria, and these bacteria were typed, they were identified, they were proposed, and I have just listed. I will not go into details of that because it was very clear that whenever you are looking for the dental plaques, there were anaerobic cultures which were prevalent, and there were facultative cultures which were prevalent when there was a buccal mucosa which was investigated, or even the microbial flora associated with the tongue was investigated. They also did the investigation in certain other cases such as skin, which was the largest organ in the human body. They also studied the urinary microbiome, and they found out that whenever you are investigating the microbial community of the vaginal flora, of the urinary tract, and the gut microbial population, there were a lots of overlaps, and based on that they identified certain group of microorganisms. Very interesting numbers, that in stomach there are hardly any microorganisms which are present because of the severe acidity, of course, and these contribute to 10 to the power 1 to 10 to the power 3 CFU, that is coliforming units per ml. This number goes up to 10 to the power 6 in duodenum, more or less the same in the jejunum and ileum, but in colon the numbers goes up to 10 to the power 10 to 11. That means there is a thick paste of microorganisms which is present in such cases. And these microorganisms, if at all their balance is damaged, their balance is disturbed, if at all there is dysbiosis, which is known, then it would cause a lot of differences in the gut brain axis, the gut brain endocrine axis, gut heart axis, and several other such parameters are there. In such cases, everywhere there are adverse effect. And what happens when there is a eubiosis? Everything is fine. At that time, if you look at the metabolites, then the short chain fatty acids, the antioxidant molecules, then there are the healthy gut epithelium, and there are several other such parameters. You will see all these molecules, all these genes expression is enhanced. And as compared to that, if you look at some of the other parameters such as inflammatory mediators or pathogenic organisms, their expression is somehow decreased or it is decreased. Now, what does it tell us? This tells us that these microorganisms play a very, very important role. And if at all you look at some of these the neurological disorders, I'll just take a minute to yeah. So in case of Alzheimer's disease, in case of Parkinson's disease, in case of autism spectrum disorders, in case of gastric cancers, you will see that in all these cases, the studies have identified what different types of bacteria are present, and there what exactly they changes. I mean, whether there is an increase in number of these bacteria or decrease in their number of bacteria has been proven. So it actually gives us some kind of insight with respect to the bacterial association with these diseases, that in cases of such kind of conditions, whether you are going to get upregulation or down regulations in this particular population. And that is something that is of our interest, because then it gives us idea whether we can use these tools as even a diagnostic tools, and that is something which has been of interest. So what does this all lead to? This all leads to a path towards precision medicine. And why do I say that? It is because when you take a look at all these factors, that is the multi-omics approach, where you have investigated the genomics, where you have investigated the proteomics, the transcriptomics, the metabolomics, and also taken into consideration the individual human genome, then that gives you a specific interaction between the body, between the individual and its microbial flora. Once you have understood that, then that can lead to a targeted approach. I'll give a very simple example. Let's imagine a combination of prebiotic and probiotic. I'm sure all of us have heard this terminology. You have lactobacilli, bifidobacteria, all such organisms which are known to be probiotics. And on the other hand, you have also heard of prebiotics such as fructooligosaccharides, inulin, and several other such dietary fibers are there. Now, how can we combine these together as a personalized or precise medicine? You can carry out the sequencing of the microbial population. When you sequence the entire metagenome, from that it is very easy for us to identify which gene belongs to which organism. You can, in fact, by using the technique called as binning, you can separate this individual sequence of individual organisms. From that, we get a clear-cut idea which organism has ability to use or degrade which dietary fibers. So from that, we essentially get an idea about the choice of those dietary fibers which are not used by harmful organism, but which are used by only the helpful bacteria or friendly bacteria. And you have the combination of those probiotic cultures which are required. For example, you want high butyrate producing bacterial culture, or you want high acetate producing bacterial culture, then you can combine them together. And with this approach, for a specific individual, you can design a targeted one. A first fecal transplant case that happened also can be considered as one of the interesting parameter. We all must have heard of this particular case where it happened in United States, when a person was suffering from bacillary dysentery for a very long time, and he was not responding to any of the 28 different antibiotics that were given to him, either as individuals or in combinations. And at that time, doctors decided to try the fecal transplant when his wife, who was healthy, this particular individual had lost more than 40 kgs of his weight, and he had become absolutely fragile, bedridden in hospital. And at that time, the since his wife has been healthy for a very long time, since they both shared the same environment, same dietary preferences, they took the fecal material from that, and through the nasopharyngeal route, they introduced it into his body. And when it was transplanted, within a very short period of time, that is within 6 weeks time, this person gained 15 kgs of body weight. And that was something which was a very unique case. Again, it was individual at that time. Whenever these doctors had to go ahead, they had initially collected the sample from this individual, investigated the microbial flora, understood what type of microorganisms he needed but were not there. They investigated the microbial flora of his wife. They investigated and confirmed that there were no pathogenic organisms were present. They confirmed the compatibility, and then this was used. And it was all possible because of the availability of these latest genetic techniques or analytical techniques. And that is how people go ahead and do that. So we all know that we cannot change our genome, we cannot change whatever is our genetic makeup, but we know that microbiome can be influenced. It is very easily influenced by dietary preferences, it is very easily influenced by the exercise, and even by diseases, and even by the drugs. We know it can be manipulated. We can introduce certain bacterial cultures from outside. So what it tells us is, as per our requirement, whenever we want to do that, and when we anticipate that such kind of bacterial introduction is going to be useful, we carry out the genome analysis. We use this particular sophisticated technique to analyze, and then we can prepare a customized formulation and introduce this genome into body, and then it can be very easily used. There are several examples, especially with respect to type 2 diabetes, that there is, when there is abundance of butyrate producing bacteria, it is linked very strongly with type 2 diabetes. With colorectal cancer, there is a very strong correlation between prevalence of the fusobacterium and porphyromonas, which is a dental pathogen, by the way, and it has impact on the colorectal cancer. There is a liver cirrhosis, where you know there is a low abundance of friendly bifidobacterium and lactobacilli, and there is a higher abundance of potentially harmful bacteria such as members of Enterobacteriaceae and Valloneriaceae. So these are the several cases where we know. So from this kind of data, we can actually look for a combination treatment to inhibit the harmful bacteria and to promote the friendly bacteria. And if at all we come up with such kind of combinations, then that would definitely help us in making use of microbiome for the application in the medicine. And there are several examples of such therapeutics, which are dietary interventions, which are absolutely fine. And there are prebiotics, probiotics, synbiotic, which is combination of both. There are antibiotics, there are fecal microbiota transplantation, and now these days you get the capsules, and it has become very acceptable way of taking the fecal transplant, and the company will make the customized capsule for consumption, and one can use it. There is a customized phage therapy, and there is a customized biotherapeutics, where certain antibodies which are targeting certain harmful proteins or agents, when they are to be targeted, these antibodies are expressed on the surface of bacteria, and then those bacteria are introduced so that they will get into our environment and they will express such kind of antibodies. So there are different ways in which we can use them, and this, in this particular slide, I have tried to summarize. I will not go into the details of that because in CRUSC we have discussed most of these part, but I would just like to differentiate at this particular point what exactly is the difference between the probiotic and fecal transplant. Normally, if at all we want to see an individual where the host physiological augmentation is to be obtained or achieved, for that purpose we can give the probiotic treatment. When we know that because of the presence of pathogen, diets, antibodies, alcohol, and environmental parameters, and several combinations of one or few or more or all of these, then there is a disturbance of the microbial community structure, which is known by the term dysbiosis. Then obviously we have to have some kind of intervention, and at that time, to replenish the entire gut flora with the healthy flora, normally a combination of broad spectrum antibiotic followed by the treatment with the microbial population is followed to achieve the microbial equilibrium and restoration of the healthy flora. And this is where the fecal transplant from with the availability of the healthy donor who has the same dietary preferences, who also has the who also is from the same environment, can be used, and this is something that can be achievable. So towards the end, I would just talk mainly about the examples of the microbiome based therapeutics. I have listed certain examples for just for our information, and these are some things which have been investigated, which have been proved to be useful. There are certain cases where the challenges and ethics about the use of this microbiome needs to be discussed, and there are challenges in the form of suitability of the cultures that we are using, the biosafety of the cultures that are to be used, especially some of the borderline cases where you are using streptomyces species. There are certain saprophytes, certain pathogenic and some friendly species. You have to have a very accurate identification as well as quality check to use such kind of cultures. You have to have a very terrific and in-depth microbial characterization that has to be done, and after only having the several human trials to prove its stability, to prove its usefulness, to prove its harmlessness, then only we can go ahead with this. So there are challenges which we have listed, some of them. The unidentified microorganisms, especially the viruses, because whenever we are doing this, these are some of the parameters which normally are not very well understood or investigated. Some of these cultures need to be properly identified. That is one part. Understanding the interactions and dynamics and adaptation is something that needs to be investigated, and identifying specific microbial molecules as well as the mechanisms which regulate the host health are something which has to be identified. I would say that at this particular time, we are in early days. We are in early days because this is a new up and coming branch of science. This is something which is going to have profound implications on our health. This is something which offers as a wonder pill, which would have ability to cure several diseases. But if at all it was the case, then it would have done so earlier. So there is need for a lot of investigation that we need to carry out, and this is something that has been done. As in the previous presentation, Dr. Arora mentioned that they are collecting the data for the human population, for the Indian population. This is something which is very important, and I must stress on this, that there are several efforts, but there is still a paucity of information regarding this. And if at all we want to take this further, and if at all we want to find these as a solution for some of the diseases, which can be affordable solution, which can be in the interest of society to achieve such societal benefits, I believe that there is a need to work very closely. I always believed that doctors in India are they are the best of the brains, but maybe because of several reasons, as every individual doctor has to look for so many patients, very few, if any, doctors are involved in the research. But that is a need of the hour. If at all, even 1% of the doctor, even any one of any or few of the doctors are ready to give 1% of their time for research related to development of the newer therapies, which could be useful for the Indian population, then I believe that our country will have a great future. Again, I would like to thank the organizers for giving me opportunity to share some of my thoughts and introduce this interesting topic. And I hope that when we meet next, we will have far more data to discuss. Thank you. Thank you so much.
Thank you, Dr. Prashant, sir. It was a wonderful and really a talk which has given a lot of vision to every listener present in this house. And yeah, thank you for introducing most of the doctors to the new horizon in the field of medicine and the future, which is not very far off. It has to come soon. So thank you so much.
Thank you, sir.
Can we take up a question, sir?
Sure.
Yeah.
How do you do fecal transfer?
Okay. So now this has become a very routine technique where there are certain companies which offer you these services. So what doctors do is they initially carry out the screening of the individual, the donor. And they also carry out the screening of the recipient. They identify the need of specific type of cultures, and then in those cases those cultures are put in a capsule in a lyophilized form, and these capsules are administered. Earlier days they used to prepare the enriched solution of bacterial culture, and through nasopharyngeal route they used to introduce this. Now they don't do that, they just prepare the capsules, and those capsules can be engulfed.
Dr. Phadke sir, yeah, that was an excellent lecture and giving future insights. I would say, Madam mentioned about barcoded babies. Probably you are speaking of barcoded poo pills in future. So I request Dr. Gupte sir, Dr. Sanjay Patil sir, and President Dr. Varyani sir to join the felicitation of the speaker and the chairpersons to join. I request Gupte sir to felicitate the chairpersons. Padma Iyer Madam, she is trustee IMA Pune. Dr. Alka Shirsagar Madam, treasurer IMA Pune. Dr. Vaijayanti Patwardhan Madam, managing committee member and past president IMA Pune. We thank all the chairpersons for chairing this session.
Thank you, the chairpersons, for chairing the session. I take this opportunity on behalf of IMA Pune, from bottom of our heart. We wish to thank Dr. Sanjay Gupte sir and Dr. Asmita Gupte madam for this wonderful CME and oration. IMA Pune wishes to thank you, and I request Dr. Sanjay Gupte sir. Sanjay Gupte sir, please come on to the dais. I request President Raju Varyani sir, Dr. Sanjay Patil sir, Dr. Navarange sir, and Dr. Meenakshi Deshpande madam to come on to the dais. We wish to felicitate Gupte sir. Madam, will you be okay? We all of you, we request you all to come down and felicitate madam.
I request Dr. Aarti, please join Dr. Surgeon. Moving on to the next session, we have a lecture by Dr. Seema Gaikwad on earliest and fastest detection of infectious diseases. For this, I would like to invite the chairpersons, Dr. Raju Varyani sir and Dr. Sanjeev Khud, an eminent gynecologist, to chair the session.
We also wish to thank the whole team of Dr. Gupte Hospital and especially Mr. Nitin Gupte sir, Mr. Avinash Joshi sir. Please, are they here? Okay, just खाली गेलेत का? नाही, काय असतं, काम करणारे लोक पुढे येतच नाही, ती नेहमी मागूनच असतात. सो मेनी टाइम्स बोथ ऑफ देम केम टू IMA फॉर मीटिंग्स, सो मच वी डिस्कस्ड, आणि या सगळ्यातून इतका सुंदर प्रोग्राम आज आपला झाला. त्या सगळ्यांचे खूप खूप धन्यवाद आहेत. कुठे आहेत? ओके ओके सर. सर, थँक्यू व्हेरी मच. Over to you, the chairpersons for the session.
Hello, yeah. Good afternoon, everyone. It's indeed a pleasure to be a part of this wonderful program. And my sincere thanks to Dr. Sanjay, Madam, and my friend Raju and the whole team. I must thank Sanjay for giving me this opportunity, because this has given me an opportunity to meet Madam, the one who gave a fabulous oration. And secondly, Madam taught me how the baby delivers. Baby pelvis June, she is the first one when we were residents, junior residents, to have learned the first lessons of obstetrics from you. And Sanjay is the one who taught me hypertonic, hypertonic saline घेऊन abortions केली जायची. So the first lessons actually were learned from them. And so I must thank them for giving me this opportunity to chair this wonderful session. So may I request Raju to introduce our first speaker.
We have next talk by Dr. Seema Gaikwad Madam. She will be talking on earliest and fastest detection of infectious disease. Dr. Seema Gaikwad has done MBBS from Government Medical College, Miraj in 2010. She has done post-graduation MD Microbiology and DNB Microbiology. Over to you, Dr. Seema Gaikwad, Madam.
Thank you. Thank you so much, sir. Thank you, IMA, for giving me this opportunity. We shall now discuss earliest and fastest detection of infectious disease. So infectious disease, as we all know, is an emerging branch, and CDC has dedicated its one unit to infectious diseases, which is called the National Center of Emerging and Zoonotic Infectious Diseases, that is NCEZID. So CDC defines infectious disease not only as the illness that is caused by germs like bacteria, viruses, parasite, fungi, which multiply in the body and then can cause infection, but some germs which need carrier to spread, like food, water, air, by vectors, out of which some of them are emerging, which we have never seen before. These are newly diagnosed, which were completely gone and have come up to a new area. Some which were previously there in that area, now they have vanished and now they have coming to some new areas. So there are different emerging and re-emerging infections, as we call them. And some of them are zoonotic, which are spread from animals to humans, like Lyme's, rabies and all. So all this entire classification is given by CDC as far as infectious diseases goes. So when you talk about any disease, for that matter, a diagnostic cycle comes into picture. When you say diagnostic cycle, there is a pre-analytical phase, analytical, and post-analytical phase. So when you talk about pre-analytical phase, it is when the patient goes to a physician or clinician, the physician examines and a test is prescribed. Some investigations are advised to the patient, and the patient is going to the laboratory to get those tests done. So this phase from where the patient goes to the physicians, gets examined, and the test is advised is the pre-analytical phase. And when the sample reaches the laboratory to the report is generated is the analytical phase. And after that, the treatment is started, and we call it as a post-analytical phase. So we'll focus on the analytical phase. For any infectious diseases, we have the basic, like we have always been discussing about microscopy, we have cultures, we have biochemical identifications. Now that we were doing manual, some have automations have come up, and there are serological tests wherein we detect the antibody antigen titers, and then we have come up with molecular analysis. So allow me to say that molecular diagnosis is the future. So when I say that, I want you all to ponder over this fact that before early in 2000s, PCR came into picture. We were taught to advise PCR as a very glamorous test, like some of the viruses, infections, like some parasites, some fungi, still have PCR as gold standards for them, for detection of their core antigens or something like that. So when you see PCR or molecular diagnostic, it has always been so glamorous, so expensive. These tests were never done in our near neighborby laboratories. They were always been shipped to, metro cities or some reference laboratories where you would get those tests done at some humongous cost. You have to pay, like from thousands and thousands and thousands bucks you have to pay. But just when it seemed so impossible to think about molecular diagnostic, COVID happened, pandemic happened, and you know how molecular diagnostic has moved. It was within time of days and hours we would get results. Very, very, very rural and remote areas got their VDRL labs were set up where they did their PCR. Samples were picked up from homes. People were quarantined and the samples were picked up from their home. Within hours and times of days, the reports were available. Patient would be quarantined, treatments would have been started, steroids, and patients' lives were saved. That is what molecular diagnosis has done. And this has been only realized, only happened after COVID. We have come to know this fact that yes, it can be done. Yes, it can be done in a cost-effective way. Yes, it can be done in a timely manner. Yes, it doesn't have to have a fancy name or a fancy laboratory. Yes, we can do it with our present laboratories also. So when you talk about molecular diagnosis, what it is about, it is just to address or to target the nucleic acid, the protein or the antigen which is responsible for causing that infection. You extract the nucleic acid out of it, you amplify into a detectable level, and you detect those. So when you amplify them, you do a polymerase chain reaction, that the small amount of antigen is attached to peptides and polypeptides, and the bond is formed, and you get a long chain of polymerase chain reaction. The product which is formed after doing a PCR can be detected by various ways. You can just detect it visually by doing a gel electrophoresis. It can be done by fluorescent or direct visualization, sequencing, and when you do a polymerase chain reaction and at the same time you visualize it, it is called as real-time PCR. And real-time PCRs, or PCRs for that matter, has been an integrated and high throughput technology right now. It is also in some cases been proved as point of care. So when we talk about infectious diseases, when we talk about molecular diagnosis, and when we talk about earliest and fastest detection of infectious diseases, what can be better than discussing tuberculosis, right? So I'm just going to give you a few numbers. I know nobody here needs any introduction to tuberculosis because we live in the world capital of tuberculosis. 28% cases are today, the world's 28% cases we have in India right now. We are among the 8 top countries loaded with tuberculosis. Every 3 minutes, 2 patients die of tuberculosis. So you just imagine by the time we finish our talk, what tuberculosis has done to us. So how about prevalence? So when I praised so much the pandemic, like pandemic has given molecular a different era, we have come to know that yes, molecular diagnosis can be point of care, it can be easy, it can be approachable and things like that. But uh, the fact we cannot deny is that by 2019, right from 2014 to 2019, we have come long way in diagnosing, detecting, and managing tuberculosis. But this entire goal of tuberculosis management, or eliminating tuberculosis, was derailed during those 2 years of pandemic. Our goals were completely derailed. Our figures have been shattering. The prevalences have gone above, like 19% more tuberculosis cases have been reported by 2021, and God knows what's going to happen in 2025. But still, we have a goal of ending tuberculosis by 2025, while WHO gives the same goal to end tuberculosis by 2030 to the world. But India needs to be ahead of time, and we have to end tuberculosis by 2025 if we say that we are capital of tuberculosis. So is it really doable? Can we do that? We'll see. So this is again those figures which are really disturbing. 10.6 million people fell ill in with tuberculosis in 21. 1.6 million died. Every year, 10 million people fall ill with tuberculosis, no matter which year or which era we are talking about. And 5 million people die each year of TB. So TB being the most dangerous killer of infectious disease right now. So it definitely deserves your time, right? It definitely deserves to be discussed right now in this platform. And this is our own Honorable Prime Minister, Narendra Modi ji. He has been inaugurating the Free TB India campaign in February 2023. So yes, we all are moving towards the same goal. So when it comes to diagnosis of TB, we all have read in our microbiology books and the same old age techniques we all know, but there are some modifications here and there, not much. Smear microscopy, we were doing the ZN stain, now WHO has endorsed fluorescence microscopy. Culture techniques, we were told to culture them on LJ medias, and now we have the liquid cultures, trade name being MGIT. Molecular methods, we have come up with many molecular methods. Famously, we know about the CB-NAS, which is also called as Gene Expert, and line probe assay, and sequencing is the upcoming thing. Then there are tests for latent tuberculosis like IGRA and TST, which have been only used for diagnosis of tuberculosis, and WHO or Government of India has banned them for diagnosing tuberculosis per se. The active tuberculosis cannot be diagnosed using these tests. And then there are some other serological tests like the LAMS and ADA, which have been old age, and we know how to use them. So again, these are few tests: microscopy, cultures, the phenotypic and drug sensitivity, and again a platter of molecular tests. So every now and then, every year round the clock, there are tests, there are companies which come with various platforms, various principles, and they design many such tests so that tuberculosis diagnosis done in a rapid and earliest way. They claim to do so. So WHO, what they have done is they endorse few tests, few molecular tests, or few such tests which are WHO endorsed, which you can rely on. The sensitivity and specificity of those tests are studied over worldwide data. And few of those tests which were endorsed, like in 2007, automated culture, liquid culture was endorsed by WHO. 2008, first line LPA. 2010, expert was endorsed. And 2015, urine and TB lamp was endorsed. 2016, first line LPA was endorsed. And in 2019, we had the TrueNat, which is our own Indian gene expert, like the TrueNat, which is chip-based, which was designed and was a made in India product. So this is the diagnostic algorithm of TB. I am sure everybody knows, but just think about how times have been changed. We remember, memorizing those algorithms wherein we were asked to take 3 sputum samples, consecutive 3 days, do a smear microscopy, do a X-ray. We have totally shifted to CB-NAT. Totally shifted to molecular diagnosis, be it presumptive or be it all the diagnosed case, be the previously treated close contacts of DRTB, PLHIV patients, or the pediatric age groups. Everybody, the first test for the diagnosis is a CB-NAT, which is commonly called as the Gene Expert. It is a molecular test. It is a semi-nested PCR. Again, if you are subjecting a sample to gene expert, it will either give you a rifampicin resistant result or a sensitive result. Again, if it is resistant, we can go down and see the second test which is advised by the RNTCP or now the NTEP is the second line LPA. Again, reverse hybridization PCR for letting you know whether the fluoroquinolones and second line injectables are resistant or sensitive. So yes, not only has there been a modification of various tests and various principles and various platforms, but also national programs are integrating all these platforms into our algorithm so that it is available everywhere and it is available as a point of care. So to convince you more on what I'm trying to say, let's just go back to this case. This was a 43-year-old staff nurse. She worked in the same hospital where she was diagnosed and treated. It was a private hospital in Pune. She was presented with backache, radiating to both lower limbs for 3 months. She had a significant weight loss of 3 kgs. There was no cough and no fever. Okay, so MRI was done. There was D12L1 disc erosion, edema, and soft tissue involvement was seen, and the MRI report suggestive of TB spondylitis. A CT-guided biopsy was done, and sample was subjected to gene expert. So when, of course, gene expert, when first you do it is an MDR. So MDR TB was detected in low levels, and rifampicin sensitive resistance was found. Then the clinician was very worried whether we are dealing here with XDR or just an MDR. So he asked to subject us the sample to gene expert XDR. In gene expert XDR, it was surprisingly found to be sensitive to INH, ethambutol, fluoroquinolones, and second line injectables. So any idea what we are dealing here with? By definition, if MDR, you have to call a patient, MDR by definition, you have to have rifampicin and INH resistance both at the same time. But here gene expert has only said it as only rifampicin resistant, while INH was found to be sensitive on XDR gene expert. So yeah, just to give you a brief idea, gene expert, there are MDR and XDR gene expert, XDR being a newer version of gene expert. Previously, this was the model of their gene expert wherein only MDR was done. It is a very simple method wherein the sample and the buffer, you can see a small bottle, those two are mixed and put it in the cartridge, which is this blue colored cartridge, and that cartridge is loaded into the machine. For 52 minutes to be precise is the runtime, everything calculated right from the sample processing. 2 hours max to max, you will receive a result. And this is a semi-nested PCR, everything happens inside the cartridge, no need of any biosafety 3-level preparations or no well-trained staff required. Just you put up the sample inside the cartridge and the machine takes care of the rest. And then there is something called, they came up with Gene Expert Ultra. So what was so fascinating about Ultra is that earlier when Gene Expert MDR was designed, they came up with CT values. We all are very aware about CT values, the cycle thresholds. The difference in the cycle thresholds of the probes which they put up were measured, and difference, if there was a significant difference, it was called as rifampicin resistant. If there was no significant difference, it was called as rifampicin sensitive. But there was some probes which failed to pass and were invalid results. So they came up with a new technology of Gene Expert Ultra, wherein the entire PCR happens, the double-stranded DNA is synthesized, and it is broken down to do a melt curve analysis. So melt curve analysis, if you have a normal TB genome which has been degraded, you will get the melt curve analysis at certain given temperature. If there are mutants involved, it will break down at an earlier temperature. So the Tmax is lower. So that is how we come up to a conclusion. Yes, we have rifampicin resistance or mixed population accordingly. Then they came up with Gene Expert XDR, wherein all the second lines like fluoroquinolones, injectables like amikacin, kanamycin, capreomycin, ethionamide, all those were diagnosed, all those reports were given to us, and not just detected, not detected. They also told us whether the resistance was low level or high level. And there is something that is called indeterminate also came. So there was a lot of confusion again. Then we, so yeah, so MDR, be it MDR, be it XDR, or be it gene expert, the advantages is you get the results in 2 hours. You get to know if it is rifampicin resistance along with tuberculosis. The sensitivity and specificity are quite good. It is superior. It has known to be showing superior performance in patients with PLHIV, and the biosafety and training precautions are really minimum. Two disadvantages. Coming to disadvantages, culture and DST you cannot give up. No, you are not allowed. Since you are a national program, you cannot give away with culture and DST any point of time. Blood, stool and urine samples are not recommended. Possibacillary, like the pericardial fluids, synovial fluids or pleural fluids tend to have low bacillary load, so they have claimed to have low sensitivity. INH monoresistance is missed. Rifampicin heteroresistance discrepancy results have been seen, and patient not at risk of drug resistance have tested positive, and then in that case you are asked to repeat the gene expert. So coming to the second test we discussed in the algorithm was the LPA, the line probe assay, trade name being Enolipa. So it is, again, you have to extract the DNA, you do amplification, a PCR product is generated, a double stranded DNA you get, you have to break that DNA and put it into put it on reverse hybridization. It is copied on a strip, and the strip is read in this way. They have their own controls and everything, but this test has a disadvantage. There are lots and lots of cross contamination. So even if you see the controls, that is the conjugate control or the amplification control or M tuberculosis control, once you get all these controls, then only your test is considered to be positive. But it was seen that there are lots and lots of false positive cases due to cross contamination happening with LPA. So again, coming to the advantages and disadvantages, yes, rapid detection of rifampicin, you get to know whether your patient is MDR or not. In less than 48 hours, you get those results. You don't have to wait for cultures and DST, and 48 samples. So a huge throughput for 48 samples at a time you can test. Again, disadvantage, you cannot get away with cultures and DST. Since LPA detection is more than 10 to the power 5 CFU per ml, like you have to have 10 to the power 5 colony forming units in your sample if you want to if you have to detect it by LPA. So only smear positive cases are subjected to LPA, not the smear negative ones, because they believe that it is less in colony count. There were no specified guidelines for the second line injectable drugs, and yes, it requires trained people and expertise to read as well as perform those tests. So coming to sequencing, so all these tests we have in our market, we use day in, day out. We have the advantages, we have the disadvantages with us. So let's see what is upcoming. Upcoming is sequencing. So sequencing is what we are going to study the entire genome. We have known during COVID that in less than 2 years, like we had a pandemic for 2.5 years, less than 2 years span of time, the virus came, it infected, it caused a pandemic, it caused lockdown. But being such smart humans, we have been able to find out the entire genome. We were able to develop a vaccine against it, and yes, now we have overcome that pandemic. So that is the power of sequencing. Sequencing can give you the entire genomic type of that organism, the strain, the lineage, the evolution that has come up with. So sequencing can be done from sputum sample, or it can be done from the culture DST. When you do it from a liquid culture, it takes less times, because liquid cultures gives you better positivity. So it can be done in 8 to 14 days after your liquid cultures are positive. It can be done from the solid cultures, which take more time, like 6 to 8 weeks. And then it can be directly done from the sputum sample as well. We'll see how. So when you talk about whole genome sequencing, it is a very fascinating process. It is very expensive. It is a very robust thing to do. But to simplify it to you, you are going to extract the DNA from your sample or the culture if you have. Whole genome sequencing only allows you to use the cultures, not the samples. So you take the DNA extraction out of those sample of those liquid cultures or solid cultures. structures, and you make a double strand out of it. And then there are sequences made. So these sequences are put up in your central storage. Like there is a genome of TB, which we all know that the TB genome has been designed. And just like a jigsaw puzzle, all these short sequences are placed here and there. And once the jigsaw puzzle is solved, you get a report and you can see which codon or which particular base pair is missing, what mutation it confers to. And the good news is, not just is the technology advancing, WHO is endorsing, and it has come up with a catalog of various mutations, various codons which have been replaced and causing mutations. And what does it indicate? When you replace certain codon, what is it going to implicate? How is it going to change your treatment protocol? So recently, version 1 of this document or catalog of these mutations have come up on WHO website, and soon they will be giving version 2 as well. So WHO is advancing also to sequencing, and you should not be surprised to see sequencing done here and there, and WHO endorsing this test. So yeah, again, the specimen, there is a bacterial culture, same, the genomic DNA is extracted, sequencing library is made, and the it is matched up to the raw sequences we have. Okay, so then there comes first and second next generation sequencer. First generation, it's just that it is essentially a automated electrophoresis. The visualization of the sequencing is different, while in next generation it is rapid. It is with the help of bioinformatics, and it is a low throughput, high cost thing. Again, the disadvantages or advantages. Advantages, it is high resolution. It allows you to know the exact type, the exact lineage, the genomic makeup of your patient's strain. What strain is your patient infected with? You need not to go and, you study, no, it is rifampicin resistant, let us avoid rifampicin. You will be getting the entire genomic, which codon is replaced, what does it mean, everything you can get in a whole genomic sequences. You can predict drug resistance TBs if you see one codon missing, and if you see that it is low level resistance, might as well you give a higher dose or skip that drug. Okay, so you can predict drug resistance TB, and it will help you guide the patient treatment. TB, the biggest problem with TB is the adverse drug reaction. Patient gets himself treated for 2 to 3 months. There are some adverse drug reactions. We find out that the patient is resistant to so and so drug, and now we have to change. So adverse drug reaction does a lot of damage. So we can, if we can foresee all this, we can be thorough about what empirical or treatment we have to start on our patients on. We can totally overcome the limitations of molecular tests like GeneXpert and LPA, because GeneXpert targets the RPOB gene, which is responsible for rifampicin resistance, and LPA, if it is first line, it will again target the RPO gene. If it is second line, it will target the gyrase and ethambutol genes, which are responsible for second line drug resistance. Disadvantages, yes, it is very expensive, it is labor intensive, it is financially demanding, it will mostly rely on the central data. So you will have to have always an access to the central data. You will have to give your sequences to them, and you will have to wait for the report format from them to come. That is what it is called. The bioinformatics is very challenging. There are ethical concerns. There are technical complexes. There are papers and case reports wherein discordance have been seen, because the genotypic tests which we have been doing right till now, like LPA and GeneXpert, give you only idea of few genome sequences or only few area of that entire genome. So there is going to be discrepancy when you treat your patient based on GeneXpert or LPA, and then a whole genome sequence report comes. Sometimes you might find discrepancies. Then there is something called as target sequencing. Target sequencing only gives you the advantage that you can directly do it from your sputum sample. You take a sputum sample, subject it to DNA extraction, and you can perform sequencing based on that. Here, when you give sequences in whole genome sequencing, just 2 minutes, whole genome sequencing, you will be having sequences, only few different sequences, while target, you have specific targets for target sequencing. Again, the advantages and disadvantages: full genome sequenced in whole genome, and targeted, few targets are done. Only advantage here for targeted is you can directly do it from the sample, so you cut down the time of culture which takes for liquid or solid cultures. Disadvantages: WGS requires a lot of complicated bioinformatics and a relatively simpler in targeted. So coming back to our case, so this patient was diagnosed with rifampicin monoresistance. A high dose rifampicin and HZE treatment was done. Clinical, but 45 days down the line of treatment, clinical and radiological worsening was seen. But when they sequenced, they found out this F511CCG mutation, which correspond to rifampicin resistance, which only means that this clinical and radiological worsening was a part of IRIS syndrome, but nothing else, and the patient has improved with no relapse. Again, the same patient with PTB, expert rifampicin resistant, LPS showed INA mutations, WGS confirmed that INS high level mutations, and the patient was started with 18-month regime. So yes, we need to come up with combination of TB screening and diagnosis. No one test can solve your problem. We need to decentralize this. We need to have more point of care tests, and promising thing is the molecular diagnostic. And we have many other tests available at our Greenarray lab: influenza panel, TB respiratory panel, TB PCR, HIV, HPV, and STD panel. All these tests are, along with those platforms, are soon going to get enable accredited. The lab is centrally located. We have a very cost-effective platforms here, and you can send in those tests. All those tests will be done in external and internal quality proof areas and enable accredited labs. So yeah, please send all the samples to Greenarray lab, and thank you.
Thank you, Dr. Seema.
Thank you, sir.
I think it was a wonderful, comprehensive talk.
Thank you, sir.
Now, being a gynecologist,
yes, sir.
For the physician, it's easy. But
Yes,
for a
sir.
gynecologist, diagnosis of genital TB is the treatment is very simple.
True.
The challenge is the diagnosis.
True.
And probably from your talk, what I can
Yes.
see, well, there is a light at the end of the tunnel.
Yes.
Through molecular diagnosis.
Yes, sir.
So thank you.
Thank you so much.
Any questions?
Cost of CBNet for MDR is 2,500 roughly. For XDR, it goes from range of 4 to 5,000. But just because, ma'am, you asked, we haven't figured out the cost of WGS in Greenarray. But for competitive marketing price, if I have to tell you, WGS comes with a cost of just 6,000 rupees. So it is cost effective as well.
But I'm sure it would get cheaper as more and more samples
Yes,
will be there. And
yes,
probably that's
yes.
the future actually.
Yes, definitely.
So thank you very much.
Thank you, Dr. Seema Gaikwad, for your talk. I request Dr. Raju Varyani sir, Dr. Khurd sir to join for the facilitation, Dr. K.H.Sancheti sir, President-elect, and Dr. Gupte sir, Dr. Navarange sir to join for the felicitation. Before the last lecture, I would like to inform that the feedback forms would be distributed. We need the feedback forms filled in for the MMC points to be uploaded and credited in your account. So for the next lecture, I would like to invite Mrs. Manju Kurup for her lecture on role of genetic counseling in clinical practice.
Well, although this is the last talk of the day, well, as a clinician, I feel this is the most important talk. See, because the thing is, when you are young, you are constantly doing many things. But when you mature, you understand where not to do. and then what to do, what not to do, when to do. See, then that part of counseling is very, very important. And here we have in Dr. Manju Kurup, who is going to tell us the role of genetic counseling. Well, as it is, genetic counseling is a rare specialty. There are many counselors, but genetic counseling, there are very few. And madam, we are really looking forward to your talk. Now, she is a MSc in biomedical genetics from Vellore, more than 6 years of experience as a genetic counselor, and has had many contributions to the field. So without any much ado, we would go ahead to your talk. Now, as a clinician, there are two dilemmas which I normally face. Number one, see now with so many labs coming in, patients come with a lot of reports.
Sure, sir.
And then there is one remark of undetermined significance.
Variant of uncertain significance.
Yes, and as a clinician, I really do not know what to do or how to, what to tell the patient about the future. Another important thing when it comes to counseling, see, when we have cases of repeated miscarriages, say 3 miscarriages. Now, on one side, our textbooks and our personal experience also says that the patient has 70-80% chance of going ahead with a normal baby in spite of 3 repeated losses. Now, but on the other side, when the patient has a report, and then finally at one stage it leads to IVF and pre-implantation genetic diagnosis, where the cost is about 3 lakhs of rupees. So I am in a dilemma whether to tell her no, keep trying once, or to go ahead with this. So please, we look forward to your answers.
Sure, sir. I'll just try to cover all your queries in the presentation. So beginning with the presentation, what is genetic counseling? So American Society of Human Genetics defines genetic counseling as a communication process that deals with a special health service that provides information and support to the people who have or may be at risk of genetic disorder in a family. So genetic counseling is a skill-based communication process that employs scientific knowledge regarding principles of human genetics, genomics, psychological aspects of genetic disease, and communication expertise to support individuals and their families to understand and cope with genetic diagnosis. So like sir mentioned, there are n number of genetic tests that are available. So like different genetic tests have different principles, they have different purposes. Like for karyotyping, if we want to see if any major chunk of DNA is missing or if there is any numerical abnormality, we go for a karyotyping. And FISH analysis, if we are looking for some specific chromosomal aberrations. And chromosomal microarray analysis, like we had discussed previous in the sessions, if any microdeletions or duplications that could not be found out by a karyotyping or a FISH analysis, we go for a microarray analysis, which is of a higher resolution. And a single gene sequencing when we want to focus on a particular gene which is associated with a particular condition. And a panel testing where more than one gene is associated in causing a condition. Exome analysis when there are multiple conditions running in the family and we are not able to exactly pinpoint if we have to go for a panel testing or a gene analysis specific, we go for an exome analysis. And also if we have to see a exonic as well as the intronic region, that is a coding and a non-coding region, we go for a genome analysis. And epigenetic analysis like we had previously seen in doctor's lecture. So it is certain genes that are expressed the way it is expressed. So for all these genetic testing, the application can be of various types. It can be for diagnostics testing, pre-symptomatic or predictive testing, carrier testing, for pharmacogenomics, prenatal testing. It can be for newborn screening or pre-implantation genetic testing. So surely genetic testing is complicated, but invaluable in medical diagnosis and determining treatment for many diseases and conditions. So as per National Society of Genetic Counseling, there are more than 40,000 different tests available and more than 10,000 conditions, genetic conditions that have been enlisted and more than 16,000 genes that have been identified. Now, sir, your question arises like which test to give for which patient. So deciding which genetic test to offer and to whom can be a complex process that involves careful consideration of various factors. So which can be the unique characterization of a condition, that is a genetic condition, its features, its clinical representation, the circumstances of each individual, continuous communication, like for getting the detailed family history as much as possible from the patient, and it should be patient-centered approach are essential in the process of deciding which genetic test to offer. So this is when genetic counseling actually comes into picture. So genetic counseling could be included in clinical practice by trained candidates who can assist clinical practitioners in this time-consuming procedure to ease their work in their hectic schedule. So what exactly genetic counseling focuses on? It actually focuses on the psychological aspects and taking the family history, the onset of a specific condition in the family, what is the age of onset, and to see what all genetic history is there in that family, and to provide support and additional information about all the genetic tests and options that are available that is particular for that patient, and also interpretation of the result, where it can be a pathogenic variant, what it signifies, a benign variant, what it signifies, and like a variant of uncertain significance. And also detecting the type of inheritance pattern by a proper pedigree analysis. And also if we are getting a positive result for a patient, how that information is beneficial not only for that patient, but also for the additional family members. So these are the major aspects that genetic counseling looks into. So how did it all start? Like in 1947, Professor Reed Sheldon, he was the one who coined the term genetic counseling in USA. And he wrote the first book in genetic counseling, Counseling in Medical Genetics, in 1956. And 1981 was the era where genetic counseling was actually identified as a separate profession, when Professor Peter Harper, he wrote the Practical Genetic Counseling book. So the main aim behind this was to prevent or minimize the recurrence of serious disorders presumed to be completely or partially genetically influenced. So what are the main genetic counseling goal in clinical practice? To increase the family's understanding of a genetic condition, discuss options regarding disease management and the risk that benefit of further testing and other options. Like, sir, you had a query like when we can suggest for a testing. So it actually depends on what exactly is the family history, what is the patient's personal history, and what all testing it is already been done and what was the finding. So basis that we can provide options to the patient, and it is upon the patient that which test is feasible for that patient and what would be the outcome. So at least in our Indian scenario, it is like not the patient who decides what is supposed to be done. It is always a family. They sit together on a dinner table and they have a discussion like what exactly has to be done for the female exactly. So help the individual and the family to cope with potential outcome and reduce the family's anxiety regarding the genetic testing, the cost and everything. So who can be referred for a genetic counseling? So it is, if there is a family history of a genetic condition, it might be known, or if any genetic condition is suspected in the family, or if a patient is a carrier for a certain condition and they want to know if there is a risk for their next generation to develop the condition, and if there is a consanguineous marriage in the family, if a fetal structural anomaly or prenatal ultrasound abnormality is observed, abnormal screening test result, either traditional serum screening or cell-free DNA screening, known teratogenic exposure during pregnancy, recurrent pregnancy loss, and if a patient proactively is well read and wants to know if he is a potential carrier for any genetic mutation that can lead to a predisposition in the next generation or even the other family members, he can also opt for a genetic testing only if there is a proper family history, or if certain condition that doesn't require, and directly he can go for a carrier testing. So what is the most important component of genetic counseling is the pre-test counseling. This is a session where patient has an opportunity to facilitate the informed decision making after knowing all the positive and the negative points, like the limitations of genetic testing he is going to opt for. So here, informed consent is the major aspect of pre-test counseling, which is received by the patient after the patient is informed about why he is being offered the genetic testing and what is the accuracy of the genetic testing and what are the available options, alternate options for that genetic testing, and what does the positive result or the negative result or the uncertain result signifies. After the patient is informed about all these information, and if he is convinced and no other additional doubts is there for that patient, he can provide an informed consent, which is helpful for us to proceed with the testing. So it is very essential to provide all the information during the pre-test counseling, because inadequate pre-test counseling can adversely affect the patient's understanding of genetic testing process as well as the accuracy of the test. And the next component of genetic counseling is the post-test counseling, which is an informative discussion that involves educating patient and their families about the occurrence or recurrence of the genetic disorder in the family. So it is very true that if the pre-test counseling is very informative and all the information has been shared to the patient in the pre-test counseling session, the post-test counseling becomes easier. By providing clear information, addressing concerns, establishing open communication, pre-test counseling creates a foundation that supports individual through the entire testing and the counseling journey. So what are the applications of genetic counseling? It can be applied in prenatal setting, pediatric, adult genetic counseling, or cancer genetic counseling. So prenatal genetic counseling, as the name suggests, during pregnancy, if there is any previous history of any genetic condition in the family, or the previous baby is affected with some genetic condition, or if there is any abnormal ultrasound reports or biomarker reports, or if there is a history of infertility, multiple miscarriage, or stillbirth, even in the family, or the patient herself has the history. So what is pediatric genetic counseling? Is caring for the children. If the child is showing any signs and symptoms for any genetic condition, which could be a congenital defect, abnormal newborn screening result, intellectual disability or developmental disabilities, or autism-like disorders, vision or hearing problems. So genetic counseling for adults, it can be provided in case of any history of cardiovascular condition, psychiatric condition, cancer genetic counseling, if there is an early onset of cancer in the family, or if multiple generations are affected with some certain cancers, or if the patient is closely related to the person counselee who wants to do the genetic testing. So also in case of conditions like familial hypercholesterolemia and similar conditions, muscular dystrophy and other muscle diseases, inherited blood disorders such as sickle cell disease. So what are the types of genetic counseling? It can be prospective, which allows the prevention of the disease if no genetic condition is detected in the family, but as discussed earlier, if the patient wants to proactively go for a carrier testing, that is known as a prospective genetic counseling. Retrospective genetic counseling, which is hereditary disorder has already occurred in the family and the counselee wants to know if he is predisposed for that certain conditions like mental retardation, inborn error of metabolism, or for psychiatric conditions. So the steps of genetic counseling, the major part is the history. So patient's past clinical history, the present history, and if there is any family history of any related conditions, if this is a consanguineous marriage, if anybody is affected with some congenital anomaly, taking all those history is very important. It is very truly said that the family's future starts with the family history. So the next very important part is the pedigree charting. So constructing a pedigree with proper interrogation through time is time consuming, but it is ultimately rewarding because it is a pictorial representation which helps us to know how many members are affected in the family and what is the onset of the condition and what could be the possible risk for the next generation or the siblings to be affected by that condition. And it is the way where we can detect what is the inheritance pattern of the genetic condition. So estimation of risk, mode of inheritance, pedigree analysis, the result of other tests, these are all the way that we can make an estimation of risk for the other family members as well as the next generation for the counseling. So diagnosis and analysis phase. So in certain cases where there is a rare congenital disorder or multiple anomalies are detected in a baby, so in certain cases we have to go for an extensive literature search and review of information, and we need to consult expertise also who have been working in that field to know what exactly the test can be referred for the patient. That is, the chromosomal analysis test is perfect for that condition, or going for a genetic analysis means molecular DNA analysis is perfect. Like chromosomal, we have karyotyping or microarray, and molecular DNA testing where we can go for a single gene or multiple gene. So this is one extremely important part, which is again time consuming for counselors, because they have to collect all the information before they actually go and counsel the patient. And this is the most important part, exchange of information like discussed before. They should know all the benefits and limitations of doing the genetic testing, what implies the positive genetic, if the result is positive, what it implies to him, himself or the family members. It is very essential for him to know that. And assess the counselor's understanding of the fact and relevant hereditary pattern, diagnostic and management option for the disorders. So this is the referral and the support phase. At times, the counselees are interested to connect with other families or other NGOs that specifically work for that condition, like for thalassemia or sickle disease, so that they can know if their baby is affected, what is their experience and how to cope up with that situation. For example, Down syndrome conditions. So in that cases, they do ask for referral where they can talk and get more information. So that is also included in the role of a genetic counselor. And support can be provided in case the patient is emotionally down. In that case, if a genetic disorder, the cure is unknown, he can be connected with a clinical geneticist for management plan that can be provided appropriately. And also, if one counseling session is not enough for the patient to understand, multiple counseling sessions can be provided for that patient as a part of support phase. So what are the code of ethics by National Society of Genetic Counseling that a counselor has to follow? So summarizing it, it is most important part is it should be a non-directive counseling. Like Dr. Phadke madam had also said that this is the most important part for a counseling session. We counselors should never be a part of what decision the patient has to make. It should be, the patient should be completely empowered with all the genetic information, the benefits and the delimits, everything, so that the patient can make an informed decision for himself and the other family members. But it should be completely his decision. And also we should respect the patient's decision, and we should support throughout the genetic counseling procedure, testing procedure. And the whole aim should be the benefit of the patient and doing good for the patient, and no negligence with patient's health. And it should be a non-biased counseling session, because it should be not that in case of RPL, we are just supporting the female candidate or the male candidate. It should be unbiased. We are just there, counselors are there to provide them with the required information they are supposed to know for their health and genetic aspects. So these are just basic general scenario. Like if a couple in their 30s, they have a 6-year-old son, wife's mother passed away due to breast cancer at the age of 40, which is an early onset, and she has a family history of heart disease as well. The concerned couple opted for genetic counseling to see what is their risk, what is the wife's risk and the next generation risk. So certainly in this case, the procedure is the same. First should be the risk assessment, and while taking the family history, the pedigree should be drawn in such a way taking into account the cancer history as well as the cardiac condition that is there in the family, the age of onset, the condition that was diagnosed, and also providing with all the available options for him or her for testing and informed decision making help, and understand the genetic risk factors that could be passed on to the future children, and explore the other options and emotional support and health management options. And also education and advocacy, which is an important part, because At times, patients, if they are detected positive, they are very secretive. They don't share it with the other family members. He should be, because at last it is his or her decision if he has to share with the family members. But as counselors, it is our responsibility that we are supposed to inform them what is the health benefit they are going to know if they know that they are at the risk of developing the condition. So sharing that information is very essential, and we have to provide them with that information. So this is a second case scenario where a young couple who are planning to start a family, they are both carrier of thalassemia, although neither of them has the disease itself. They are unaware of the potential risk associated with having children. So initially, ideally in this case, the couple is supposed to have a genetic testing done, that is the HBB screening. If they both have the similar genetic mutation in them, so inheritance pattern, it is autosomal recessive, so the next generation will have a 25% risk of developing the condition. So in this case, a pre-implantation genetic diagnosis might be recommended, or going for a prenatal genetic testing, which is a single variant that is detected only in the family. So these are ideally the procedure that are supposed to be followed. So this example underscores the crucial role that genetic counselors play in ensuring the health and well-being of individuals and families at risk of genetic conditions. So this is the third case scenario where the ethical and the psychological issues are coming into picture. A 29 years old man presented for counseling with a concern that his fiancée had a family history of a rare eye disease. His fiancée is not affected, but her father has completely lost his vision in his early 40s, and his younger brother had blur vision since his 30s. So the consultant had presented for the counseling session alone without even getting his fiancé along with him. So here the ideally what is supposed to be done is the affected person, that is the index or the proband case, is supposed to be diagnosed, supposed to be referred for a genetic testing to see if it is what is the variant actually running in the family, to see if it is actually predisposed to, and also to see what is the risk for his fiancé to have that condition. But in this case, the consultant insisted on directly testing his fiancé for the genetic condition, and she was not present in the counseling session to understand the condition and also to give her informed consent. And here genetic counseling plays an important role. It is very important for the counselor to respect a patient's autonomy, non-maleficence and beneficency. So the counselor was convinced to get his fiancé first for the genetic counseling session to proceed in the ideal process for proper predisposition analysis. The benefit of getting the proband tested were discussed with the counselor. So in accordance with the ethics of genetic counseling, the job of genetic counselor is to offer unbiased information and assist in making well-informed decision. It is always advised that the genetic information only be given to the concerned individual, 18 years of age or older, or to parents, because it is a personal, sensitive and confidential information that could be occasionally be used inappropriately. So coming to the summary part, in India, genetic counseling has a great scope and demand in the upcoming years. Beginning from a basic karyotyping test for Down syndrome, we have come a long way ahead in genetic testing and counseling facilities. Genetic testing has evolved to encompass a broad spectrum of condition, offering insights in various aspects of individuals' health, including metabolic disorder, intellectual disabilities, etc. The landscape of genetic testing is dynamic, and ongoing research continually expands the list of conditions for which genetic testing is possible. There is still much to be done, and genetic counseling professionals can greatly contribute to the awareness and education of genetic science to the public at a large, considering the community genetic approach. Thank you. Sir, I think I did not address that variant of uncertain significance. So, sir, when we get a result of uncertain significance, initially what we are supposed to do is a clinical correlation, which is ideally done by a medical geneticist. So if there is a clinical correlation, then we can see there is what is the risk for the additional family members or the next generation. Or if the occurrence is spontaneous, we have to see if the parents are carrier for that condition. If no, that condition might have a variable penetrance. So that is one aspect that we can take into account. And if the parents are normal, then we can see it is a spontaneous occurrence and what are the chances for developing that spontaneous occurrence in the next pregnancy. So according to that, we can take a call what is the next suggestive approach for that patient.
Thank you. So now we know where to refer.
Yes, sir, sure.
Anyway, any questions?
सगळे निघालेत, पण फक्त एक सांगते की जाताना चहा घेऊन जायचा आहे, त्यामुळे सगळ्यांनी थांबा. हो नाही ते होऊ दे. थँक्यू मॅडम.
I request chairpersons, Dr. Gupte sir, Dr. Navarange sir, Dr. Sanjay Patil sir and Dr.Sancheti sir to join for the felicitation. I request Mr. Nitin Gupte sir and Mr. Avinash Joshi to join, followed by the chairperson's felicitation.
आणि सगळे निघालेत, पण सगळ्यांना एक आठवण करून देते की 15 ऑक्टोबरला इलेक्शन्स आहेत IMA मध्ये, सगळ्यांनी जरूर यायचंय.
I request Varyani sir to felicitate Mr. Nitin Gupte sir. Mr. Avinash Joshi.
आणि हा सगळा कार्यक्रम पॉसिबल झाला नवरंगे सर या.
As it is customary, I'll give this briefest Thanksgiving. Thank you all.